Even the Department of Microbiology was in the corner of the old building with stacks of old furniture lying outside. But now that I'm in practice, I realize that it's not the microbiology which was unimportant, but it was stupidity to think about it as such. When the diagnosing get tough and tough get going, the one who comes to our rescue is microbiological test. The test help us to reach to our goal and find the culprit of our child's problem. So without wasting any time, let's find the needle in the haystack, the microbiological test. I request Dr. Vijay Yevle to start the session.
At the outset, apologies for this postponement of the session, and thank you organizers for accommodating us. And I don't wish to spend time in introducing this learner panelists who are known all over the world. I must say so. And so here we are to discuss some microbiological tests that we use in our day-to-day practice and some which we do not use very often, and try to carry on some concrete messages. Finding a needle in haystack is the title of our panel discussion. The dictionary meaning is something that is impossible or extremely difficult to find, especially because the area you have to search is too large. And with respect to microbiological test, I'm sure with the experts, Dr. Camilla Rodriguez, Dr. Suhas Prabhu, Tanu Singhal and Sanjay Nathu, let us see how can make it possible and not so difficult, especially when we narrow down or define our area of search. So there could be two ways. One is use the conventional ways, that is blood culture, serology, etc. And then you have like what is shown in this cartoon. You can have that magnet or newer tests, molecular tests, which have come to our rescue many times to find the pathogen implicated in the underlying condition. So with this, what I propose to do is present before the panelists a few case scenarios and try and understand the utility and limitations of various tests that we carry out in day-to-day practice. So here we go. This is a 2-year-old girl who has some upper respiratory tract infection symptoms, and very often routine tests are advised in such cases. And this is the result of those tests. WBC is normal, neutrophilic count, and CRP is 12. Urine routine shows 8 pus cells per high paraffin. And the urine routine shows bacteria seen on gram stain. So my first question to our clinical microbiologist, Dr. Camilla, what do you infer out of this? Bacteria seen on gram stain.
First of all, this is a 2-year-old girl. She's possibly not continent. So she's
not.
Yeah. So my first worry is how the sample has been collected. And in a 2-year-old, you can have a clean catch, you can have a urine bag. Luckily for you, you have not done a culture. Because if a culture was done, I would trash it. Because you're going to grow some normal commensals. And unless you do a catheterized sample in and out, or you do a suprapubic aspirate, only then you would rely on your colony count. Any other culture, so because it seems so easy to do, people apply urine bags, but really the cultures are completely unreliable. So don't go that way. I think if you really want a good answer for if a few bacteria are seen, I would go for a catheter aspirate.
Okay, if I were to tell you that this was a clean catch and the sample was collected in the morning and sent to the laboratory sometimes late afternoon, how do you infer this bacteria on smear? Are they significant? Is there any significance?
Again, not. Because
okay.
Every bacteria takes 20 minutes to multiply. And if you've collected the sample in the morning and it's 6 hours, I've already got 10⁵ by the time it's reached me. Do the math. It's a geometric progression.
Okay.
So 1 becomes 2, 2 becomes 4 every 20 minutes. And then after about 3 hours, it's clearly 10⁵.
Okay, unfortunately, I'm looking at the urine showing 8 pus cells in a febrile child. Urine culture was asked for, and this is what it grew. E. coli, colony count significant 100,000 CFU per annum. Child is afebrile. By the time the report came, the child was afebrile. So Tanu, when do you ask for urine routine I mean, very often this is a common practice. You have febrile children having respiratory symptoms or symptoms which can be, assigned to some other system. And very often urine is asked and it shows pustule, CRP is borderline. How do you proceed?
Actually, this patient didn't need any investigations because you have already a localization of the fever. So no investigation should have been done. And these pus cells could be due to febrile pyuria also. So we should actually ask properly collected urine specimen, routine and culture only in a case of fever without focus. And that too after 48 hours, because many times the focus develops after 24 to 48 hours.
Yeah. So that's a very important message to carry home, that unless you have a child with fever without focus at the end of 48 hours, I mean, wait for it to localize to a system. And if not, then only ask for urine routine. Dr. Suhas Prabhu, how do you collect urine for culture? Because very often we just write our order that do urine culture and spend very little time counseling or
I think
advising
the
the
best
patients.
way of collecting culture, Dr. Kamila has already said, is a suprapubic tab, but you can't really do it for an outpatient. But if you have a patient in your ICU or hospitalized, that's the best thing to do. The second best is a catheter sample for an inpatient. For an outpatient, in a younger child, you need a clean catch. In an older child, you can do with a midstream catch. So the clean catch involves the fact that the child has to pass on command, which becomes a problem when it's a younger child. He's not going to pass on command. So there are various methods by which you can stimulate the child to pass urine. I think your New Bombay group has put up videos on how this is to be done. A child with a full stomach, maybe soon after he's fed, to be held up under his armpit, and you stroke on the back and you hold a clean container which is sterilized and collect the sample. That's your clean catch. But as Kamila said, you still need to worry about clean catch and a midstream sample. In the midstream sample, you first clean the genitalia, but don't use any antiseptic, don't use any violent measures. Otherwise, you can get some blood or something that can contaminate it. The first drops or first few ml of urine is discarded. The middle sample is collected and not the last. And again, the method of catching is the same. Of course, do not catch in an unclean container and pour it into a clean container. Do not collect it from the diaper. Do not collect it from the Macintosh. I mean, that's simple to understand.
And no bag sample as well. Urine bag
No,
sample.
no bag sample, of course. Kamila already said that.
Yeah. So we need to be a little careful and spend a little time in advising our patient how to collect
I think
urine.
we also need to mention that as to reach the lab
Absolutely.
in time. And if you cannot send it to the lab immediately, you probably need to refrigerate it so that your colony count will not go.
Absolutely, because our diagnosis is very much based on the colony count, and she mentioned the doubling time of this bacteria, and that we may end up in erroneous diagnosis. Okay, Sanjay, this is a 9-month-old boy, has fever with chills, has leukocytosis, which is neutrophilic CRP is 86, and urine shows packed filled pus cells. Blood culture is sterile, and the urine culture was sent, which comes as ESBL E. coli, obviously resistant to the third generation cephalosporins, but there is sensitive to piperacillin, tazobactam, meropenem, coamoxiclav, and nitrofurantoin. And this patient, after having sent samples, was started on injectable ceftriaxone. And by the time the culture came back, the child was afebrile. So what do you do in such situation? Do you change antibiotic?
So the patient obviously seems to be urinary tract infection, and ceftriaxone has been started and the child has responded. So probably I would not want to change the antibiotic because the culture may be not representing what is happening in the body actually. So the in vitro and in vivo effects may be different. So if the child has responded, I would probably continue the same antibiotic rather than change the antibiotic.
So is there an agreement amongst all the clinicians? Do we, Tanu, Dr. Suhas Prabhu, what do you do?
I would continue the
You
same
would continue the same
because
antibiotic.
yes, see, you are now seeing a discrepancy between in vivo sensitivity and in vitro sensitivity. Sometimes there is a discrepancy, and that's particularly true for the beta lactams because when we know they are concentrated in the urine, when Kamila tells us it's sensitive or not, it's on projected levels in the blood. That's what your standards talk about, your CLSI guideline. And the urine concentration of that particular antibiotic might be even 10 times higher. So the patient will respond. And I think the response of the patient is primary, not really treat the patient, not the report.
The only caution is I would watch this patient for a late therapeutic failure or relapse, because sometimes you get an immediate clinical response. So you would watch out for that. And if that happens, then you would want to use an antibiotic based on the sensitivity.
Now, suppose if I tell you that this child has had a documented UTI in the past, and this is a second or third infection, would you still, stick to beta-lactam or go as per the culture sensitivity?
So again, it would depend whether how short have been the intervals between them. So suppose a child had a UTI 6 months ago and is now coming up with another episode, then I would not treat it as, I would treat it as a recurrence and not a relapse. But let's say 20 days ago, this patient had a UTI, was treated with cefixime, got better, now has again come back. This is a kind of patient where I would probably want to change, because this may be actually a relapse due to inadequate microbiologic sterilization.
Dr. Camilla, very often you tell us that coamoxiclav is sensitive in the lab report. How good is this antibiotic for urinary tract infection?
When the bug is E. coli, we find it's not so good. But we find as third generation oral cephalosporin, cefixime with clav actually works better for E. coli. But for certain other gram-negative, you can get away with coamoxiclav.
Suppose you have an ESBL, then, and very often it is sensitive to piperacillin, tazobactam or amikacin, and the parents are just not willing to stay back in the hospital or continue with the injectable therapy. And the sensitive report shows cotrimoxazole and coamoxiclav sensitivity. Which one of these should be chosen? How good are they as
I would prefer coamoxiclav. Cotrimoxazole.
Cotrimoxazole would be good. Yeah. You want to add something, Tanu?
I think, we also have to look at the MICs, because most often you find that the coamoxiclav MIC will be 8 and it is being reported as sensitive, which is just at the break point. So if it's an ESBL pathogen and it is ceftriaxone resistant, then coamoxiclav may not work, especially if you have a situation where the patient had a UTI 15 days ago and relapsed. So I think it will also depend on what is the previous history.
Okay.
Because this time you would want to give definite therapy. And also one thing we must remember is that whenever a child is having a UTI, we are losing nephrons. Okay. So you can say that, okay, the patient is better and we'll watch if he gets the next one. Though then every time he gets a UTI, there is damage to the kidney. So I think our aim is not just clinical improvement, but also microbiologic cure in that sense.
That's a very important point.
I'm pretty fond of cotrimoxazole. I use it even for other conditions. The problem really is we don't get injectables. So if you have a patient who is very sick, you can't give. And even the oral preparations are not easily available. The syrup is no longer available. So you have to give the tablets which you have to crush into.
I agree. But then in case oral preparations are available, it's a good switchover from injection. Okay. Sanjay, this is a 5-year-old girl, has abdominal pain, there is no fever. Again, urine routine has been done as a routine test. It shows 2 to 3 pus cells and culture also has been said, which has grown E. coli with a significant colony count. And child has no symptoms at all. So what I'm trying to ask you is how do we tackle this asymptomatic bacteriuria?
So actually, if the urine routine is normal and the child does not have any fever at all, so no symptoms of urinary infection per se, probably this is more likely to be an asymptomatic bacteriuria and need not be treated if the child is keeping well otherwise.
But how did Dr. Camilla grow some bacteria from this urine?
No, asymptomatic bacteria is known. And the whole issue is whether we are going to treat asymptomatic bacteria with pyuria or without pyuria. The CDC and the international organizations say even if there is no pyuria, there's a lot of controversy on this, but clearly asymptomatic bacteria, I believe, should not be treated in the antibiotic stewardship world that we are getting into.
The only situation where you would treat it is it's a pregnancy. And second is that if you are planning some urologic intervention, then you would treat. And thirdly is the most common cause is improper collection of urine and delayed transport to the lab. These are the more common causes of this significant colony count.
So UTI by definition is culture positivity in a patient who has pyuria. So and symptoms. Absolutely.
Vijay, just go back to that slide. If, for example, you have a patient who has symptoms, not here, you're really desperate to know if this patient has UTI in significant bacteriuria, ask the lab to do a gram stain. not a routine which we cover slip, which we do. And in the gram stain, even if you see one bacteria, 1 gram negative organism, it correlates to 10 raised to 5. So immediately within 20 minutes, you come to know, oh, this is significant bacteria. The person is symptomatic. There is pyuria. I should treat. I don't have to wait for 2 days.
So regardless of
That's
the
assuming the sample is reaching the lab immediately.
Yeah.
That never
Different
happens.
conditions.
So you're always going to find one bacteria, they will always
No,
find,
you
right?
don't,
Because
you
it
don't.
reaches after several hours.
fever without focus is a very common scenario that we come across in practice. Here you have a 5-year-old girl has high fever for 4 days. There are cases of dengue and influenza and other viral infections going on in the community. Liver is just palpable. So Sanjay, what are the routine tests that you order in such scenario? A very, very common scenario.
Right. So I would definitely start with the complete blood count with a peripheral smear. I would probably do a C-reactive protein, a urine routine, and a blood culture probably, because 4 years high fever is persistent. So I would like to go in for a blood culture as well. And with the dengue season, dengue NS1 will be required.
So Tanu, my question is, do you as a blanket ask for all these tests, or you have some
Yeah,
discriminating
so
clinical-
I actually tend to do a little triage. So my initial tests in this is a CBC, malarial parasite, C-reactive protein, dengue, NS1 and urine routine. I don't order a blood culture upfront because if this turns out to be dengue, then it would be a waste and it is an expensive test.
No.
Of course, the downside to that is you will be pricking the patient again. But usually, unless I have a patient where it really looks like enteric clinically, you can differentiate, by
Right.
clinically. So if you are if your clinical likelihood of enteric is high, then you would do a blood culture along with the test. Whereas agar every third patient you're seeing is turning out to be dengue, then in that case, I would probably do a dengue serology first and then maybe do a blood culture if that turns out negative.
So malarial antigen depends on the area where we are practicing.
I
For
would
example,
add malaria to that.
so in
Malaria.
Pune, in the last several years, we hardly have seen malaria. So we do not do malaria as a routine in Pune.
Yeah, but we do in Mumbai, so I would definitely add
Absolutely.
malarial.
What do you prefer? Peripheral smear at the hands of a good microbiologist or malaria antigen?
If you have a good laboratory, as WHO says, a good
Smear
sequence
has a
smear
better
is the gold
sensitivity.
standard.
Okay, yeah. Now I have a long list of questions for Dr. Camila, and let's do a rapid fire. Blood culture, which patients with AFI? Tanu has already alluded to that. How do you prepare this site, the volume, whether you collect 1 bottle or 2 bottles, same site, different site? In pediatric practice, when do you ask for anaerobic culture? How do you store it, transport it, and how do you identify the isolate?
Blood culture is the only test I really, really like, because when I get something positive, which is not a contaminant we'll get into, you've got the diagnosis. The most important point is how do you prepare the site? Because the skin is full of bacteria, of skin colonizers, and even if you have prepared it, the person collecting, I collect blood sometimes and I'm always tapping with my dirty finger. So if you're going to do that, everybody does it, even my most experienced phlebotomist. Put some of the same disinfectant you're going to use there, put it on the tip of your finger so that this doesn't contaminate the site you're going to pierce. The best disinfecting agent is actually chlorhexidine with 70% alcohol. Now, chlorhexidine we use in our hand rub. All of us are using 0.5% chlorhexidine. This is different. This is not the hand rub chlorhexidine. This is 2% chlorhexidine, which we use actually for central lines. So 2% chlorhexidine in alcohol, 70% alcohol, keep for 30 seconds and do it. This is not applicable to neonates. Less than 2 months, you cannot use chlorhexidine as a disinfectant there. And there we would use either tincture iodine or povidone iodine. The problem with povidone iodine is that you have to wait and everyone is in a hurry. The child is crying. We can't wait. So best is actually, if not older than 2 months, chlorhexidine 2% in 70% alcohol, 30 seconds. Volume, we calculate 1% of the volume of the child. In neonates, it's 85 ml per kg. So 1 kg child, 1% of that. And in older children, it's 73 ml per kg. That's the body volume, so 1% of that will go. 1 bottle or 2 bottles, actually, children don't get much of anaerobic infections. Unless, of course, there's a ruptured appendix or there's some reason to suspect an anaerobic issue. It's better actually to take 2 aerobics. What we do if we're taking 2 sets, we take 2 aerobics and 1 aerobic anaerobic. storage and transport, it's really sad. Sometimes we get blood cultures collected perfectly, and the very over efficient staff have actually put the blood culture into the ice or kept it in the fridge. That's really sad. Two things you don't put in the fridge. One is CSF and one is blood culture that is already inoculated. The reason is that once you put the blood of the child into the bottle, and the bacteria are there, the bacteria start multiplying. And we will always catch them in the lag phase as they multiply, and then they go into the log phase. So you have to get it fast to the lab, because the lab's machine, I'm talking about automation, they detect come positive, especially in the lag phase. So if you've actually given the blood culture after 8 hours and it's already reached the the lag phase, you may not get it positive in the machine. That's the thing, because it's already become lallu, as we say. So catch it quickly inoculate it. Do not refrigerate and put it into the lab, into the machine fast. Isolate identification, anything except cons, anything Propionibacterium, Micrococcus, Bacillus are contaminants. Cons only if you have hardware. That means there is some foreign body. It can be anything from a line to a foreign body that's kept in the body. Everything else is in coagulase negative is a contaminant, which is why we need to do 2 sets at least, because if I grow 1 of the 4, I will say forget it. But if I grow 4 of the 4, all growing cons, I would seriously consider that a coagulase negative is important. MIC.
Just a question before that. Can you quickly tell us how do you identify the isolate? Do you do a routine gram staining, or what are the recent
now we
advances
become
in
really
that?
spoiled. We don't bother about doing anything. We take it from culture, we put it into MALDI-TOF, and in 10 minutes we come to know. The old microbiology is gone, but traditionally you don't have MALDI-TOF. You would make a gram stain, you would do gram negative or gram positive, and then you do biochemicals. If it's gram positive, there's catalase, coagulase to do.
And in a language that all of us can understand, what is MALDI-TOF?
MALDI-TOF is an expensive, nice machine that I've grown to love dearly, because within 10 minutes, it tells me not only what bug it is, what bacteria, what even NTM, even fungi. It's just really a wonderful machine, which basically stands for matrix assisted laser deabsorption ionization time of flight. It basically, when you put the bacteria on that small well, it sort of makes it evaporate. And then it goes, depending on the signature protein that the organism has and on the database that the machine has, it can accurately, to the point of 99.9, tell you that this is this.
Oh.
It's like me going through a machine and you are Camilla and you are Vijay. That's it. It's so accurate.
Does it tell you the genetic resistance pattern also?
You can do it, but it's very specific. You can do it for carbapenem resistance, specifically imipenem resistance. It's it's not yet standardized for resistance yet on MALDI-TOF.
So this is, you said, protein based. What is the difference between MALDI-TOF and Vitek2 that many laboratories use?
See, MALDI-TOF is looking at the protein signature of the bug. Vitek2 is actually identifying the bug on the basis of its biochemicals, which is the traditional one we were doing all along. Put it TSI. Remember in MBBS how I used to hate mugging those up. I never knew I'd land up with this. But you would, urease, whatever. You did a whole lot of battery of biochemical tests manually. This just does it in a machine.
You talked about some contaminants which are true contaminants, but very often we get reports, surprisingly, Acinetobacter or Klebsiella, which are pan-sensitive in a patient who is hospitalized. And it really doesn't corroborate pretty well with the clinical findings. So how do you, and you get scared to disregard such a report. How do you interpret this report? What should be?
See, Acinetobacter is clearly a hospital bug. There are reports in Taiwan where they say it could be community, but as far as we are concerned, it's a hospital bug. It just may have come. See, some like Burkholderia, for example, comes from the disinfectant you're using. It grows in betadine. If you're using betadine and you culture the betadine, you will find the Burkholderia there. So it's literally, you have to be very careful how to interpret these bugs. And in a hospital setting, when something is sensitive, span sensitive, I think, God, this is not really coming from the patient, because we're so used to seeing resistance. But again, we have to interpret clinically.
Tanu, can we roughly say that if this kind of a gram-negative bug is pan-sensitive, it is unlikely to be a pathogen in a hospital environment?
No, you cannot say that. It also depends on when you drew the culture, at the time the child was admitted or after 2 days. See, suppose your patient has come with fever and you have admitted as enteric and you've drawn a culture and it goes Klebsiella or Acinetobacter, then you know that it is probably a contaminant. But if the patient has been in hospital for 2-3 days and then maybe the patient's fever is not coming down or you're not making a diagnosis and then you have grown it, then you can't just dismiss it because it could be a hospital acquired infection. We know that the nursing may not be proper. We may know that the fluids may be contaminated. So that is why it depends on when you actually do the culture. And one more thing which I wanted to add to Dr. Kamila is maintain the blood media ratio. Like if you use the PEDS plus bottles, which have 20 ml of media, you can output only 4 ml of blood. So if you have collected 8 ml, you'll have to put 4 plus 4 in 2 bottles, and putting in 2 bottles also helps because you can differentiate between contamination and true infection. But you will have many cases where it will grow in one bottle and not the other. Then you can't dismiss it as a contaminant because the entire reason we send 2 bottles is because the volume has increased.
Correct.
So
I just want to clarify this. I want to ask you, where are these 20 ml bottles available? All bacteric culture bottles are 40 ml. So even pediatric bottles, they are available.
20 ml
PEDS
bottles.
plus. Yeah.
In
No,
my-
I wanted a clarification from, since Dr. Kamila mentioned that all of us have this habit of tapping before you collect. How important is it to wear sterile gloves before doing blood culture collection? Because then you solve the problem. How
Yeah.
many would you insist that your people wear sterile gloves before blood culture collection?
Our people will, I'll tell you what they do. I have to show it to you because you said sterile gloves. They will put on their sterile gloves. Then they'll tie the tunique, then they'll do everything. So the sterile glove, unless just before you're collecting the sample, you put the sterile glove on, then in a sterile way, then I wouldn't. But you say sterile gloves, everybody loves to use sterile gloves and does everything after that.
Yeah.
what you can do is that you can put the hand rub. See, you have done the palpating, you have done the cleaning, then you are tapping, then you can again put the hand rub on your hand. So that way you have disinfected
That's
your
what I
hand.
said, yeah.
Okay, Tanu.
Just a short,
Yeah,
sir.
Sanjay,
Is
please.
Vitek too, I mean, we are not all lucky to have Malditoff. So can we rely on the Vitek? Is it comparable?
It's excellent. It's a little expensive. Malditoff is just 30 rupees actually, and Vitek 2 is much more expensive. Once you get a Malditoff, you've got a nice donor who's given you Malditoff, it's great. Then it's just 30 rupees per isolate.
But I think for Malditoff, your running cost is very low. So if you have the, no? So
Exactly.
once you have the equipment,
It's
it's
fine.
very easy to use it for
Exactly.
everything.
Tanush mentioned something like if you want to use co-amoxicillin, look at the MIC. And so either Tanu or Dr. Kamila, can you quickly tell us about MIC and the clinical breakpoint and how do you interpret, and for a clinician, when he gets a report, how do you, suppose you have 2 antibiotics which have MICs in the range of sensitivity. How do you select between the 2?
No, so MICC, when you do susceptibility testing, earlier we used to use the disc diffusion method, where they used to do the zone diameter and compare it. If the zone diameter was bigger than the breakpoint, it was sensitive. If it was smaller, it was resistant. Now we have moved to automated testing by Vitek, where you actually, you see what is the minimum inhibitory concentration to inhibit the growth of the bacteria. And once you have that MIC, then you compare it with the breakpoint, because you can't just say on the basis of the MIC. If the breakpoint, so you have 2 breakpoints, sensitive and resistant. So if the MIC is below the S breakpoint, it is sensitive. If it is above the R breakpoint, it is resistant. And if it is between the 2, it is intermediate. But you also have to, especially if you're dealing with intensive care patients, it's not enough to just look at sensitive or resistant. You have to also look at the MIC and what it is compared to the breakpoint. Now, the breakpoint we know, let's go for piptase for E. coli is 8. So if you have an MI or 16, if you have a MIC which is 16, it means it is just at the breakpoint and you may not achieve therapeutic success. So you have what is called as the MIC breakpoint ratio, and the lower the ratio, the better is the antibiotic. So if you have to choose between 2 antibiotics, you can look at the one which has the lower ratio, but in clinical practice, you don't look at that so much as you look at the cost, you look at the site of infection. Those are the other factors which make you determine. But you must remember that if you have an MIC which is just at the sensitivity breakpoint, then you have to use that antibiotic carefully, or you have to use a higher dose.
Dr. Kamila, do you mention these breakpoints when you give us
That's what
the
I was going
report?
to say. See, that's the magic word. None of us, see, because we're doing so much, when you as a clinician see an MIC, the MIC is only true to that bug. It's representative of that organism. The breakpoint is already what we follow. It's written in stone. We changes every 3 years, 2 years. That ideally should be printed on the report, which none of us is, some few labs are doing it because it needs a lot of software to keep changing your, as you print out. But if you have the sensitive breakpoint on your report and you have the MIC, you just divide, you get an efficacy ratio and then you can do it easily. Otherwise, you have to go online and check what the MIC breakpoint
There
is.
is an app which is available called Breakpoint MIC, but it's not for Apple, it's for Android. You can download it and you can just write the name of the organism and the antibiotic and it will tell you what the S and R breakpoints are and you can use them.
We're getting them. We just put pressure on the microbiology and say, "Arey, kaisa report tumne diya? You should put your breakpoint on it as well." And that will put pressure, and we are starting to succumb to pressure and we'll do it.
That was really enlightening. Okay, Sanjay, these are the reports of this patient. Now, everything is negative. How do you proceed further? Do you add for additional labs? Say, for example, do you ask for scrub typhus IgM or extended Vidal, or what do you do in such situation?
So preferably if we would of course like a good history. If there's a history suggestive of say possibility of exposure to livestock or something, then definitely we would like to go for rickettsial infections to rule them out. Sometimes we have to give a therapeutic trial because the test may not be feasible at that time. So yes, depending upon the history, we would like to go for rickettsial tests.
How sensitive is this test? The scrub typhus IgM?
Actually, I do not use it in my practice. In the setting where I practice, I have to give a therapeutic trial which is cheaper for the patient rather than doing the test.
Dr. Suhas, extended Vidal, and do you order those tests?
No, I think the most important thing is what Dr. Nathu said. Look at the clinical background. You started in the beginning by saying searching for a needle in the haystack.
Yeah.
So a prolonged fever patient is not one where I'm going to do all tests and try and say what is.
Absolutely.
If you have the clinical background, you'll find ways to confirm it. And also I need to point out that while this is an ID session here, a lot of these patients will turn out to be non-ID, non-infectious disease. Look at whether it's a rheumatological case. Don't miss a leukemia. There are so many other things to think of.
You know, this patient, you could even be enteric for all
Yes.
you know, because this patient may have got some antibiotic and may not have had enough volume of blood collected. So one test which I particularly find useful is an ultrasound abdomen. If you're suspecting enteric, your blood culture is negative. If you have a good sonologist who can tell you there's terminal ileal thickening, splenomegaly, mesenteric nodes. So I would think of enteric earlier than scrub typhus, especially if there was no epidemiological link.
And one we
That's because
found, sorry,
the people outside Mumbai will think of scrub typhus first.
just one point from the CBC, if you look at the absolute eosinopenia, that's really a good marker for enteric. We really find it very useful. Just from a CBC, you can, even blood culture is negative and absolute is nothing. So
One important information which you have missed out is the DLC, which is very important to try and judge what kind of infection it is, and also the peripheral smear. If it is showing reactive lymphocytes, you could be dealing with a viral illness.
Right. Okay. These are very tempting tests. You have this different panels available. There is one such panel available in Mumbai, tropical fever maxi test. Tanu, when do you use this? How sensitive? I mean, are you always happy? Or anyone?
No, I don't use this test commonly because I first look at the conventional tests, like what you said. And then if at all I've thought in thinking of chikungunya or lepto, then I ask a specific PCR because they are available. I would do this test only if I'm really suspecting rickettsial illness because there's no quick way of early diagnosis because it's an expensive test. So we should try 70 to 80% of your tropical fevers will get sorted out with your malaria, dengue, blood culture and other things. And this salmonella is not good. I think you have to do it from the culture bottle. You can't do it from the blood.
So, Dr. Kamila, why is West Nile virus included in this fever panel?
because it was developed abroad.
Okay. Okay.
I think this is a test for the lazy pediatrician who doesn't want to even attempt a clinical diagnosis and do what you showed earlier, use a magnet and hope something comes out of the haystack.
but this is a new way of looking into the haystack. Which, okay, so Dr. Kabila, what about contamination? See, she said she would use it to diagnose rickettsia. A DNA detected in blood, is it 100% specific for rickettsia?
See, the sensitivity and specificity of these tests is generally okay. If it's done in a good
Okay.
lab and everything is followed for molecular biology, it's okay. I'm not too fussed about that. It's a negative predictive value and the positive predictive value that's important, and it's the pre-test prevalence. Pre-test
Test
likelihood of that, like you said, is it looking like a chikungunya? Sometimes we have patients who, not so much kids, but adults who clearly are not able to hold a cup, and we know it's chikungunya, and the IgM has come negative. We've probably lost the window for PCR, but if you're lucky, you may get a PCR positive.
Dr. Prabhu, that area of search needs to be narrowed. She mentioned about negative predictive value, positive predictive value, sensitive specific. Can you quickly enlighten us on that?
Okay, I think that's very important because a test has a value depending on what its positive predictive value is and negative predictive value is. We only look at what we call sensitivity and specificity, but that's not adequate. Because what is positive predictive value? It means that if I have the test positive, does it mean the patient has disease? And a negative predictive value is if the test is negative, it means the patient does not have disease. Now, this is not directly correlating with the sensitivity and the specificity of the test. It depends on how likely the patient is having the disease. As Dr. Kamila just said, if the chances of having the disease are low, then doing such a test looking for 10 different things is useless.
So the pre-test prevalence is.
And if you have a low pre-test likelihood, your positive predictive value is poor, even if the test is positive. And that is a classic example is the TORCH panel. Because there the pre-test prevalence is less, the test comes positive. Most of the times it's a false positive report.
Absolutely. Another common infection that we see in clinical practice is lower respiratory tract infection. This is one such patient, 2.7-year-old boy, high fever, cough for 5 days, has received these 3 antibiotics before he came to us. Child was febrile, sick, and was wheezing also. And these are the counts: neutrophilic counts, leukocytosis, normal platelet, and a very high CRP. And this is what the X-ray showed. How do you make a microbiological diagnosis, Sanjay, in a case of low respiratory tract infection? Do you do blood culture in all patients, sputum culture, throat swab culture, urinary pneumococcal antigen in a case of pneumonia?
So actually, a small comment on antibiotics. The antibiotics probably are a little haywire.
Let's not discuss that. And I said he came from outside to us.
Absolutely. So blood culture has a very low yield in respiratory infections, pneumonias, maybe up to only 10 to 15%. So an attempt may be made, but it is not going to give us much of a microbiological diagnosis.
So which pneumonias will you ask for blood culture? Sanjay, you can continue. Yeah.
No, actually, Madam Kana, I'm not sure.
So, Dr. Suhas?
I think, I mean, there is a clinical situation where I mentioned this to Dr. Tanu last week, where you can clearly make out an acute bacterial infection, for example, due to streptococcus. You have an older child who comes with a single chill. He has chest pain, very typically of streptococcus. Streptococcus pneumoniae, typically you'll have chest pain because there's an initial pleurisy. You say consolidation on the X-ray, and this patient has not received any antibiotic. I'll be happy to do a blood culture on that. In this patient who's received 3 antibiotics in the first 5 days, I'm not going to get anything.
Dr.
And as
Kamila,
Dr. Nathu rightly said, in any case, the yield is going to be low. But if I do get it positive, I have an unequivocal diagnosis. As Kamila said, she loves blood culture. If it's positive, you have your diagnosis. You're seeing the pathogen in front of you. And you're also going to get a sensitivity so you know exactly what to give. So while the yield is low, if done correctly at the right time in the clinical situation,
True.
blood cultures are useful even in pneumonia.
But as a thumb rule, hospitalized children, very young children, sick children, you would do blood culture.
If the child is very sick, I'm going to attempt it anyway.
Right.
And if the child is in our ICU and if you
certainly
think is acquired a nosocomial infection, definitely I want to do a culture.
Dr. Kamila, quick word on this sputum culture, throat swab culture. And once you showed me that urinary and pneumococcal antigen, Binax. So
In a 2-year-old, I don't know what is the value of a sputum culture. The poor thing cannot even cough it up. A throat swab culture, again, we are going to grow so many. Throat swab is actually only done for one indication, no beta hemolytic strep isolate. That's what we report. Anything else is a commensal, so I'm not happy with the throat swab culture. Urinary pneumococcal antigen is a good test, but in children, unfortunately, there is an issue there are three issues. Yeah, Binax, because Streptococcus pneumoniae is carried in the throat, and also it shares certain capsular polysaccharides with strep mitis, or rather strep mitis shares the same. So in kids, I'm not really happy about that test. In adults, it really works well. That urinary pneumococcal antigen does wonderfully in CSF. For example, you have a child who comes in looking like pyogenic meningitis, possibly received an antibiotic. Cultures are going to be negative, cannot afford that wonderful biofire, which is 10,000, and you're thinking pneumococcus. Do the urinary Binax test for the CSF. It has really good sensitivity.
Is it validated for CSF?
Yes,
Yeah.
it is valid.
And is it validated for pleural fluid? Because that's the other question that people ask.
Yeah.
And I know you say, no, I don't want to do it in pleural fluid.
It's not validated, so I don't do it, but you can try.
So that's an important. You could try urinary Binax on CSF sample in case of suspected bacterial meningitis, and we put our foot into it. We asked for a nasopharyngeal swab PCR, very tempting test, and this is what we got: strep pneumonia detected and RSV detected, and this is the Excel picture. What do you infer out of this, Sanjay?
So I'll still obviously continue the antibiotics looking as it is.
No, this is PCR, strep pneumonia and RSV, both detected.
RSV may be there just as a co-infection sometimes.
Or is the other way around?
No. See, I don't think you can get pneumococcus on the upper respiratory biofire. It does not include pneumococcus.
Not biofire. This is
Some other test.
laboratory.
So one more important point which I want to make here is that please always ask for the validated test. Please don't do, because there's so many labs offering their in-house PCRs and these are not validated. So you will get all these kind of results, because most of them, I mean, in the validated test, pneumococcus is present in the lower respiratory biofire, not in the upper respiratory one.
Okay. So last couple of months, we have tried this PCR on several patients on nasopharyngeal swab. We have got all sorts of viruses, detected all sorts of viruses. Sometimes human metapneumo, adeno, RSV plus strep pneumonia. In fact, we had two twins admitted with bronchiolitis. Both detected RSV. One detected pneumococcus, the other detected Haemophilus influenza. I mean, it's becoming extremely difficult to interpret. But as Tanu said, maybe ask for a validated test. And so this we have discussed. I think we are running short of time. Last 5 minutes, so this is what I said. Okay, last 2 minutes. Yeah. This is 2 minutes.
Vijay, just one point.
I'll fly you to Shirdi, don't worry.
Asymptomatic carriage, a long incubation period, we've seen it with SARS. Co-infection and superinfection are big issues in this. And asymptomatic carriage can happen with rhino, with entero, but when you get influenza, when you get para-influenza, when you get RSV, generally they are pathogens.
Okay. Dr. Suhas Prabhu, 2-month-old baby, referred for unilateral otorrhea. Should we try to find the needle here?
No, I don't think in an acute otitis media, there is any role for doing a ear culture. We know the common organisms are community acquired and they're likely to respond to amoxiclav or ceftriaxone if the patient is going to be admitted. The issue of doing a culture from a discharge in the ear will come in CSOI, not in an acute otitis media, or in a patient who's got some kind of a comorbidity or something. Like, for example, he's got a ciliary dyskinesia or he's got cystic fibrosis and which is getting a chronic ear. Then I'm suspecting an unusual organism. Sometimes it's Pseudomonas. And on 2 occasions in my 40 years experience, we have grown mycobacteria. So that's for CSOM.
So can
acute otitis media, we don't.
Can staph cause ASM, acute otitis media, staphylococcus?
Staphylococcus, yes, I suppose.
Okay.
But it would be very rare.
This is a true case. The swab culture was sent and it grew MRSA, which was sensitive to vancomycin TCOP. How do you interpret this? Do you treat this? A 2-month-old child with otorrhea growing, MRSA staph.
In a 2-month-old child with an autoreogram MRSA, I cannot afford to neglect it. This child might
You
end up
treat
with
it.
sepsis, so I would have to treat it.
So staff
But I have
can
never
cause
seen,
acute otitis
I have
media.
not seen an MRSA in a
Tamu,
year's
your
time.
take on
And you
this?
know, this is a skin organism. So this MRSA could be coming from the skin of the external auditory canal. It may not be the pathogen.
So you
Unless you
neglect
are
it.
actually, and you have to be sure that you are having not otitis externa. You have
No,
to
no,
be
this was
sure.
otitis media.
Because if it is otitis externa and there is a pustule in the ear and you have grown MRSA, it makes sense.
No,
But-
this is otitis media.
I would also like to add that I would not do a ear swab. I would aspirate the pus and send it directly. That will avoid these chances of contamination from the
In fact, this is
external
what
ear
the
canal.
patient came with. He came for admission for injectable vancomycin to our hospital. So Camilla wants to make some.
Vijay, I don't think. I think AOM has 3 typical pathogens: strep pneumoniae, moraxella, and non-typable Haemophilus influenza. If this is an AOM.
Should we try PCR on this?
No.
No. Okay. Okay. So friends, I think for want of time, I'm sorry I had to stop here, but it was wonderful listening to our experts. And I think the finding the needle would be a little more easy with the newer methods and the expert advice that we have received from all these experts. Thank you so much. And thank you for the patient listening.
Thank you so much, sir, for your wonderful lecture. I request Dr. Anil Kasliwal to felicitate Dr. Vijay Yevle. Thank you so much, Kasliwal, sir. I request Dr. Vijay Yevle to felicitate our speaker, Dr. Tanu Singhal, ma'am, Dr. Camilla, Dr. Suhas Prabhu, and Dr. Sanjay Nathu. Thank you, sir. Thank you, Kasliwal, sir.
Now we shall move on to our next session. For this, may I request Dr. Tanaji Kanade sir and Dr. Jayashree Suravashi ma'am to come upon stage as a chairperson. I also request Dr. Tushar Maniyar to come on stage, the speaker of the session. This session is on common household poisoning. Children are like small mice. They crawl and run around the entire house, checking every nook and corner. Being so supremely innocent, they cannot say the good from the bad. He would pick up anything from anywhere and would not just stop looking at it. He may put it in his mouth, his nose or eye. without the knowledge of any family member. And before they know, the child may have landed himself and the family into trouble. This trouble could extend from little watering of eyes or sneeze or right up to severe problems. So, to know more about this, I request Dr. Tushar Maniar to take over.
Thank you very much. Thank you, team MAHAPEDICON, for the wonderful arrangements, events, hospitality, and of course, the scientific content. Thank you, Chairperson, for your time. And in the next 30 minutes, I will try and I'll just change that slide. I don't like to see my name and I've removed my photograph from the screen. So today I'll try and speak on household poisoning. And the topic given to me was common household poisoning. I used to wonder in all this subspecialty era, why are we thinking about it? But we have to remember that almost half the cases of poisoning that we see are common household poisonings. And so it's important for us to know because they come as emergency and we should know how to react till we gather more information. If you see here on the screen, you see a bottle which is nicely labeled as poison. Unfortunately, all poisons don't come labeled as poisons, and many things which are non-poisonous can behave as poisons. Some of you may know this lady. She's from Kerala and she has confessed of giving poison to her beau in Kada simply because she attempted earlier of mixing 50 tablets of paracetamol in a juice and tried to give him, which he thought it was too bitter, the juice, and did not consume it, which is what happens with most our children. They try to explore new things, but fortunately, things which are poisonous are not tasty and they don't land up consuming more. So she decided to give it in an Ayurvedic kada, which is supposed to be bitter, and she succeeded. But it's not always so simple when we see in our lives. So when do we suspect a child having consumed or suffered from poisoning? When a patient comes to an emergency room, the first three things that come to our mind are injury, infection, and intoxication. But remember, any emergency, if you don't have an obvious cause, or sometime even with an obvious cause, consider poisoning as a differential diagnosis. Suspect poisoning in any emergency when you are not sure of the cause, and especially so if the presentation has been sudden or the presentation has been unusual. Meaning, you have a child who comes with loss of consciousness. If the child has had seizures, who has never had seizure earlier, or there is no reason for the child to have seizure, consider poisoning as one of the obvious possibilities. A child comes with breathing difficulty, abnormal breathing, abnormal rate, rhythm, or type of breathing, do consider poisonings. Also, if the onset has been unusual or history is not commensurate with the presenting examination, think of poisoning, whether intentional, suicidal, or as non-accidental. Various odors, which we'll discuss, can also sometimes point toward poisoning. Whenever the patient comes to us, as any other emergency, you always do the assessment first, and we do assessment on basis of PALS, airway, breathing, circulation, decontamination, disability, and exposure. All of you are experts in managing emergency and PALS. Okay. Can we close that door behind when people move in and out, because it's a bit of a disturbance. Thank you. If you are dealing with different type of breathing, whether it's a metabolic, acidotic, tachypnic breathing, or if it's a Kussmaul breathing, or there's a depression in the breathing pattern, as you see with sedatives or barbiturates and opioids. In circulation is one of the most common things that gets affected, whether it is brady or whether it is tachy. whenever you deal with poisonings, make sure that decontamination is taken care so that the further absorption and exposure is prevented. And the child's eyes should always be looked at because that's an area which is vital for further care and preventing long-term morbidity. AVPU is the standard of care when you look at disability, and we will discuss pupils and toxidromes a little later. So when you now think that this child has poisoning and you know probably the substance, there are two important things that we always focus on. One is when the child has consumed or has been exposed to a poison. Sorry. And how much, if you can assess. Then the important thing is, because once you know the time interval between the consumption and presentation, you know how much longer to monitor the child, what different symptoms to expect. Because, for example, if it is an exposure to overdose of salicylates or paracetamol or consumption of iron tablets, you would know that presenting symptoms are different in the first hour versus after a few hours. Also, it's important to know when they noticed symptoms and what has been done so far. Important to know if there have been any pre-existing illnesses, like, for example, a child with G6PD would have a very different manifestation with naphthalene ball poisoning as a household exposure versus somebody who does not have. It's always good to ask for bottle or drug, or at least have a photograph, because it's not enough to say that he or she consumed or exposed to so-and-so. Give you a classic example of, say, rat poisoning. Somebody will say the child has consumed some rat poison. Now, it could be that it is a rat poison which contains warfarin-like substance. It could be a poison which has a phosphorus, or it could be an arsenic-containing rat poison. And the manifestation and management is going to be very different. It's also good to ask, especially ask them to get the bottle or the tablet and the pills, and ask them, when did you buy this product? How much has been used? If you know that there is a 15 ml content, you can measure what is left inside, and that will give you an idea of what max dose the child may have consumed. It will always be less than that, because there will be some used amount, some spilled amount, and some amount which is left. So that will give you an idea about how much the child has consumed. Just like a foreign body, when you look at one, you look for others. For poisonings also, especially if it is exposure to pills, etc., it's not necessary that they have consumed only one particular tablet. There could be exposure to more than one. Now that you have a history of poisoning on examination, you would want to look at the vitals. As we know, they are the most important thing when you are managing any emergency. It's also important to look at pupils, because they will give you some indicator on what type of poison has been consumed. There are some other specific areas which are important to look at, and that is loss of consciousness, seizures that you see with stimulants or camphor and methanol. What I've tried to do is, rather than giving you a whole list of poisons, I've tried to focus on household poisons, that means exposure from the house. And if you see the skin that is flushed, then you think about atropine or atropine-like substances. If you see cyanosis, you can think about naphthalene balls, which will be giving methemoglobinemia. And if you see spill marks, then you know that there is some corrosive substance, whether it is acid, alkali, or something similar. Various odors are peculiar to certain poisons. And it's good to remember that organophosphorus compounds, when there is poisoning, give rise to garlicky odor. And some are obvious. So if there is petrol, gasoline, alcohol, hand sanitizer, or substances containing methyl salicylate, they will have their own odor and you would be able to make out. There is something called as circumstantial evidence, and that means in jurisprudence, you know that there is a direct evidence, meaning I saw somebody shoot that person. Now that is a direct evidence. So if you have a direct evidence, you are very happy. You know that this kid has been exposed to this item. But then you get history that I heard the gunshot and this guy ran out of the room. So that's a circumstantial evidence, but even that is admissible. And the same thing, I will explain to you what I mean by circumstantial evidence for poisonings. We'll not spend too much time on things which are obvious and you already know it. So I've tried to highlight them in different color so that we can pay attention and finish my talk in the given 30 minutes. So hypothermia, when you think about hypothermia, you think about anything that depresses the system. So it can be carbon monoxide, opioids, or alcohol. I know alcohol is appearing at 2 places, but that depends upon what are the other manifestations. You can have bradycardia, you can have tachycardia, slow or fast respiration, and hypo or hypertension. And this is not an exhaustive list. This is just a selective list of common and or household items. This is very important because pupils are a very important indicator. And just like everything else, there are mnemonics to remember everything. And there are mnemonics to remember the mnemonics. And finally, we'll end up not remembering any of those mnemonics. So you can choose your own mnemonic. I have chosen today COPS. That means cholinergics, opioids, phenothiazines, and sedatives. So these exposures give rise to meiosis. On the other hand, if you have cholinergics here, then you must have anticholinergics somewhere sitting with mydriasis. So you have sympathomimetics, you have anticholinergics, and various drug substance withdrawals which can give rise to mydriasis or dilated pupils. I was talking about circumstantial evidence. This means if you know the site where that probable accident or incident has happened, then you know the possible event. Suppose this child was found to have visited the puja room and he is now irritable or has thrown a seizure of unexplained origin. You will say, okay, let me see if this is a camphor poisoning. Of course, there may be smell or odor of camphor in that child. If it is a medicine cabinet is open and some pills are spilled, then you know that that is the problem. Also, if you feel that there was certain amount of medicine in a particular bottle and now it's not there, you know that there is something missing. So sight, smell, spillage, and something missing. All this history will guide you towards diagnosis of this. Finally, we come to toxidromes. It's a very fancy word, and when I teach my PGs, we always tend to ask them questions on toxidrome. This is the chart which if you see the standard treatment guidelines, which are now coming up twice a week by Indian Academy of Pediatrics, it's a wonderful collection. I think the latest one is 119 number. It's a bit of an exhaustive list, but they have really covered very well. And a large amount of my talk today has been taken from standard treatment guideline because it's very easy to refer and it's very practical. And I have no financial interest in STG. Everywhere you must declare that, isn't it? But how do you remember this? That is my challenge. It's not possible to remember. So I'll tell you how I remember it. I remember from my very early days, datura poisoning. And datura is equal to atropine. Atropine is equal to dryness. So I know that atropine will cause pupils to dilate. It will cause skin to dry. Urine will be less. Heart rate will be high. It will be, my skin will be red. So, you know, all those red as a whatever and mad as a dog and whatever else. So that will apply to everything that is anticholinergic. And then if you have anticholinergic, you have opposite as cholinergic. So if it is a cholinergic, that is your OPC. And so the antidote is going to be atropine and the pupils are going to constrict. And this one, well, that one was dry, so this one is going to be wet. So there will be excessive urination, there will be diarrhea, there will be diaphoresis, and so on and so forth. So there's some simple things to remember. You should remember all stimulants will stimulate this, everything in the system, and depressant will depress everything. So give you a general idea, but that's not enough. So you must always have helpline, you know, whether you are in KBC or whether you are in real life situation. These are some of the helplines that you can use. Hinduja Poison helpline is available, I believe, from 8 a.m. to 7 p.m. and these are the numbers. They are very useful. They will not only give you right information for uncommon substances. AIMS had helpline supposed to be 24/7. I haven't used them. And the other two are mentioned in the SDG, which also I have not used. But we are in the Atmanirbhar area, right? So we need to be Atmanirbhar. And so it's a good idea that apart from keeping antidotes in the emergency room, make sure you have one good toxicology book, preferably an Indian author and an edition. Because if you have the foreign authors, they won't have Datura and camphor and neem oil written on it. And those are the ones you will be struggling. We have now diagnosed that this is a child with poisoning. So how do you manage them? So first, of course, is 4 steps in managing: rapid assessment, stabilization, decontamination, and finally looking at a specific antidote. Let me tell you, the last one is least important. We always question antidote as the most important thing, but in most poisoning, antidotes have a very limited role. And as I will explain to you in subsequent slides, decontamination also has very limited role. I'm not going to talk about rapid assessment and stabilization because you all are very good at it already and it's not poison specific. When you look at decontamination, I'm going to put a disclaimer. First of all, I want to ask you, how many of you have seen an activated charcoal? Correct? So I'm not even asking used, I'm saying seen. So that is as limited a role of decontamination that it has. It's good to know. So the cardinal rule is meticulous supportive care. That means rapid assessment and stabilization is what you're going to do. Decontamination plays a very limited role and has very few indications. Ipecac induced emesis, a standard gastric lavage, and cathartics are not to be used in most of the circumstances. Activated charcoal and whole bowel irrigation are potential in very few cases, which I will try and elucidate in next few slides. So activated charcoal is not like any other charcoal tablet. That's a specially treated charcoal substance which increases its surface area multifold, and it allows the adsorption of certain toxins, metals, toxins and other substances. Preferably used within 1 hour. If you want to remember 1 to 2 grams per kg, you are free to do so. Otherwise, 25 grams below 6, 50 grams or above 6 should be useful. And there are few areas where you don't use it. I'm not spending too much time reading those slides because believe me, the moment you walk out of this room, you will forget them. At least I can't remember them. So important to know what are the standard of use and principles rather than knowing the specifics. When you talk about whole bowel irrigation, you use a PEG solution, use 500 ml per hour and keep using it till the effluent is clear. It usually can take 4 to 6 hours. And again, very, very limited role. Use it if more than 2 hours have passed since ingestion, or if you are dealing with sustained release tablets or formulations, okay, because then there will be a delayed excretion, which you have time to throw them out. Next one is what we call enhancing elimination. And that means you can use multiple dose activated charcoal. Again, limited use of urinary alkalination only in barbiturate poisoning or sometimes in salicylates. But in critical care situation, in ICU and in severe cases, you can take help of your nephrologist and critical care people to use hemodialysis or continuous venovenous hemodialysis, etc. Next, we come to antidotes. So these are some of the common household poisons and the antidotes for the same. But as I said earlier, you should keep at least these in your ED, in your emergency room. Also, if you see, some poisons can be an antidote and some antidotes can become poisons. So if you keep ethanol in your ED, you can use it before you have an issue with somebody with poison. And for acid poisoning, you should keep alkali. Am I right? No, please don't. Okay, that's why I put it in red. Never use an alkali for acid because it just sounds logical, which is not. So because it generates heat of neutralization and will further damage the skin. So only water or dilution or saline should be used for that. So what do you keep in the ED? You keep antidotes, you keep pediatric specific resuscitation equipment, and this is extremely important for our multi-speciality hospitals because the ED is totally prepared and oriented towards adults, and we have to really struggle hard to have pediatric things over there. These are some of the common poisonings that we see. And in next few slides, I will just tell you what is important for each one of them, not all of them, at least some of them. But before that, I'm sure all of you get multiple phone calls where you say, okay, don't worry about this one. My child has eaten toothpaste. When I tell him to eat, he does not. But when I don't tell him, he goes out and eat it. So there are things like soaps and shampoos, which usually are not a problem. Unless exposure to eyes, then you have to take care of it. Crayons, just make sure they're aniline free, then there won't be a problem. Most newer and good company crayons are. Inks in reasonable quantity is safe. Air freshener blocks, nail polish removers, matchsticks, all of them are safe simply because they are never consumed in large quantities. Okay, they just appear to be dreadful, but usually they are not. So whenever you think about household poisonings, you can think under these criteria where you can see them. So if you're preparing something or studying, if you take hydrocarbons, it will be kerosene, petrol, spirit, etc. Most common toxicity is aspiration related, and you have to take care of respiratory symptoms, usually delayed after a few hours. No lavage, no charcoal. If needed, respiratory support may be required. Important alert is there can be delayed changes on the X-ray. So don't do X-ray at the onset. Wait for a few hours, see if there is chemical pneumonitis, and then think about it. Same way, if you have acid or alkali corrosives, think about corrosive injury to eyes, airways, or GI mucosa. Again, no lavage, no charcoal, no NG insertions, and local decontamination should be paid attention to. Naphthalene balls look interesting, looks like one of the edible tasty items, and children tend to put them in the mouth. Problem, especially in G6PD deficient patients, you can use methylene blue if the methemoglobin levels are high. Important to see is the last line, is the second one which I put, SpO2 PaO2 mismatch. So you do that SpO2, you may not pick up a problem when the child is looking blue because methemoglobin doesn't get picked up on your standard pulse oximeter. Okay, and not all of you will have a special machine to differentiate the two. Very small lethal dose for G6PD patients. And we have to remember that newborns and fetus, though not deficient, they will not have enough G6PD activity in their RBC and behave like G6PD deficient. Bleach exposure, again, treat like a corrosive poison. And if you have eucalyptus oil exposure, think about local irritation and CNS depression. Again, if you see, only symptomatic treatment. So far we have seen 4 different exposures and we haven't even talked about antidotes or hardly ever talked about even lavage or decontamination. So that's where I'm coming, that's what I'm coming to. Neem oil exposure can be if there is mosquito repellent or antiseptic preparation. Again, symptomatic treatment and CNS depression to be looked at. This is one area which I am very, very bothered with, and that is button batteries. Believe me or not, you may have handled more button batteries than coins in real life after the digital payment. So you should make sure that your kids don't get exposed to it. Some interesting facts. Button batteries, newer ones are more dangerous than the used and the old ones because typically button batteries don't corrode in the system. It's the potential difference between of the electrode that gives rise to the burn injury. So newer or more powerful are more dangerous. If they're in nose or the esophagus, immediate removal is recommended. If it's in the stomach, it's debatable, but you can even ask for removal from there. Beyond pylorus, you will have to monitor and take care of that. On the X-ray, if you are not sure that this is a coin or a button battery, if you see double rim shadow, then it's most likely a button battery. And if it's a single rim, then you think about a coin, because a coin is going to be much less threatening compared to this. And so it's important to know. It's also important, some studies have said that if there's going to be a delay and button battery sitting in the esophagus, you can give the child honey, because honey is a very poor conductor of electricity. And if it coats this button battery, the chance of injury to the esophagus is going to be delayed. So we are not saying just give honey and sit on it, but till you get a surgeon to remove it, you can use that. I actively tell my patients not to buy this. And if you have bought this, make sure that you dispose it and not give it to anybody else. These are small magnet toys which are made out of neodymium, which is a non-ionic magnets. They are extremely strong. They are very small, pellet-like, and kids like to play with them. They are called so-called de-stressors, but they are a major stress to system. A single one is not a bother. But imagine there are two beads and they pinch the mucosa, then they will not move anywhere further and they will cause avascularity and gangrene, and you will have to end up removing them. Again, we said about camphor. Camphor is an important poison because, again, like naphthalene ball, very small amount is required to give rise to symptoms. CNS symptoms and seizures are the potential complication. If you get a history of rat poisoning, make sure that you get a picture, because what it says, I'm not promoting either of them, by the way, but the one on the other side, mortine, that is called, that has vitamin, it has warfarin, and so your antidote is going to be vitamin K, I'm so sorry. And the other one has phosphorus containing poison, and so the management is going to be different. Some of the dangerous places, if you found poisoning, are medicine cabinet, because that contains, again, substances which in very small quantity can be dangerous for small children. Once you have managed this child properly, when do you discharge them? So if the child was stable to start with, most of them you can be discharged after 4 to 6 hours in your emergency room or ward if there are no new symptoms, and if they have not consumed anything that has extended release formulation. If there has been delayed action or long half-life of the substance, then wait for 24 hours. If the patient is unstable, then of course you are in the PICU. And before you discharge, make sure you educate the parents to make sure how do you prevent this from happening. So always make sure that all dangerous stuff, including medicines, are out of reach and out of sight of children. Make sure there are safety locks when there are toddlers in the house. Always keep in their original containers and do not interchange. Label clearly if you put it in a new bottle or a box. Return items to a safe place after use, because majority of the poisonings happen when that particular substance is in use. So if you remove something from the cabinet, it's lying on your table and you have gone to do some other work, there's a chance that the kid will pick it up and have a go at it. Also important to educate children and the caretakers to prevent poisoning and discard old and rarely used items. Remember to do a medico-legal intimation, especially if you are dealing with non-accidental injuries and if you are thinking of intentional or suicidal cases. Of course, all of us talk about do no harm or first do no harm. And so as I mentioned earlier, acid antidote is not alkali, and NG insertion in corrosive ingestion should be definitely avoided. Do not do lavage in kerosene or any aromatic or solvent poisonings. This I'm not spoken here, but I thought this is important message. So do not put tourniquet in snake bite as it is commonly advised. And no MSS should be attempted, especially in button battery cases, because remember that esophagus is at least a safer place than trachea. So you don't want anything going there. Pets are family too. So though we are pediatricians and not veterinarians, we remember that things which are interesting for children can be dangerous for pets. So when we talk about household poisoning and we consider pet as our family, make sure that these things are out of reach for the pets. Finally, please do read standard treatment guidelines, not just for poisoning in children, but many of them which have come in last few months. They are really good information material. And remember, poisons fortunately don't taste good, and so the consumption is small. Prevention is the best cure. Any emergency where you don't have a definitive diagnosis, consider poisoning. Supportive care is mainstay and not decontamination or antidote. Make your ED poisoning ready and use a lifeline to save a life of the patient as well as yours. These are some of the lifelines which I have said earlier. I'm putting it on again. Thank you for your time and patience here.
Thank you, sir, for a good informative lecture. Thank you.
Thank you, Dr. Tushar Maniar, sir, for very informative session, sir. Please. I request Dr. Jayeshi Suryavanshi ma'am and Tanaji Kanade sir to felicitate Dr. Tushar Maniar, sir. I request Dr. Atul Dashputre sir to please come on stage to felicitate our chairpersons. I request sir to please felicitate Dr. Tanaji Kanade sir. I request sir to felicitate Dr. Jayeshi Suryavanshi madam.
Let's move on to our next session. I request the most charming personality and a beauty with brains, our own Dr. Shamila Kulkarni, to come upon the stage to moderate the panel discussion on pubertal problems in office practice. I request Dr. Sanjay Joshi, Dr. Tushar Godbole, Dr. Shilpa Aroskar, and Dr. Jayant Joshi to join the discussion. Welcome, ma'am. Puberty is not only coming of age, but the most drastic and evolutionary change in the life of a boy or a girl. As much as it is welcome with the avid anticipation, it turns out to be a body and soul shaking decade of our life, where not only we change by inches and centimeters, but the entire being changes by leaps and bounds. Everyone knows the famous Marathi song, "16व वर्ष धोक्याचं ग, बाई 16व वर्ष धोक्याचं." As a pediatrician and a mother of a teenage son, I am aware of how difficult it is to handle these pubertal issues. Be it is a physical change, emotional mood swings, or a social adjustment. Everything becomes a roller coaster ride for everyone. I request Dr. Shamila ma'am to conduct the session and help us to deal with this dhoka of roller coaster ride of puberty. Please, ma'am.
Thank you, Amruta. So good afternoon, friends. So after a very practical and excellent talk on household poisonings, we move to another Okay, so let us move to another important and a very common topic, and that is pubertal problems in office practice. So before we start, I'd like to introduce our eminent faculty. So let me introduce the witty, versatile women of Vashi, Dr. Shilpa Roskar, the dynamic doctor from Dhule, Dr. Sanjay Joshi, the polished pediatrician from Pune, Dr. Dr. Joshi Jayant, and our very own highly knowledgeable endocrinologist from Nasik, Dr. Tushar Godbole. So friends, we are seeing an increasing trend of puberty related problems in the last 2 or 3 decades. We all know that. Many times we see a child, a girl child, 8 to 9 years of age coming with menarche. And so many times it's happened that we loosely label them as early maturity. Or we sometimes see a boy, a young boy with a small penis, and we easily reassure the parents that don't worry, it will grow along with the child. Don't we do that? And is it right? What should we ideally be doing in these cases? Now with the changing scenarios, we have to know when to stop counseling and when to start investigating. And more important, when to stop treating and start referring this child to an expert. And for that, we have a faculty with us which is going to answer all these questions which come to our mind when an early adolescent with a puberty problem comes to us. So we all know that puberty is a physical transition that occurs during adolescence. It is a transition from sexual immaturity to a sexual maturity. And there is an earlier trend in pubertal timing and over the years. And in fact, the Copenhagen study has shown that thelarchy comes 1 year early for every 10 years. So is the case with menarche. Every 4 months, the menarche comes earlier every 4 months. So my first question, I'll start with the lady. What is the accepted age of the onset of puberty today? Because we have to know that.
So Sharmila, for girls, it is 8 to 13 years, and for boys, it is 9 to 14 years.
Absolutely. So we have to, this is probably the first and the most important message we are getting, that any child who comes with signs of puberty before 8 years in girls, we have to be careful, and boys, it is 9 years. And delayed puberty is 13 in girls and 14 in boys, right? So we know that normal puberty comes between 8 and 13. Some girls get puberty at 8 or 9 or 10. So what triggers the onset of puberty, Dr. Tushar?
So, frankly, we are still understanding the factors, but then amongst the factors, one is the leptin reserve. So if you reach a particular weight cutoff, for example, let's say 27, 28 kilos, your body sends out a signal called as leptin, and that leptin goes in the hypothalamus and triggers a chemical called as kisspeptin, and that kiss in fact starts the puberty. So, there are multiple factors, but the important one is the body weight.
Absolutely. So another good take-home message that obesity, BMI is the one which causes early puberty. So dear friends, as pediatricians, we should see that our patients do not have prepubertal obesity. So that is what we can tell them about nutrition to the mothers. So we all know that puberty is not a single, we switch on the button and the puberty starts. So it's not a single event, but it is a sequence of events which occurs over a period of 4 to 5 years. And therefore, there has to be an order to it. So, Dr. Shilpa, what is the order of events? This is important because for diagnosing, we will need to know the sequence of events. What are the events?
So in girls, it's very easy to remember TPM. So thelarchy usually by 9 to 10 years, pubarchy by 10 to 11 years, and menarche by 11 to 12 years. In boys, usually by 9 years, we start seeing, increase in the testicular volume. And after that, pubic hair, facial hair, increase in the penile length, followed by a height spurt. And usually by 13 to 14 years, we do expect a spermachy and strength spurt also.
Right. So with this short introduction to normal puberty, let us go to see some few cases which we see commonly in our OPDs. So this is the first case. This is for you, Dr. Jain Joshi. 9-year-old female has come to our OPD with unilateral breast nodule. Parents are worried. What will you do?
See, first and foremost thing, as Dr. Shilpa mentioned, that this can be the onset of puberty. And as we said that thelarchy is the initial stage. So it could be perfectly normal feature. You could have a unilateral enlargement to begin with, and maybe over a period of time, the other breast will also grow. So I think as a pediatrician, I would just reassure the parents and observe. Of course, I'll do a clinical examination just to ascertain whether it is a breast nodule or whether it is something else. Suppose, for example, I am dealing with a lipomastia. Suppose it is only a fat tissue. Of course, this child seems to be quite lean. So obviously it is not related to that. But then if there is any inflammatory process or any, even for that matter, even a neoplasm has to be thought of in this case. So in routine case, probably it looks like a perfectly normal thing. And I would just reassure the parents.
Yeah, so the faculty...
Sorry, just one point.
Yeah, sure.
If at all something to investigate, I may just go with the ultrasound.
Okay.
That can be very informative.
Okay, so a point taken. Generally, this is in children who are not very obese. We don't think of lipomastia, especially this is unilateral. And here, many times they complain of pain. Yeah. So do we treat it or just reassure them?
No, it all depends upon the extent of pain. If the pain is bearable, you just assure them. If it is something which is exquisitely tender and you have some signs of inflammation around, then of course one thinks of other possibilities like an infection.
Okay, so does thelarchy start unilaterally in all girls, or this is a rare finding?
No, generally, probably it will start equally, symmetrically, but then you can have features like this coming up. So there can be some distribution. The exact percentage is not known, but you can have unilateral.
Yeah, Dr. Tushar?
So not just in girls, but in boys also we see gynecomastia. So that's the breast development in boys. So it could start unilaterally in almost 40% of them. Oh, wow. And there may be a discrepancy, like one side will show up and maybe it may take 6 months to 1 year for the other side to show up. So people have done FNACs, people have, consulted surgeons to take a biopsy, but one should know that 9-year-old girl, the breast is growing, so you just give it time. And secondly, the tenderness is because the body wants you to protect that organ. So the pain has been given to protect. So similarly, the testicles also are painful as they grow. So the tenderness is just when somebody touches it. So at rest, it does not hurt. So no treatment required.
Right. So a good take-home message. So as Dr. Tushar said, unilaterality is also seen in boys. And again, on the first presentation, he shows a unilateral breast lump, and after 1 year, it is gone. So friends, the take-home message here is thelarchy may begin unilaterally in nearly 40% of girls. So you have to just reassure them. The other breast starts growing within 4 to 6 months and can grow up to 1 year. Generally, no treatment is required except reassurance. Okay, so this is another girl. Now, this is a 7-year-old female child, and she has now thelarchy. So, bilateral breast enlargement. Dr. Sanjay Joshi, this child has a normal height velocity, SMR is stage 3, and no additional concerns. So, like the other previous case, should I say this is normal and leave it? Do you think this is precocious puberty? What is your take?
First thing is, before, as just we have seen that the puberty, the age for puberty is 8 to 13 years. Now, this is a 7-year-old girl. And in addition to that, the height velocity is normal. There are no other sexual development. The SMR stage is stage 3. So there are no additional concerns. So this looks to be a premature thelarchy. The line.
Absolutely. So this is idiopathic premature thelarchy. So what are the main concerns? You just said that
2-3 concerns are there. First, first and most important is the parents, especially the mother comes and says, "Ki doctor aata pali kadi yeil." She's very much concerned about that. So first and most important is reassure, because there is no other treatment, but you have to reassure and ask them to come for a regular follow-up. Now, two important things, whether there is growth spurt. If there is an acceleration of the growth and there are additional secondary sexual characters are developing, then this is something to worry. Then usually no investigations are needed, but at most you can do a bone age and a baseline sonography you can be done. Refer if the patient usually don't need referral, but there are some red flag signs. So what are the red flag signs? First is if there is a growth acceleration.
I think we'll come to that a little later. So before we go to the bone scan, that
Just to highlight a point that here lies the importance of plotting the growth chart. So if a child is being seen by you over the years and you see a sudden spurt, so that's the whole importance of having a growth chart plotted here.
Absolutely. So we did a bone scan in this child, and Dr. Tushar, very often we do a bone scan. I actually don't know how to do it. So I have a question for you. Why do you do it only on the left hand? That is one. And how do we read it?
Yeah. So bone age is the concept where you are rating the maturity of the bones. So when we see a 7-year-old girl, we believe and expect that the bones are also of a 7-year-old maturity. But when the puberty is happening early or late, or if there are any associated comorbidities, the bones may show accelerated growth or retarded growth. For example, in this particular case of 7-year-old with thelarchy, so if she's really producing estrogen, that estrogen will drive the bone's maturity ahead, and you can see those changes happening in the epiphysis. So why left hand? Because it's a convention followed worldwide. Why hand? So why hand? Because we also do this for height prediction, and people say ki lambai to legs ki बढ़ती है, हाथ का X-ray क्यों करना है? So because there are 20 bones that we can see, score. So you actually go and score those 20 bones. There are methods like Tanner-Whitehouse 3 or Grillich-Pyle Atlas, where you are comparing the maturation of those epiphyses, and by that you get a rough age of the patient, which is called as the bone age.
Right. So I think what I learned from this is that reading the bone age on the X-ray is an expert interpretation and needs the help of an expert with the help of the Tanner-Whitehouse 3 methods, and as you said, the Pyle Atlas. So I think we'll leave it to you to read the bone age. And generally, Dr. Tushar, when such a child comes with early thelarchy and we say this is normal, how do they progress? Do they all land up with precocious puberty, or they have a normal growth after that?
So this particular girl who is 7-year-old and showing some signs of thelarchy, as Dr. Sanjay has rightly pointed out, many of them may not progress into true puberty, but you need a follow-up. Some of them will be the aggressive forms of puberty where the rapidity is there. So you are safe in this case to just wait and watch. But by wait and watch, I mean, don't give a blanket statement, kuch nahi hai, ghar jao. That's not the way. We should say that yes, breast development is there, but not everybody lands up into true puberty. So we'll keep them under follow-up.
So you wait and you watch. What do you watch for? For the red flag signs. Dr. Sanjay Joshi.
So usually we say that there are 5 red flag signs. First and important is the early and progressive signs of secondary sexual maturation. So in addition to the thelarchy, observe or keep a close follow-up for other sexual signs. Second, accelerated growth. So as Jayant said, if you have the previous growth chart and you can notify that there is an accelerated growth, then that is the second thing. Third, as bone age. Fourth, there are important thing that there are some other findings, like for example, the patient has an additional CNS finding, like there is a headache, or there are visual disturbances, or there is pain in abdomen, or some capsular spots, so or pigmentation. So these are the things. Then we have, these are the red flag signs, and then we should refer them to the other thing.
Absolutely.
Another one thing is if it is a contrasexual. Many times usually it is said that if it is the secondary sexual characters are according to as per the same sex, then and if it is on the other sex, like if suppose there's a male child and he is developing the breast, then that's a contrasexual thing. Then that is another red flag sign. So if you have these 5 red flag signs, then it is better that we refer them to.
Absolutely. So very important to remember the red flag signs, because that is how we are going to clinically pick up precocious puberty. Dr. Shilpa, once I have a patient and I feel that this child has precocious puberty, the first question which comes to mind is, how do I differentiate between central precocious puberty and peripheral precocity? So can you tell us in a simple way with a very few investigations? I stay in Nasik, I cannot afford to do a lot of investigations. So how do you do that?
There are some differences between central precocious puberty and precocious puberty. The commonest thing, actually, one thing is central precocious puberty is more commoner in our practice as compared to the peripheral precocious puberty. But the most important thing is that both of them have accelerated growth. But the important point is that the normal sequence, as we have just said, the normal sequence of getting secondary sexual character is PPM in girls. So first is thelarchy, then is pubarchy, and then is last is menarche. But sometimes if it's if this normal sequence is preserved, is maintained, then it is central precocious puberty. But sometimes you can get, especially some syndrome like McCune-Albright or some syndrome, you can get a menarche earlier, or you can get thelarchy and menarche at the same time. So there is a deviation from the normal sequence. And if there's a deviation from the normal sequence, one should suspect whether it is a peripheral precocious
Absolutely.
puberty.
So very simply, if there is a accelerated growth with normal sequence and a raised LH or FH, think of central precocious puberty. If there is an accelerated growth with or without deviation and low FHS and LH, think of peripheral precocity. Very, very simple. So now we come to the next case. This is a child of precocious puberty, 9-year-old. Dr. Shilpa, this child has thelarchy at 7.5 years, pubarchy at 8 years. So definitely an accelerated growth. What is it? Central or peripheral?
The key here is that the USG is normal, the sonography is normal, so it goes in favor of central.
Absolutely. So this was an idiopathic central precocious puberty. In girls, most of the time when it is a central precocious puberty, 80% it is idiopathic in girls, while 80% boys you will get a pathological cause. So Dr. Tushar, once we have a child with central precocious puberty, I have a few questions straight away. One, in this child, is it necessary that I treat her? What happens if I don't treat her? And in this child, we didn't treat her. So did we miss the bus?
So retrospectively, we are wise. So today she is 9-year-old, already is menarchal for 6 months. So I believe she has received, enough counseling from the mother or the teachers. And now she is, if she is ready to handle her menses, she has been counseled well, and we have reasonably ruled out any underlying comorbidities, then probably at this juncture, I will not treat her. Had I seen her maybe a year ago or 2 years ago, I would have definitely considered treatment, because the girl is, at that time still not menarchal, and I have the facility or provision to treat these girls safely and effectively. Another point that I wanted to make is, what will happen if I don't treat? So when the thelarchy psychosocial aspects are the one part of it, that the girl is not ready to handle the menses in the school, she is unable to change the pads in the school. That's one part of it, which is extremely important. The another one is, if the thelarchy has started before 6 years of age, then the likelihood of having underlying pathology such as intracranial some SOL is very high. So if this thelarchy would have started a year earlier, I would have, even though we are not treating here, I would have still documented an MRI for this case. Secondly, if we would have seen her a year ago or 2 years ago, we would have probably treated her and given her the benefit.
Okay. So basically, the important thing is you have to look into the age of the child, the rate of progression of the secondary sexual characteristic, the height velocities, and if there are any CNS symptoms. That is important. So the goal of treatment is to slow down puberty progression, increase the final height, and decrease the stress. So we go to another, this is actually
One,
Yeah,
I
sure.
wanted to add, Sharmila, was that I think for general pediatrician, the most important thing, whenever we see early changes, thelarchy or anything, it's extremely important to make the parents understand that regular follow-up and compliance is very, very important. Like in this patient, 6 months, that gap of
Absolutely.
not following up, and that got missed out.
In
because
fact, that
would
is
have changed.
exactly the point I was going to make. In COVID, this is an article which shows that there has been 5 times more cases of precocious puberty in the last 2 years because of COVID. What happens is they didn't come to us, or this child came very late to us. So it's very important that we educate the patients in the pre-pubertal period to look for thelarchy, to look for pubarchy. So, Dr. Jayant, this was an article which I read. Why were we seeing so many cases in COVID? In short.
Yeah, this was actually an article published by Dr. Vaman Khadilkar and his team from Pune. And it was a very informative article because they found out about 200 cases and over a period of those COVID interval. And there were some interesting observations. Number one, there was an increased incidence of central precocious puberty, and the associations they postulated were, besides the standard ones like obesity, which was expected because there were inactivity at home, and second, possibly a vitamin D deficiency. These two correlates they put. Third, very interesting thing was an exposure to sanitizers. The hand sanitizers we all used during COVID times seem to contain a chemical called as triclosan, and it's supposed to stimulate the puberty. So that was also one postulation which was putting across. So all these are, of course, under trial. They're not confirmed, but this was a very good informative paper. And that's why through COVID, we have learned a lot of things. Before we proceed, I just want to ask one question to Tushar. Suppose I have parents who are informed about the use of GnRH analogs. A child is 9-year-old. And she has started menarche, it's her first cycle. And they have heard from somewhere that there are medications available to prolong. Should I advise them to go ahead for that? Will it help?
Well, we need to sit down with the parents and discuss the pros and cons of the treatment. Now, the pros of treatment at 9 years, and after I have seen her after the first periods, so she is in shock, trauma, probably she's not counseled. So we may still offer the treatment when she comes to me at the first menses. But please remember that after starting with the menses, when you are starting the treatment for precocious puberty, what happens is when you give them injections like GnRH analogs, they don't act overnight. So when I say that the girl has started with her menses, that means her uterus is well grown, like an adult female or an adolescent female. So after giving those injections, it takes time, at least couple of months, for the GnRH to act, the FSH-LH to come down, the estrogen to come down, and for the ovaries and the uterus to go back to the prepubertal state. In between, she's going to bleed. In between, she's going to bleed irregularly. To prevent that, we still give something called as depomedroxyprogesterone as an injection or oral medicines. But then it's always better to pick them up early before the menses have already started. But we may consider after she comes with one cycle. Just one quick point before we move away from the precocious puberty. There was a mention about normal ultrasound. So the pediatrician was intelligent enough. He or she asked for an ultrasound. The ultrasound was reported as normal. But what do we mean by normal? So when a radiologist who is tuned to seeing adult USGs, he will see that the uterus is like 5.5 centimeters, the ovaries are 3 centimeters normal. But is that ovary of 3 ml size or uterus of 5 centimeters, is it normal for a 7-year or 8-year? So when you're seeing a report of normal ultrasound, please go and ask your radiologist, have you compared those volumes with the pediatric controls? So just don't go blindly by normal ultrasound.
When you send the patient for ultrasound, mention the age, mention your diagnosis, and ask him what to look for, right?
And also for the bone age, send it to a radiologist who knows how to read the atlas of bone age.
Absolutely. Or in Nasik, send it to Dr. Tushar. Okay, so take-home message is thelarchy before 8th birthday warrants evaluation. Growth charts, bone age, and USG pelvis are usually the only investigations that are needed. Isolated thelarchy needs only close follow-ups, and rapidly progressive puberty needs urgent evaluation. So let's move on to a spotter for the audience. 5-year vaginal bleeding, large cafe au lait, large ovarian cysts. What's this? Absolutely. This is McCune albite, deviated sequence, peripheral precocity. So the next case I'll ask Dr. Jayan. This is a 13-year-old male with bilateral breast enlargement. Of course, it's a gynecomastia. How would you go about managing this child?
Now, gynecomastia per se can have various causes. The most important ones we know about are physiological ones. In pubertal period also, boys can have gynecomastia because there can be an override or imbalance between the secretions of the male and the estrogen hormones. So if there is a little over secretion of estrogen, you can have gynecomastia, which can be even unilateral at times. It is quite embarrassing, obviously, but if the child has got a good growth progression, probably I would just reassure this child at this juncture. A gynecomastia probably of this nature would disappear over a period of 1 or 2 years. So I think all I will do tell them is just to observe, and we will see, of course, for the follow-up and for any signs which are otherwise developing.
Absolutely. So in obesity, the common cause is lipomastia, but in this child, it is an idiopathic pubertal gynecomastia. Dr. Tushar, any drugs can be used to treat this boys?
So there are drugs like selective estrogen receptor modulators, and there are drugs like aromatase inhibitors. So they are sometimes used. So in this case, if the size is very big, tender, lasting beyond 6 months, if the size is beyond 4 centimeters, and you have reasonably ruled out any comorbidities like any tumor or any Klinefelter syndrome, so the height velocity is normal and you have ruled out any other things, then one may consider drugs like tamoxifen citrate or letrozole.
Okay, so generally wherever you see red flags, only then you think of medical line of treatment, right? So the next case, again a 9-year-old male with a small penis. Dr. Sanjay Joshi, what is a normal length of the penis at this age?
It is very interesting. When I was also not knowing, when I started reading regarding this, like growth charts are available for standard deviation for penile length also. So ideally they say that if the length of the penis is less than 2.5 standard deviation below the normal, then it is called as micropenis. But these charts are available only.
No, in this child, 9-year-old, what is the normal expected?
9-year-old boy, usually the penile length is between 4.8 to 5.2 centimeters.
Okay, so this is the child.
Yeah.
Would you call this micropenis?
This is one of the very common thing which we come across in our practice की एक आई आणि आजी किंवा बाबा ते एकदम जाड असलेल्या मुलाला घेऊन येतात and they say that this is a short penile length. हे काय करायचं याचं? So this is a very common thing.
So what is the commonest
is
cause?
Is it really micropenis? This is usually a buried penis. So how will you diagnose? It's very simple. That is called as SPL. That is stretched penile length. Stretched penile length is a very simple thing that we can do in our OPD. That how it is measured? You take a ruler or a wooden measure, hold it in your left hand, and at the base of the ruler or the base of the wooden measure should be at the pubic tubercle, and with the right hand you hold the shaft of the penis and gently stretch the non-erectile penis and measure the tip of the glans to the base. That is actually the stretched penile length. It is said that at the time of birth, the normal length is between 3.3 to 3.5 centimeter, and if it is less than 2 centimeter, it's called as micropenis in newborn. In this picture, actually, it is actually.
I'm just going to ask you, what is wrong in this picture?
The wrong thing is that they have hold the prepuce and not the glans. So ideally, one should hold the shaft of the penis, gently stretch it and measure the tip of the penis to the base of the penis. So that is a micropenis.
Absolutely.
And such charts are available, and you can go into the charts and see whether it is less than 2.5 standard deviation. But on an average, it is said that at 9 years, it is the length is between 4.8 to 5.2, and if it is less than 4 centimeter, it is called as micropenis.
Absolutely. So again, the take-home message here is that we do have to see for the penile length in suspected cases of micropenis. As Dr. Tushar said, we may miss important syndromes like Klinefelter syndrome. So this is some which while reading up, I just noticed that the mean age Klinefelter's has to be picked up at birth or in the first 6 months of life, but the mean age of diagnosis is 30 years. And what is the reason? See the developmental stages. In neonates, they have micropenis, which we miss. 1 to 12 years, they come with some learning disabilities, which again is missed. And 13 to 18, again, they come with gynecomastia. And we just said that 1/3 of boys have gynecomastia. So these are the boys which get picked up in adulthood when they land up with infertility. So friends, the take-home message here is pubertal gynecomastia is common in boys and needs only reassurance and weight loss. Micropenis should ideally be evaluated early in life, within the first 6 months during the mini puberty. Tall stature, learning difficulties, gynecomastia, and micropenis. Always think of Klinefelter syndrome. Okay, so we go to the next part of it, and that is problems about menstruation. Many times the mothers come with so many problems. Dr. Shilpa, my first question to you. Child has come with thelarchy and mother is very worried. When will her period start? Very quick answers.
Usually by 4 years, 3 to 4 years, it should start.
Okay. So,
or 10th birthday.
Okay. So generally 2 to 3 years after thelarchy, it should start. And this period of 2 to 3 years between thelarchy and menarche is very important to achieve maximum growth potential of the child. Is it true that child does not gain height after menarche?
This is the most common question asked.
Yes.
And the answer is the height doesn't stop growing, but probably it grows less, on an average, maybe 7 to 8 centimeter in the 2 years after menarche.
So of course, the height does grow and we can make use of this. About 5 to 7 centimeters after menarche, the height can grow. Yes, Dr. Joshi.
Yeah, but the spurt definitely doesn't come. So if you have a menarche, the growth spurt which we expect with a growing age will not come. There will be some deceleration. There will be some growth, but one cannot expect a growth beyond 5 to 6 centimeters.
When the menarche comes little earlier on.
Yes.
Yes. The third question, and what is the lowest age? Very important question according to me. What is the lowest age at which menarche can be considered normal? Dr. Tushar.
See, the lowest age one can expect is, of course, as we mentioned about the puberty development, it can be even 8 to 13 years.
No, we want to give some take-home messages.
Okay. I think after post-COVID, we are seeing a lot of girls getting it early. The average age, what we are familiar about is 10 to 11 years.
10th birthday.
10 years is something which is acceptable.
The 10th birthday, keep it in your mind. 10th birthday, if the child has menarche before the 10th birthday, you have to follow up and you have to investigate. You may have to investigate. Okay, abnormal uterine bleeding, very commonly seen. Girls get menorrhagia, metrorrhagia, and they usually miss out on school. So what is the most likely cause here, Dr. Shilpa?
So first 2 years, we all know that the cycles are anovulatory. So, and it just settles on its own. So we did not do anything, just need counseling, look for anemia, look into the hemoglobin. And, but after 2 years, if it persists, then we can think of other causes. We need to look for thyroid. We also need to look for bleeding disorders. So we asked the mother, if she had similar episodes or if the child had recurrent epistaxis. Or we also look for any pelvic infections or other kind of pathology, and definitely thyroid also. And if yes, then after 2 years, yes, we do evaluate. And OC pills, definitely no in the first 2 years. And after that, if required, we usually stick to progesterone.
So you can stabilize the cycles with progesterone, but please do not use estrogens in these children. So, Dr. Tushar, when should we refer such patients to a gynec? Is there a need, or we can manage them on our own?
So, as correctly pointed out by Dr. Shilpa, that initial couple of years, you can definitely wait. Let it settle down. The hypogonadopituitary, the pituitary ovarian axis is still getting settled down. But of course, if the cycles are getting too much, frequently, every 15 days, if the girl is bleeding, or if the bleeds are getting prolonged, then one may consider progesterone only pills as an intervention. And there you may take help of your OBGYN colleague.
Absolutely. So again, the take-home messages here is menarche before the 10th birthday should be investigated. The phase between thelarchy and menarche is very important to maximize the growth. Counseling and reassuring is enough in most cases of AUB. Organic pathology should be ruled out. This is very important in a most logical and cost-effective way. And in puberty menorrhagia, that is menorrhagia which lasts beyond 3-4 years and is very severe, always think of bleeding disorders.
And also, if at all you have to give a combined OC pill, there are pills that are available with a very ultra low dose of estrogen. These girls are still in their teens, they are still growing. If you give high dose of estradiol, their epiphysis is going to get fused instantly. So if you give high dose, combined OC pill, adult one, they will just stop growing. In fact, sometimes we give adult OC pill when you want them to, stop growing.
Right.
So there are low dose pills that we can use.
Usually we give, plain progesterone.
Yeah, so I think the thing is give plain progesterone if at all you have to control the bleeding and try to avoid estrogens. So we try to cover up the common pubertal problems which come to us in our office practice. Now we have a very short session of rapid fire.
Is there a gift hamper?
Hi. Pardon?
Is there a gift hamper for the rapid fire?
No, Sharmila, just one point. I mean, like, do we treat, if some girl is getting a puberty menorrhagia, do we treat her symptomatically by giving other medicines like, say, tap pause or something?
Yeah, you can do that.
Okay, thank you.
Also, some of them might have endometriosis and even pelvic pathology. So that is the time then we send away to the gynecs, I think.
Okay, fine. So all ready for the rapid fire?
Gift hamper.
Okay. Right. So the first question, Jayant. Boys will do anything to improve their body image. When can they go to gym and what about protein powders? One line.
Very controversial issue. I think it should be done after the puberty is achieved. So I think not definitely before the age of 16. The body structure, the body forms are different. If someone is really into serious bodybuilding, he should consult a specialist and understand the form of body. Either he is a mesomorphic or exomorphic, and then accordingly go for that. Protein powder probably would be strictly recommended under a guideline, not to be recommended blanket, not like you buy Bonvita or Complan. So definitely not a recommendation for any child. But then protein powders, you can have full protein diet is a good idea.
Right. So let them go to the gym after epiphyseal closures and take natural proteins from home. Dr. Sanjay, this child has lethargy, excessive sleep, poor concentration, irritability and headache. What is your diagnosis here? Commonest.
This is very common thing. आपल्या ओपीडी मध्ये आपण बरेच बघतो की डॉक्टर हिला दिवसभर झोपतच राहते, शाळेत पण लक्ष लागत नाही. This is very common thing, and if you ask in detail, she definitely many times she has menorrhagia. So this is definitely anemia of puberty or anemia of adolescence.
Absolutely.
There are many factors like increased demands, insufficient iron intake, then faulty diet, social causes, menstrual bleeding, which is more than 80 ml per cycle. So these are the very common things which are very obvious.
Right. So one question I want to ask you here, that we see anemia in puberty very commonly, nearly 80 to 90%. Why don't we start hematinics in all adolescent girls? Do you recommend it?
Actually, I have seen so many studies, and there is a famous study by National Nutrition, and which suggests that they have found out the prevalence as high as 39%. Then there is another study which were National Social Community Study, which said that it was as high as 87%.
Absolutely.
And we just heard Phadke Madam about Anemia Mukta Bharat, so AMB. So I think it is, in my opinion, all of them should be given.
Yeah, so at least we should
And
start
in all class, even in a corporate class of patients that we
Absolutely.
cater to
So
these
it should be
things.
high up in our mind. We should really do screening of adolescent girls if they look anemic and start hematinics.
No harm in doing a hemogram and a
Absolutely.
basic peripheral smear just to rule out that they are not THAL carriers.
So Dr. Tushar, what is this?
Necklace.
So I fondly call this as Japamala. But this is not Japamala. This is called as Prader's
I would
orchidometer.
prefer it if you say that it is some, we are wearing such good saris, they can use it as a necklace.
Yeah, so this is called as Prader's orchidometer. So orchidometer is used as a OPD tool to assess the testicular volume. In girls, you have the clinical clue as the thelarchy as the first sign of puberty, but whereas in boys, you don't have any apparent clue. The boy is not going to tell you that my testicular volume is now 4.5 ml. So if you are interested in having an adolescent practice, or you want to assess the Tanner staging, you must have this tool in your OPD where you make that boy lie down and compare the testicular volume with the beads. And these beads give you a number like 2 ml, 3 ml, 5
Can see
ml,
the
6 ml.
numbers
Yeah.
in that. Yeah, so Tushar, you said if you are an adolescent specialist, now I am a generalist. Should I be monitoring the testicular length at least once in adolescent boys?
Yeah, I believe all of us are pediatricians, and the definition of pediatrics by Juvenile Justice Act 2015 is until 18. So we are all, capable of monitoring the puberty, and all of us should at least check their testicular volume on their 10th birthday, at
Okay.
least once. Yeah.
So 10th birthday, we have
That's a
got
good
2
message.
take-home messages. Menarche before 10th birthday, be careful, and testicular volume in boys on their 10th birthday, right? Fine. Next question. Girls in metro cities are using these creams and they are abundantly available. If you go on Google Auntie, you will see abundant, more than 50 such creams available there in the market. So Dr. Shilpa, what do these products contain and would you recommend its use?
So most of the time they contain estrogens, and some of them also contain, they claim that they are non-estrogenic and they contain herbal products, but I'm sure that those herbal products somewhere might be triggering, and increasing the estrogen this. So absolutely no. And believe me, this is very, very common, and in fact, I had a patient where the domestic helper who was living in their house for 24 hours was using this for months, and they had got her to me.
Right.
So
yeah, so one of the common herbal product which is used in these creams is hops, and this hops contains hormonally active herbs, and it is very notorious in causing precocious puberty. Girls are using these creams left and right. So as pediatricians, we should really ask our adolescent girls not to make use of
It
these.
is actually, it is said to be the one of the commonest cause of peripheral precocious puberty.
Absolutely, I agree with you. The next question, Dr. Jayant. Fairness creams. Such ads are very commonly seen on TV.
Tumalaska, you are using it, I think.
So they really look tempting, but I agree. You see one girl adds brown, white, and then suddenly she is fair. So very, very tempting for boys and girls both. So why would you not endorse its use?
See, there are two things. Number one, your skin color is genetically fixed. So probably no matter whatever attempts you make to conceal it, your skin color is going to have the same amount of melanin. All the fairness creams basically are sunscreens. They will protect you from sunlight and they will reduce the production of melanin. Once in a while, suppose you are going on a beach and you are trying to protect your skin from the harshness of sunlight, is fair. But for fairness cream to be effective over a long time, they will at the most give you maximum 20% effect in your fairness. Second thing is that most of them can be dangerous because they can have some ingredients over a period of time, or if you do it in excess, probably it is going to make your skin sensitive. Second thing, it is going to have a blocking effect on the skin, which can worsen the conditions like acne. So all these things have to be kept in mind. The skin becomes thin and sometimes it can cause other hypersensitivity reactions.
Absolutely. So actually, the sunscreen lotions and the fairness creams may differ, and they do contain estrogens. This is a article which I picked up on the net, Indian Journal of Ophthalmology. My daughter gave it to me. Intractable steroid-induced glaucoma. So it has very, very notorious effects. So please avoid these fairness creams in boys.
The men can be reassured that women like tall, dark men.
Yes. Okay, so now, Dr. Shilpa, till what age would you wait before evaluating a case of delayed puberty in a girl? You just read all this and tell me one answer.
It has to be 4, all of the above.
Absolutely. So absence of thelarchy by 13 years, absence of menarche till 15 years, absence of menarche till 4 years after thelarchy. Child has thelarchy and 4 years she has not had menarche. All this fits into delayed puberty. Why I have put this slide? Because we have not taken a case of delayed puberty because of lack of time. So all the above are the reasons or the causes of or definitions of delayed puberty. So my last rapid fire, actually, what is this, Dr. Sanjay?
You can see the excessive hair growth there. This is hypertrichosis. By definition, hypertrichosis is excessive hair growth on all parts of the body. And then naturally, a question comes whether what is hirsutism. So hirsutism is excessive growth on the androgen dependent area. So that's the difference. Now the question comes is असे बरेच पालक येतात की डॉक्टर आता काय करायचं याच्या पुढे काय करायचं. So the reassurance is one thing, but I think if the child is getting mentally disturbed, then I think we should go ahead with.
I was just going to ask you, a child of 10-year-old comes to you and asks you, I want to remove my hair on my face. So one question, would you recommend? Second, what type, which is the safest hair removal method?
There are various methods, but it is said that laser is supposed to be the best method. What I say की त्या मुलीला मी तिच्याशी बोलतो की ती म्हणते सगळे माझ्याकडे वर्गातले सगळे लोक सारखे सारखे बघत राहतात आणि मला फार ऑकवर्ड होतं. I think that is the right indication.
In fact, I just remembered once you said that Dr. Kanikar once told me, if you turn around and look at the girl twice, she needs a hair removal. And the best and the safest method of hair removal still is laser. Right. So friends, with this, we end our topic. And actually, there are problems galore with adolescent children. And this picture sums up the troubled puberty. This child is still innocent within, but growing up outwardly. It sometimes can get difficult for them to handle the profound changes of puberty. And so, friends, it is totally up to us as their pediatricians to understand them, to give them time, to listen to them, and to lead them to the safe shore. Thank you so much. Thank you, panelists. Thank you for your patient listening.
That was a wonderful lecture. Absolutely lively lecture, ma'am. Not even a single minute I got distracted from the screen. I request Dr. Praful Patel sir to felicitate Dr. Sharmila Kulkarni. Thank you, sir. Thank you, ma'am. I request Dr. Sharmila Kulkarni to felicitate our all four eminent speakers. Dr. Shilpa Aroska, ma'am. Dr. Sanjay Joshi, sir. Dr. Jayant Joshi. And Dr. Tushar Godbole. Thank you, ma'am. Thank you. I request all Nasik IIP females please be in the hall. If anyone outside, please call them inside. I request all Nasik IIP females. All beautiful girls in a sari, please call them, call them. Just come.
And we'll start immediately.
Chalo, we shall move to our next session. For this session, I call on stage chairpersons, Dr. Jagdish Dekne, senior pediatrician from Pune, to come on stage, please. Next, I call on stage Dr. Vibha Komawar ma'am, senior pediatrician, as a chairperson of the session. I also request Speaker of the session, Dr. Sanjay Ghorpade, to please come on stage. All matters of the heart are to be handled with care. And if it is a sick heart, then you multiply that care by 10 times. Literally speaking, myocarditis means inflammation of cardiac muscle. It goes without saying, it is an emergency of an highest order. In the intensive care setup, it may not be very difficult to manage such cases, provided we are equipped with all the equipments, medication, assistance, and above all, the knowledge to handle this emergency with utmost care and diligence. I request Dr. Sanjay Ghorpade to take us on express journey.
Good afternoon, everybody. First of all, I am thankful to organizing committee for inviting me to be here for this MAHAPEDICON, a big annual event of this MAHA-IAP. And with the permission of chair, I'll start my talk. See, whenever this topic was given to me, I was quite surprised in front of the presentation, like Dr. Jagdish Dekne sir, is quite senior. Why the topic has been chosen to me? Because I am a pediatrician, I am a pediatric intensivist, I am the ID specialist. Then I thought that yes, initially these cases are lined up with us, and subsequently these cases are referred by us to a certain pediatric cardiologist, and at periphery, there may not be a cardiologist which we will be dealing with all these cases. So initially we have to deal with cases, we have to stabilize the patient, we have to come to a conclusion, we have to manage the case, and if required can be transferred to a higher center. I think with the view of our chairperson, Madam Dr. Sharmila Madam, definitely I will give justice to my topic because I have taken a lot of references, lot of expert opinions over this topic. So straightway going to this case proper. This is a 9 months male child brought with a history of fever 15 days. 15 days back, not now. Puffiness over face since 3 days. Breathlessness since 2 days. Not accepting feeding since 1 day. History of vomiting 1 day and looking pale 2 days. In this part of history, whenever we are looking at this part of history, certain important things are there. And this point actually I am a little bit confused why suddenly baby becomes pale. So whenever I examine this baby in the emergency room, definitely baby was pale, febrile, there was tachycardia, there was tachypnea, extremities were cold, that means definitely baby was in a cold shock. Eyelid puffiness was there, periorbital edema and hepatomegaly, and heart sound soft, and this word stuck up me, that gallop. So whenever such things are there in our UG, PG, we know that we are the clinicians rather than at that time there were no facility of investigations. So definitely we pick up that this could be a myocarditis. Definitely heart failure is number one. Possibility, if history is acute, what could the cause of the congestive cardiac failure or heart failure? We must go on to digging the case. And this was a, yes, this was a video of this baby. As baby was too bad, immediately we intubated, airway secured, and we have managed this with protocol of the ABC, airway, breathing, circulation, treatment of shock and all the things. But definitely there was a puffiness and there was a hepatomegaly also. As the baby was too critical, we were not in position to think. But definitely in any case of the PISU, which is coming in the shock, the management protocol little bit same, that yes, initial 10 ml per kg bolus, you can start 9 drops and evaluate whether it is a cardiac or non-cardiac. and depends upon your protocol will be. Accordingly, we stabilize this baby and subsequently X-ray was taken. This was X-ray. And this was X-ray taken in emergency room. By the time we intubated baby, the X-ray came and there was a big cardiomegaly. Whenever such a things are there, definitely the first thing in our mind is definitely this could be a myocarditis or this could be a cardiac condition leading to all these things. So friends, whenever we are going for searching of the myocarditis, which are the reasons? N number of reasons are there. There may be viruses, bacterial, fungal, protozoal, autoantigens and hypersensitivity, etc. But whenever we are going to the common conditions, definitely see adenovirus is one common condition where you are getting the cases of the myocarditis more as compared to the rest of the things. I was searching through the literature. Does the dengue can cause the myocarditis? Because this is a common case and common disease we are managing our day-to-day practice. Answer is yes. Yes, because dengue can cause myocarditis. And if it is, it may be a very severe with a poor LV function. And patient can land up with the hypotension and shock. There may be sinus node dysfunction and arrhythmias also. So coming to the clinical features, if it depends upon age of presentation. If neonates, there may be just poor appetite, fever, lethargy like a presentation. But if it is an infant or adolescent, the presentation may be little bit different. Just now I presented like a history of low-grade fever, pallor, then signs of the heart failure, everything will be there. And accordingly, our management will be. Now here our focus will little bit change as compared to the pediatric workup, what we are doing in the day-to-day practice. Here I am highlighting or I will highlight only the specific investigation what we are interested. See, whenever we are considering this as a cardiac injury, definitely this is the most important part, that is a troponin. And famously called as TNT and CPKMB, out of which is more specific. Of course, TNT is more specific. And if there is increase in the TNT, definitely this suggests that there is a myocardial injury, and see the specificity almost to the tune of 83%. That's why TNT is one prognostic marker. But nowadays, bedside, many cardiologists doing this popular investigation that is called as NT-proBNP. What it suggests? It will not suggest the myocardial injury. It suggests only the whether your patient is in heart failure or not. But to support that specific investigation, TNT you have to go for. And of course, for the viral etiology and all the things, definitely you go for the viral serology and PCR, etc. These are certain newer markers that is called as tumor necrotic factors. These suggest that a poor prognosis of the disease. Of course, electrocardiogram, all of us know that PR depression, Q waves, ST segment, everybody knows with the low QRS complexes. And chest X-ray already, I have shown that this definitely cardiomegaly with the chest congestion and all the things. Echocardiography, what it will help? Yes, it will suggest the ejection fraction. LV ejection fraction is always low, but whenever RV ejection fraction is low, definitely that has got a poor prognosis. Apart from that, echo will know that whether there is a structural damage or whether there is a real myocarditis. And of course, cardiac MRI, which is a non-invasive investigation, and that is now become more popular in the investigation part of the myocarditis. Intracellular and interstitial edema, hyperemia, capillary leakages, necrosis, and fibrosis, etc. can be picked up, and see the accuracy is up to tune of the 78%. This endomyocardial biopsy, this is just academic purpose, and this can be done only in the institutional part. In the private practice, it's very difficult and tough to do all these things, and especially in the fulminant cases of myocarditis, unexplained new onset of the congestive heart failure. Yes, in that case, in certain cases, it can be kept as a reserve investigations. Now coming to my topic proper, why I have given the overview? Unless another you know the overview, the management protocol will not be proper. That's why ABC I have already discussed that as per the IPLS protocol, you stabilize the patient. I will not go into detail of ABC. From here, I want little bit specific focus on the treatment part. Now, heart failure treatment in our college days, we used to use digoxin. Where is digoxin? No. See, in the treatment of the heart failure, now the drugs are AC inhibitors. That is a captopril and enalapril. The doses already you know, you go through the books. But apart from that, yes, introduction of the beta blockers such as bisoprolol, metoprolol, etc. can be combined with AC inhibitor, which have got additional effect. Now, third part, once your patient becomes stable, when the beta blockers can be used, once the patient becomes stable, these are the two new drugs which are used by the cardiologist. That is called the ARNI, that is an angiotensin receptor neprilysin inhibitor, what it does LV remodeling and it increases the pumping of the LV part of the heart. Like the same thing that dapagliflozin is a sodium co-transporter. Actually, this drug is an anti-diabetic drug, especially this can be used to decrease the glucose level, but here this can be used in cardiac pace for the left ventricular remodeling. That's why whenever we are discussing the drugs, yes, these are certain newer things we must know as a pediatrician, and of course from the cardiologist we can take the guidance how to use these drugs. What is the role of digoxin? See, it is in red mark. That means digoxin should be used with caution only in low doses in patients with the viral myocarditis. It has not been removed yet, but it should be used in a caution, and definitely that is the important part whenever you are using the digoxin. Now, coming to the antiviral therapy. Any antiviral therapy is useful? I went to lot of literatures. The answer is data in human being is not that much available, number one. Number two, certain single case studies are there, like the single case study series of the antiviral therapy such as the ribavirin, actually used but not that much effective. In certain literature, they have used the interferon B. In that case, little bit improvement in the left ventricular ejection fraction. But whenever in general, you are talking about the use of the antiviral, answer is no. Yes, in myocarditis, first is the definitely treatment of heart failure. Antiviral therapy, answer is no. Now, this is the most important part and this you must focus on. Yes, immunosuppressive therapy, it has a role and evidence suggests that yes, it must be used whenever you are treating a case of myocarditis. And prednisolone is a drug of choice. You can load with the 2 mg per kg, then subsequently you can taper up to 0.3 mg per kg, and it reduces the myocardial inflammation, improves cardiac function. Of course, relapse in some patients after discontinuation can be there, but yes, there is a role of the steroids and definitely beneficial in treating the patients even in the chronic cases of the dilated cardiomyopathy like that. Prednisolone should be given for at least 3 months duration and subsequently can be tapered, and definitely see that there is an improvement in the ejection fraction up to more than 40%. So there is a definitely role of the steroids in cases of the myocarditis. Now, role of IVIG. This is one debatable topic I want to touch upon. How are the trials and what the various Cochrane data analysis says that no randomized controlled trials in children at present. Whatever trials about IVIG are that are in adult, and case here is shown that use of IVIG high dose improved left ventricle function and better survival, especially 1 or 2, like the certain studies are there saying that yes, if you are using the early, yes, there is a benefit in children. That's why routine use of IVIG is not recommended by adult physicians and consider only in an acute phase of the disease. Like the Kawasaki, if it is used early, best result. If you are using late, once disability happens, morbidity happens, it will not recover. That's why if you want to use IVIG, it should be used early. That means intravenous IVIG in severe acute myocarditis in children in high dose 2 gram per kg, yes, there is documented some benefit and definitely improvement in the left ventricular ejection fraction. Same literature shows that yes, in case of fulminant myocarditis also, if it is been used early, there is a little benefit, not too much benefit in the improvement of the disease. So friends, in general, whenever we are talking about the population in pediatrics, whether I should give IVIG or not, what the literature says that? Yes, literature says that IVIG in the treatment of acute myocarditis in pediatric population improved recovery of the left ventricular function, better survival rate in the first year. That's why coming to a conclusion that IVIG in pediatrics in the early stage, yes, you can use in a day-to-day practice. But once there is a development of dilated cardiomyopathy, no. That means if you want to use IVIG, it should be early, because once there is development of dilated cardiomyopathy, there is no improvement in ejection fraction of the heart. In the lupus myocarditis, it is a collagen vascular disorder. Of course, there is a definitely role of the IVIG is there, and in these cases, definitely the IVIG will be beneficial if that myocarditis is because of the connective tissue disorder like a lupus myocarditis. Touching upon the part of COVID-19, what the cases we face in COVID-19, that is definitely MISC. The presentation may be shock or features of Kawasaki and cardiac dysfunction. Yes, As per the protocol, yes, IVIG was the first, steroids second, biological therapy third, and fourth was anti-thrombotic therapy. All we have observed and we have practiced in day-to-day practice in the last 2 years in the COVID pandemic. And definitely in cases of shock, the first will be steroids and then IVIG. In the moderate cases, first will be IVIG, then steroids. This should be protocol, must be followed in our day-to-day practice. Antiarrhythmic treatment, yes, there is will be benefit of anti-arrhythmic treatment in myocarditis, and certain cases may require temporary or permanent pacemakers also. And defibrillation, everything will be should be a standby, and in the chronic cases may require cardiac transplantation. So friends, in general, whenever we are summarizing the protocol of the management of the myocarditis, yes, stabilization is first, and definitely diuretics and vasodilator will be first thing. If patient is stable, definitely you can shift to the ACE inhibitor and beta blocker and subsequent follow up with the ejection fraction. If there is no response, definitely inotropes, then balloon pumps. If no response, you can go for the immune therapy, just we have discussed with the steroids, other therapy, etc. And the last resort will be the cardiac transplant and ECMO, everything will be. So when you're coming to the future trends, what is a new thing in myocarditis? Yes, this is the one SF that is called as antiviral drugs. They have tried in certain cases, and there is a CYP3A expression regulation will be there. That is, it will be used like a immunomodulator, same like a cetirizine. They have tried in certain cases with a certain beneficial effects in myocarditis. They have tried in antihepatitis like valsartan. These are cases where they will be beneficial in the myocarditis due to the Coxsackie virus. That's a various drugs they have tried. Certain cases they have tried as antiviral drugs, certain cases they have tried antihypertensive, certain cases they have tried as anti-diabetic drugs, and plus minus benefits will be there, but the future will tell that what is the exact we should go ahead. And about the physical activity, definitely restriction of physical activity must be there. And prognosis, this is a important sentence, and I was also surprised with the reading this sentence. The fulminant myocarditis excellent long-term prognosis. What is by that? That means if you are treating in the fulminant case or acute severe myocarditis in the initial part aggressively, definitely prognosis will be best. Once there will be development of the disability, the dilated cardiomyopathy, prognosis will be worst. So your action should be too fast, and definitely that will require a lot of kids in our day-to-day practice. I think this is all from me as a pediatrician. Hope so. I have given justice to my topic. Thank you. Thank you very much.
Hello, thank you, Sanjay. I think it was a wonderful, a review of myocarditis for a general pediatrician. And you started with a very important case, and it's very important to think of a patient who comes with breathlessness and a tachycardia. And I think with a viral illness, some of them do get it. It's an important thing that which we might miss in our busy practice. And I think you highlighted the management very well, and the role of IVIG, steroids, and the long-term prognosis that you told. I think it was overall a very interesting session, very elaborate and a detailed session. Thank you so much, Sanjay.
Yeah. Any questions? Okay. Thank you. Thank you very much.
I would like to request Dr. Jagdish Dekne sir to felicitate Dr. Sanjay Ghorpade sir. Next in this session, we have lecture on 7 rights of highly effective pedicodes. For this, I request Dr. Pramod Zog sir to come on stage. Topic of this session to be addressed by Dr. Pramod Zog on rights of effective pedicodes. So far as I understand, it is related to conduct of a pediatrician about and with his patient and their parents on one hand, and thoroughness of his knowledge conveying his knowledge to his client on the other. I do not know whether I am right myself. So I invite Dr. Pramod Zog sir to tell us about 7 rights of effective pedicures.
थँक्यू. प्रोग्राम या हॉलमधला बऱ्यापैकी प्रिपोन झालेला आहे, त्यामुळे आपल्याकडे भरपूर वेळ आहे, त्यामुळे शांतपणे ऐका. आणि 7 राईट्स ऑफ हायली इफेक्टिव्ह पेडिकोज. पेडिकोज म्हणजे पिडियाट्रिशियन्स. बरं, हॉलमध्ये मराठी समजत नाही असं कोण आहे? ठीक आहे, सगळ्यांना समजते. कारण मागे मी एकदा लेक्चरमध्ये असं विचारलं की मराठी कोणाला समजत नाही त्यांनी हात वर करा, तेव्हा 4 लोकांनी हात वर केले. म्हणलं लेका तुला प्रश्न कळला म्हणजे मराठी समजते ना, नाही का? तर त्यामुळे हात तर कोणी काय वर केला नाही. एनिवे दॅट्स फाईन. ओके, तर राईट शब्दामध्ये अर्थातच जोक स्टाईलनी बरेच चेंजेस केलेत, म्हणून त्याला असा रेड कलर दिलेला आहे. तुम्ही प्रत्येकाने आपापल्या पद्धतीने नंतर विचार करा. See, you can see that the degrees of Dr. Zog include GRP, which stands for Grassroot Pediatrician. L stands for Lifelong Learner. DHDP stands for Diploma in Handling Difficult Parents, particularly from Pune. And FOTC stands for Father of 2 Children. Yatli ekhi degree official nahi, but then you should remember that these are very important degrees in the life of a pediatrician. So when I passed out my MD, I got first D, that was the degree. Okay. So Dr. Zog became Dr. Pramod Zog, MD Pediatrics. So that was the first D, that was the degree. Okay. Then I started rather getting money, and that's why there was another D with me, and that was dollars, that was money. Okay. Then I got married and I got the dear one. So that was the third D. Okay. And then the central D. Okay. Dr. Zog became the 4th D, and that was donkey. Okay. All the childlike qualities which I had tough time to manage them. Remember, every one of us has childlike qualities. Okay. And those childlike qualities which are there right from our birth, like somebody might be good at painting, somebody might be good at dancing, somebody might be good at playing tennis or whatever it is. And over a period, these qualities, they start getting suppressed, and the child which is within us slowly starts dying off, which is the tragedy of life. Okay. And that is why we need to maintain those childlike qualities. I recently met one of my friends, Kishore, and he is a pathologist in Pune. And when I met him, he of course had lost all the hair, he had a pot belly, and he appeared with a face which had no smile at all. I said, Kishore, what happened? Why are you looking like this? He said, Pramod, what should I tell you? My children are abroad. I have enough money in the cupboard to spend my life without any problem. So I could sense that there was a tinge of frustration in what he was speaking. And then probably I thought that I should speak to my friends about what I think about certain right things in life. Okay. So remember that these 4 Ds are very important. And the first thing that you must use rightly is the right brain. Okay. When I started my practice long back, there was another pediatrician who was practicing by my side. He was very senior and he had a huge OPD. So I was looking at him that how can I get a practice like him? Okay. And then he had a board outside where it was written entrance. So of course people would enter from that clinic, from that area. Then I used my right brain. And then I put another board in front of my entrance saying main entrance. When I wrote main entrance, people thought this is entrance, this is main entrance, let us go this way. And then slowly and gradually people started coming from the main entrance. Of course, I did not know as to whether, and still I do not know whether he knew as to Dr. Zog's trick what it was. But then what I'm trying to tell you is that when you start a practice, do not follow the lines of your guru. Many of us, like to follow the role model. Don't do that. Use your right brain. You have a right brain. But unfortunately, in our education system, we have only been taught to use the left brain. So 1 + 1 is equal to 2. Match the pairs, fill in the blanks, pass your 10th, 11th or 12th standard. At my time, it was different. So we become doctors by the use of only the left brain. But the right brain remains like this. And it is said that 10% of our brain is only used in the lifetime. 90% of our entire brain goes unused. And our complaints of the patients in front of us, except for the super specialists in the audience, they are usually the same: fever, cough, cold, pain in abdomen, vomiting, diarrhea, convulsion, febrile convulsion, constipation, khatam. Again, constipation, pain in abdomen, vomiting, fever, same. So what is there? So it's natural that you are going to get bored. Let us accept that practicality in the life. And, let us not be, what I may say, conformists. There is a word called conformists, means almost 90% in this world are conformists. What my seniors did, I will follow that. Very few are the ones who do what they like. Okay, so be on your own. Do not be conformists. Anyway, so remember to use the right brain. In fact, in my clinic, in the waiting room, I have created a play area using my right brain, giving different sorts of crayons and card papers and others, so that children play there. Okay, the purpose is that the child will go home and tell mother, I want to go to that doctor, who has that play area. Okay, so of course I will get more patients. I celebrate the 6-month completion birthday in the OPD. Why 6 months? Because that is the important point in the life of the child, when complementary feeding starts and so on and so forth. And 1 year birthday, everybody celebrates. So here I celebrate 6th birthday, because by the end of 6 months, the idea is almost most of the vaccines are over. And between 6 to 9, it is very difficult to maintain the, your clientage, isn't it? So they will come at 6 months. Okay. Anyway, so some of these are things. So except for Jagan, I don't see anybody from Pune. So I can tell some of the tricks here. Okay. Of course, he has his own way of practicing, and he is a very rational and a good pediatrician. Anyway, so when you enter into the clinic, the entry of the clinic also should be right. Okay. Never paint your name board. Okay. 2 things in life, except for women, never paint. One is, of course, the hair. So keep as gray as possible, because it reflects your experience. Okay. And do not paint the board. The rusted board is always taken with lot of experience. Okay. If you put a new board which is nicely painted, people will say, "Ye to naya doctor dikh raha hai," so they won't come to you. So never paint these 2 things if you want to increase your practice. Okay. Of course, the patient enters inside, and then ambience. Ambience is a French word. The pronunciation is not ambience, it is ambience. Okay. And then you have to see that you display all the good things that you do in the society, display all the medals that you won all throughout. Now today also one of the medals will be presented to me by the organizers. So it will go in the showcase there. Okay. So that people will know that this fellow to whom we have brought our child is an authentic person. Otherwise, they have no way to understand that Dr. Jog stood first in FIBSC, first and got gold medal at MD, and so on and so forth. There is no way. So the only way to increase your authenticity, to display your medals. Of course, some of my colleagues might be thinking, I never speak, I never get any medal. So what do I do? Don't worry, outside there now available at 200 or 250 rupees. And nobody looks at the bottom, what is written. Nobody writes that presented by MAHAPEDICON on 18th of November 2022. You put it at a little height, display 10 or 15. It increases your authenticity. Of course, once I told some of my colleagues that you display some of these things like that. And unfortunately, he had displayed some medals very much in front of the view, where it was written first in dancing in 3rd standard, first in football in 7th standard. Don't do that. Don't make it very obvious. Utna to right brain use karna zaruri hai. Remember, that is very important. So the ambience is important, and also keep it very clean and neat and tidy. People don't like that in the clinic, the rats are running from here and there. There are cobwebs at the corner. So use that particular methodic way, okay, and display all the good things which are done by you on the notice board. Like, if you write some good article in the newspaper, put it there. If you participate in a health camp, please see that the newspaper clipping is put up there. Of course, if there is some consumer protection case going against you and your name has been printed, don't put it. Otherwise, you will put it with pride that a case is going on against you. Don't do that. Anyway, then in the life, one more right is meeting right people who are positive and good. So that is PGs. PGs are always, remember, positive and good. Never keep a company of negative people. Okay. Negative people are like acid fast bacilli. They will infect you and chronically infect you. So you will have tough time living with them. So as soon as you go back to your home on Monday morning, see which of the staff members is negative. Okay. Because otherwise, I have seen so many nursing staff also. They do not have the way. At the bottom, you can see I have written nursing staff how to talk. अरे तो डेंग्यूचा पेशंट होता ना त्याला रक्ताच्या उलट्या झाला आणि मेला. Now, if somebody says to a patient coming to you for fever for 3-4 days, who is going to come to you, isn't it? So see that people speak properly. Now there are coaching classes for even staff nurses where you can train them as to how to speak. Very important, okay? And there are some stars in the life. Parents, father and mother, they are the ones who, make up your personality. Preachers, they are the teachers, okay? And the peers, these are the friends, okay? Remember that the word friend has some alphabets and each one has a meaning. With whom you make friendship, he should be frank, he should be rational, he should be intelligent, he could be of either sex, and he should be a non-doctor. Remember that. Never have friendship in the morning, at least, with doctor. All doctors are our friends. But in the morning when I go for a brisk walk, the people with whom I walk, one of them is a milkman, one of them is a chartered accountant, one is an engineer, one is a lawyer. Okay, so all of them give their general knowledge to me. Now you will ask me why that milkman? Recently he told me as to how to maintain the quality of the milk same by adding extra water also. Okay, so he increases my knowledge every day and different people. So otherwise if you keep friendship with your pediatrician colleagues, ते काय बोलणार असेल काल 10 पेशंट आले आज 15 येतील उद्या 20 येतील स्लॅक चाललाय तेच बोलत बस. So don't keep, at least don't waste your early morning hours. Remember, like the tap of water, the energy is highest in the morning when you get up till 10 o'clock. Important works are all to be finished before 10 or 11. Okay, all other things like seeing patients and all later. Okay, okay, I am just joking. And then remember, for people, there is a boss who is also a right people. What is a boss? That is BV, obstetrician, sister-in-law, and SAS. Okay, so these are your real bosses. Okay, and the reception is also has to be right. Never appoint hypothyroid receptionist. Otherwise, your life will be doomed. Okay, you will have to do the same work twice. So select them, pay them little extra. भरपूर पैसे मिळत आहेत वॅक्सिनेशन मधनं इकडून तिकडून जरा खर्च करा. ओके, 1000 रुपये जास्त द्या, you will get better people. Okay, and appoint good people so that your life is good. Okay, and also see that there is something like emotional quotient which you should always try to increase. So in case if they want a holiday, please sanction it. If she says that I want to go for some vacation, please see that the receptionist gets an off. Okay, if there is a birthday of your ward boy, Aya, or somebody, celebrate it. Cut a nice cake and give the remaining cake back to her so that she can enjoy with the family. Don't take it back to your house. Okay, so remember that all these are important things which should be done at the reception counter. And the receptionist also, as I said, should always have a normal head circumference. Okay, that means her intelligence quotient should be normal. Okay, unfortunately our colleagues, they look at other circumferences, so please don't do that. Anyway, then you should have a right clinical approach in a proper equipped cabin. Okay, remember, the poorest of the poor patient will understand as to whether Dr. Joga has examined my child properly or no. Okay, so use everything. Wear a nice apron. Okay, all the pockets. In one you should keep an horoscope, in one fundoscope, a hammer, a stethoscope. You should appear like a very good doctor, and then it will impress the parents to a great extent. Many of us just go casually to the clinic. Don't do that. Wear proper clothes, just as I worn today, a tie, nice blazer. You need not wear a blazer. And women should use good saris. Many women I have seen, they use a dress. But then usually I have seen the mentality of Indian parents is that they like women with a sari. Okay, nice Calcutta saris are also not very costly, but then you can use them. They give a very I would say a mature look. Okay, these are strictly personal opinions, and then you can follow if you want. So rightly dressed, and remember, this is important. And then the prescription also should be a right prescription. Okay, we do not have any way to advertise ourselves, isn't it? We cannot advertise in the daily newspaper that your child had diarrhea. Okay, come to Dr. Joe. Okay, yeah. Now this timer should be rather stopped because we are running before time, isn't it? Okay. If it is okay, because anyway, we will continue. In case if there is any real crunch of time, you tell me here. Tarun, is it necessary that we stop earlier? I can continue now. Okay, that's fine. So because the session has already started before it was supposed to start. So I said I will just take a liberty, and our people may not get an opportunity to listen to the learned speaker again. Okay. I'm just joking because you're all my good friends. Okay. So remember that in the prescription, you have to write at the top of the prescription allergic to something like amoxicillin, ibuprofen. You write it at the top of the prescription. Okay. And it is very important. And note down the seriousness, note down the diagnosis. If you really do not know the diagnosis, then write down IDK. That is, of course, I don't know, or GOK, God only knows. Okay. Because patients won't understand what you have written. Of course, when I started writing it, very often the sister said that this Dr. Jog is writing IDK or GOK for all patients. What is this? So I did not tell her the meaning of the last short form, and that is DUR, that is diagnosis under revision. Okay. So it may be revised after 3 days. Okay. Okay. And then of course at the bottom you have to put SNDT, that is signature, name, date and time. Okay. And then also remember, some of our seniors, they used to write I treat, he cures. He means the God. Okay. So I have treated, but he could not cure. That is not my fault. Okay. And if you have a pocket full of money or dollars, see that you are able to pay someone to sit in front of you, preferably a DCH or a DNB if you are busy in practice. So that, it's an indirect control on what you're writing. Okay. Otherwise, you write the diagnosis as viral and underneath you are giving amoxicillin. So it doesn't fit with the diagnosis, isn't it? So please see that you have some indirect check on what you're doing. Of course, there are some slides related to rational use of antipyretics. Diarrhea. This is something which you must say. Shraddha or Saburi. Almost all the diarrheas are viral. 90%. So just tell that this is again, I treat, he cures. So viral diarrhea means, self-limiting diarrhea means he cures. Okay. So after 7 days, because we don't know who cures diarrhea after 7 days. That is he, isn't it? Okay. And then the cough mixtures, some academic information that you should not use the combinations and, of expectorants and suppressants. And then there are some mixtures which are of doubtful benefit. And then the combinations of cough medications with nasal decongestants are not of proven benefit. Also remember that the combinations of cough medications with antihistaminics may be rational in certain situations, but still it would be better to prescribe individually. And the combinations of cough syrups and antihistaminics with antipyretics, 3 together, they are absolutely irrational because the dosages of antipyretics become confusing or unnecessary. And as regards the decision of using antibiotics and the infant milk formula, you have to be very, very careful. Most of us are infected with HIV, and that is habit, ignorance, and variety of other factors. As to Khushwant Singh was once asked as to when does he drink? He said, I drink only on 2 occasions. One when it is raining, one when it is not raining. Means I drink on all occasions. Similarly, Dr. Jog is asked, when do you write antibiotics? When the child has fever and when he doesn't have fever. That means I write antibiotics on all occasions, isn't it? So out of habit. Many obstetricians have a habit of writing ampicillin, gentamicin for every child born with seizure. Irrational, isn't it? So remove those habits. Also attend MAHAPEDICON and Pedicon regularly so that your ignorance is removed, because many of us behave like Hanuman pediatricians. Hanuman was asked to bring the entire, medication for unconscious Lakshmana. He brought entire Dronagiri because he did not know which is cefixime, which is cefodoxime, nothing. And that's why don't behave like Hanuman pediatricians. Remove that ignorance by bringing new editions of Nelson. Right now, 21st edition is going on. Okay. Otherwise, the bookseller may sell 16th edition to you because he knows that you don't know which edition is going on, isn't it? Okay. And then variety of other factors. Anyway, and then prescribe the right antimicrobial, the right drug, right dose, right route, right duration. Have an intelligent choice. Never use BL-BLI combination, that is beta-lactam, beta-lactamase inhibitor combinations unnecessarily. Where amoxicillin is useful, use only amoxicillin in 40 mg per kg. Cefixime for enteric fever, not cefixime with clavulanic acid. Metronidazole for amoebiasis is not required because less than 2% children under the age of 5 have amoebiasis and giardiasis. So most of these academic points you should be aware of, okay? Remember that only few combinations are approved like amoxiclav, ampicillin, and piperacillin, tazobactam and others. While the ones on the right side are nonsense combinations, particularly, as I said, cefpodoxime, clavulanic acid, cefotaxime, sulbactam, so on and so forth, because they are pharmacologically incompatible, or they lack studies, or they have a limitation of the spectrum of the parent beta lactam. Okay. And there are some situations which are called as shake hand situations. Particularly in the morning, we discussed that when a child has leaky nose, that is runny nose, leaky gut, that is watery diarrhea, and wheezy child, these are all situations where you should not write antibiotics. Okay. For the want of time, I may not elaborate more about instructions, but then counseling is very important. Whenever a child is brought, you know that it is more or less viral. So tell the parents, the first sentence should be don't worry. When you say don't worry, when Dr. Jog says don't worry, when the gray-haired pediatrician says don't worry, they are really relieved, because every parent coming to you is under great tension. Number 2 sentence should be, this is viral. Number 3 sentence, it is self-limiting and will take, be all right within 3 or 5 or 7 days. Okay. And that is why the 4th sentence should be antibiotics are not required. And then these are the red flags. So these 5 things should automatically come in most of the children who come to us with diarrhea, which is of viral origin. And then when you find your colleague's prescription, never comment about it. Okay. There are different ways of communication: verbal, non-verbal, then physical. Verbal means pediatrician doesn't know anything. Of course, you should never say that. Non-verbal means just, either giving wrinkles or what a dirty prescription it is, not saying, but showing by face. And, crumpling his prescription and throwing in the corner is the physical way of showing that it's a dirty prescription. But don't do that, because you are also at the other end of the situation. Sometime or the other, you will face the music. Okay. And also have a look at the cost of prescription. Remember, where amoxicillin is useful, it will cost 40 rupees, but amoxiclav, if not necessary, will unnecessarily cost 100 or 110 or 120 rupees. However, do not compromise on the cheaper brands. And as I always say, look at the Mangal Sutra of the Hindu Indian woman. In case if there is only black thread in the neck, please waive off your charges. Okay. Give her samples which you have and see that they do not have tears in the eye. The good pediatrician should always have the ability to see the unseen tears. Okay. Many times when you tell your consulting charges, suppose they are 500, many of them they cannot afford and they really do not cry, but the facial expressions change, and that's why you should have the ability to understand that there are tears which are not seen because they openly cannot cry. But then you should have the ability to understand at least after a certain practice. Okay. And then with every prescription, you should give 3 things free of cost. One is a smile on the face. Okay. Many of the pediatricians, they simply don't smile. Okay. A small little child smiles 500 times a day and an adult smiles only 15 times a day. And God knows where those 485 smiles disappear. Okay. Always smile. It increases your face value. It is the cooling system of the head and the enlightening system of the heart. Remember, smiling is always better. It makes the person in front of you very happy. Okay. Have a sugar on the tongue. Always speak in the way I told you, and have sandalwood on the head. The person in front may be irritating, but tolerate it. Many times we tolerate so many people in the world. On the other hand, there is another extreme of this story. Many of us, simply because the patient pays, they tolerate the dialogues of the patients in front. But when they go back home, their old parents, they don't tolerate. So that is also another extreme. So please see that at both the situations, you are quite tolerant, and do not be checkaholics, because, many times we unnecessarily send investigations for that U in the CT scan or an MRI, which is nothing but a mutually rewarding investigation. So do not use some investigations for monetary purposes. And as I told you, you should have a right and a regular academic updating. If you want to change to rationality, only 2 minutes, you have to take up the challenge. And the challenge is nothing but addition of LLE to the change. And that is lifelong education. I told you, I am a lifelong learner. And in life, you should always remember to take up this particular challenge by adding LLE. Okay. And then back home, you should have right time with the family. Today, because of the crunch of time, I will not elaborate more as to how should be our family relations, maybe at some other time. But then you should have adequate time of good quality to your family. And then a right lifestyle with a positive attitude, being aware of what is bad, having a good company, having a good diet and a good exercise. And then, my dear friends, lastly, You should take right decisions on the lifestyle. I told you many of us are the ones who follow the path of others, which you may not. But I would strongly suggest you that follow your own path. In case if you are tired, have someone who is younger than you and do a group practice. And then of course, some of you might have heard of Ikigai. Whatever you do in life, you must love it. You must see that you continue your study in that field, and it should be also helpful to the society. For example, we are doing immunization every day. We get money out of it. That is one thing, but do we really love it? Okay. So whichever work you do, it should also be such a work that you love it. Please read this book on Ikigai, and it is something which you can apply rather in your lifetime. And then remember to have a right mentor. My teacher always used to tell me, Pramod, you first try to be a good human being and then a good pediatrician. So at the end, everybody will remember that Dr. Jog was always a smiling person. He never said anything bad to anyone. He checked patients normally. He never refused my phone calls. These are the things which remembered. Okay. They won't remember that, he could not diagnose this and that, but how you behaved, that is what will be remembered in life. And that is why, remember, in the morning, give 10 minutes to yourself. Get up at 5:30 for about 45 minutes to 30 minutes, do some good meditation. It will change your entire day. And remember, Dr. Pramod Jog's birthday, that is 10th August, 108. That is 1 hour of good exercise, 0 screen time, and 8 hours of good sleep. Okay. Sleep is 1/3 of our life. Have a good sleep. Do not unnecessarily keep awake at night looking at serials and others. And in the morning, get up at 5:30. That will change your life to a great extent. Most of these are my personal views, which I try to follow to the best of my abilities. But then I think you will benefit from some of these points. And then call me on 10th of August, 2023. Thank you.
Thank you, Pramod. It is always a pleasure, and it's very relaxing to hear whenever you give such a good lecture. I've been hearing Pramod since 1976, when he was 3 years junior to me in college, but the sense of humor has matured so much that he's become a philosopher now. Thank you so much, Pramod.
Thank you, sir. I request Vibha Kumar ma'am to felicitate Dr. Pramod Jog, sir. I request Dr. Rajendra Gaikwad, sir, to please come on stage to felicitate our chairperson. Vibha Kumar, ma'am. Dr. Jagdish Nikne, sir. Thank you, sir. Thank you, ma'am.
After this so much enthusiastic and entertaining lecture, let's move on to our next session of neurology panel discussion. I request Dr. Umesh Kalane to conduct the panel discussion with very eminent speaker, Dr. Anand Diwan, Dr. Nikhil Pawar, Dr. Prashant Utage, and Dr. Sanjeev Joshi. All of you please join the stage. With the cup of coffee in your hand, let's charge your neurons to listen to this neurology panel. With Selka and Gyra going up and down, ventricles accommodating CSF in it, and billions of neurons trying to control even a blink of our eye, neurology always amazes me. As a pediatrician, you are supposed to have a working knowledge of neurology, but dissecting each and every neuron and its connection is not our cup of tea. A good knowledge of neuroanatomy and neurophysiology by itself cannot make a good neurologist. But today we have some good neurologists with us who dedicated their career entirely to the subject. May I request moderator Dr. Kalane to take over.
Thank you, IIP Pediatrics MAHAPEDICON Nashik Organizing Committee for giving me this opportunity to conduct as a moderator this session. Dimag ki batti jalao. Let's see, with our panelist with us, Dr. Prashant, Dr. Sanjeev sir, and Dr. Anand and Nikhil. हम लोग थोड़ा दिमाग की बत्ती जला सकते हैं नहीं? Okay, so I'll start with this session. So next 45 minutes we are going to discuss about few cases in common pediatric office practice. I have divided this into 3 parts, 3 sessions. One is on epilepsy, one is on acute encephalopathy, common scenario in indoor pediatric practice, and then the common problems like headache. And this will be a case-based session. So I will start with my first session, and that is scissors or scissor mimic. So this is a first case, case 1, and this is a 18-month-old boy. And he was presented with fever since last 2 days. And then he had brief episode of query seizures, uprolling of eyeballs, brief stiffness followed with looseness, and then unresponsiveness. He recovered within 1 or 2 minutes. He was admitted. Usually in such scenarios, parents are panicked, and then he was admitted. He had fever which was treated with antipyretics, and seizure was subsided with midazolam spray. And then he was evaluated for cause of fever, which most likely a viral. And next day, child was playful. So with this opening case, I will move to my panelist. What could be the possibilities and what could be the things? So I'd like to know what could be the possibilities, Prashant, with this history. Mike.
So this is a 18-month-old child, so presented with febrile illness of short duration and then short duration of seizure, which is lasting less than 5 minutes. So most probably the simple febrile seizure we are dealing with as of now and the history.
Yes. And can it be encephalitis or meningitis? Because this is the common scenario when the patient comes in the middle of the night to the treating pediatrician. The child is drowsy. So what are the points in favor of meningitis or encephalitis or on the top of febrile seizure?
Well, I feel this child is having a brief seizure and he is otherwise well, no focal deficits and no prolonged seizures. So less likely to be meningitis and encephalitis because he is well CNS wise. So I don't think it's.
Yeah. So this is a very good message. At the time of admission, one might not be sure, but the next day the child is normal. It is very unusual for an encephalitis child to be normal next day. So the initial 2-3 hours you might not be sure. So better to get admitted and observe. But this is a usual story, as Nikhil mentioned, that if the child is playful, active within few minutes or few hours of admission, unlikely it is a meningitis or encephalitis case. And then going to the febrile seizure, this is a common question for us. What is a simple or complex febrile seizure? Dr. Anand can add to that.
The points to differentiate simple versus complex are only 3 points. If it's a brief, that's less than 15 minutes. If it's a generalized, and if it's a single event, then it is a simple febrile seizure. If neither of these is there, then we can say it's a complex febrile seizure. Means it's a prolonged seizure, more than 1 in 24 hours, and focal. It's not generalized. Why we want to differentiate simple versus
complex at the time of admission, because we want to know how it is going to have recurrence or whether it is going to go into the epilepsy. The rate of recurrence will be for a febrile seizure, doesn't depend whether it's a simple or complex, but development of epilepsy is dependent on the whether it's the first event was a simple seizure or the complex febrile seizure.
So now, Dr. Sanjeev sir, how will you advise them how to manage it?
Hello, very good afternoon to all, and thanks the organizer for this wonderful opportunity. The first and foremost thing in the management would be, I would highlight what should not be done. This is a classical case scenario of a simple febrile seizure, as Dr. Anand has already excluded complex febrile seizure from this child. So never do EEG or neuroimaging, number one. Whatever, if at all you want to advise any blood investigation, they should be directed to find a cause of the fever rather than for finding the cause of the seizure. And the most important thing, sir has just concluded, reassurance, reassurance, and reassurance to the parent. Explain, give more time than prescription to the parents, because they are very apprehensive. They are panicky when the child gets first episode of febrile seizure. Give a proper counseling. And in addition to it, if at all, in this child, educate them about the rescue therapy. So they should have a midazolam nasal spray, how to use it, how is the recovery position, and everything. So this should be the part of the management. And of course, if at all the frequency of seizure is more, or if you are dealing with a case of complex febrile seizure, then intermittent clobazam could be one of the mode of treatment.
Yes.
But speaking, I think it doesn't have a very good evidence as such. Okay.
So whenever it is, sir, as I already mentioned, any seizure first should be treated with a rescue medications and proper care of ABC, and then you will decide about intermittent prophylaxis. If it is a simple febrile, usually they don't require much, but if it is a complex febrile seizure, we can advocate then intermittent prophylaxis if the recurrences is too much. And most commonly used is clobazam. Initial days phenobarbital was used, but now or diazepam because of lots of ataxia. Low dose clobazam, usually 5 milligram half BT for 2 days is sufficient. So that's about the intermittent prophylaxis. And this question already touched by Anand. A brief 1 or 2 lines I want from the panelists. So if the father will or the child's parents will ask you, what is the recurrent chances and will my child will develop epilepsy? This is a common scenario they will ask you. So what will you answer to that?
So as I said, development of epilepsy after febrile seizures are dependent on not on the whether it was a simple or complex febrile, but depends on the family history. If fever was low at the time of a patient had a seizure, then chances of recurrence is high. If other family members are also having seizures with or without fever, if patient has some neurological abnormality, then the risk of epilepsy is high. But on an average, if everything is normal, then risk of development of epilepsy is just 2 to 3 times compared to the risk of general population developing epilepsy. For general population, if we say it's just 1 to 2%, here it will be 2 to 5%. So not very high risk of developing.
So febrile
epilepsy.
seizures have very less tendency to develop epilepsy. You can tell them 1 to 2% only, and these are the few risk factors, if at all. If they are there, more than one risk factor is more additive for this epilepsy. So if they are, then we can tell them that there are chances. Otherwise, simple febrile seizures, even though there are recurrences, they don't develop epilepsy. So, but sometimes, the parents want to know why you are not starting continuous medication. We are afraid. 2-3 seizures, hamari to jaan nikal jati. You have to do something, doctor. Every time you are telling me intermittent prophylaxis, I want some continuous medications. So when will you advocate continuous medications in case of febrile seizures? We will not go by parents' demand, but what are the indications when in case of febrile seizures, you will think about, I'm telling thinking, not a dictum that one might consider. So when are the situations?
So I think if it's for you.
Yeah, anyone can go ahead.
Yeah. So if a child, if the history has the child has developmental delay and a febrile seizure, or it's a prolonged febrile seizure or febrile status, or recurrent febrile seizures with high parental concern, then is a time we can think of starting a long-term prophylaxis.
So this is
And for the simple febrile seizure, my counseling would be, I will never start that child on a continuous prophylaxis, because the risk of anti-seizure medication, which has to be given for a prolonged time, outweighs the benefit. Simple febrile seizure is a benign issue, self-limiting issue, not going to cause any neurocognitive issues in the future or any issues with the learning abilities in the future. And if at all he has to develop epilepsy in the future, even if I start certain anti-seizure medication at this time, this is not going to prevent epilepsy in the future. So that is also $1 million of question. So I will always counsel the parent that risk of starting continuous medication is far more than the disease itself. But as Nikhil has already pointed out, you have certain exception to the rule like febrile status, very frequent seizure, or uncommonly, rarely, if that febrile seizure is one of the presentation of the so-called fever-induced genetic epilepsy, then I may have to start continuous medication.
So this is a clear message.
One more point, actually, we should insist when we are sitting in a OP and you see nowadays every parent has 1 or 2 child and they are apprehensive. Use of rescue medication, that is the midazolam nasal spray. We should insist and counsel them very frequently so that they will not in a favor of starting anti-seizure medication. And in fact, few anti-seizure medication will increase the hyperactivity, learning disability and cognitive decline.
So this is the message that simple febrile usually don't require much treatment. Complex febrile may have intermittent prophylaxis and few situations where you might give continuous medications, but each case is individual, and rescue medications. I will continue this case. We'll go a little fast now. So this child, sometimes it happens, the simple febrile seizure child will keep on coming with recurrent episodes. Now the same child continue for next 1.5 years had 5-6 episodes, many status. And he intermittently used to have this myoclonias like this. And in between he started having a febrile seizures as well. So story started with febrile seizure. Many times we might see kids with vaccine-induced fever, seizures, early age. So this child had this myoclonias. Now see this. So now febrile seizures with myoclonias. So what could be the possible causes now, Prashant?
Yeah, now as we are moving from simple febrile towards complex febrile or recurrent febrile plus afebrile. So definitely the red signs alert that am I dealing with something like a JEPS plus or Dravet syndrome or SMEI. That should be my possibility, because in spite of starting valproate, one anti-epileptic child is not responding to that. So my possibility will be like whether Dravet syndrome or genetic epilepsy we are moving towards.
So this child is now having a possible epilepsy, so he will require some more attention. So nowadays there are many things happening in epilepsy with genetic causes. So Nikhil, when will you suspect in such cases genetic epilepsy?
So again, with the history, if the birth history is normal, development is normal, there is consanguinity, and if there is a family history, there is a high index of suspicion of having this recurrent febrile or febrile seizures, most likely it could be a genetic.
So this is important, the developmental delay, other manifestations, family history. And so we'll go to this Dravet syndrome. It is a genetic epilepsy. It starts with fever, and this is because of the sodium channel mutation. Dr. Anand, what are the clinical presentations of this Dravet syndrome? We'll discuss that much only with pediatrician.
First time febrile seizure will be like a other febrile seizure. At first event, we will not be able to differentiate whether it's really a Dravet or not. But points in favor of Dravet is if it's a fever-induced or just hyperthermia-induced, prolonged hemiconvulsive seizure. Sometimes seizures just alternate on one side and then other side. Getting recurrent seizures, getting other types of seizure, as the video shows, some myoclonic, sometimes tonic. So those other seizures, absent seizures with recurrent seizures is usually a Dravet syndrome. I like to keep a threshold of 3 for a febrile seizure. Usually after first febrile seizure, the risk of developing second seizure is around 30%. After 2 febrile seizures, it will be around 50%. But if it's more than 3, then it is more likely not just febrile seizures, but it is likely to be entering into the field of epilepsy. And age, earlier the age, though the recurrence is high, if the seizure is happening after 3 years of age, febrile seizure, it is more likely epilepsy than just simple febrile seizure. So I want you to remember just threshold of 3. The presentation is like prolonged hemiconvulsive seizures alternating induced by fever, hyperthermia, and other kinds of seizures. And at the same time, after this seizure starts, the cognitive decline also develops. So this is classical for the Dravet syndrome or SMEI.
Yeah, vaccine, then seizures.
This is, if we summarize the history and the seizure semiology, changing seizure semiology, starting with the febrile seizure, afebrile, changing semiology, and the age of onset. This is a classical case scenario of an epileptic syndrome, encephalopathy, epileptic encephalopathy, starting at the infancy, fever triggered, most likely Dravet.
Same points to highlight. So this case is required.
The most important thing, most of the pediatrician, sometimes if what they do is, if the child get frequent seizure, they inadvertently put the child on carbamazepine, and that is the worst thing which you are doing for this kind of situation. So my word of caution, never ever start the drugs like carbamazepine in this situation, because that will make the seizure worse. Okay.
Or phenytoin.
Yeah. So to conclude this case, some cases required workup, and now these genetic panels are available and which are easily available, simple blood test. Now the costs are also coming down. It is sometimes helpful because that will guide you for the treatment. And as panelists may have mentioned, that few drugs may be avoided accordingly, like carbamazepine, phenytoin, which should be avoided in the phenytoin. So this spectrum already we have discussed. So I'll go to the next scenario. Now this is again a 8-9-month-old child. He was rushed to the casualty with this emergency seizure-like episode. He had this episode of thrashing his limbs. Then he staring, crying, abnormal posturing, and followed with limpness and some perioral cyanosis. These are frequent episodes since last few days, but very important in the history, always preceded with crying. So what is the take on this case, Anand sir?
Yeah. So recurrent paroxysmal events usually induced by some cry or trauma, and then patient developing unresponsiveness posturing. It looks like a reflex kind of phenomena, like a breath holding spell.
Yeah, so breath holding spell. Okay, very good. And sometimes there are difficulties in diagnosis in such cases. And otherwise, it's a classical diagnosis. So what will be the difficulties you will always face such cases, sir?
As this is not only the nightmare for the parent, but for the practicing pediatrician also. If you are not aware of the sequential event, what was the sequence of the event, and the child just came to you with just limb and respiratory arrest and all, you might think that it could be one of the a very near dying situation. If at all the classical age window of 6 months to 2.5 years is not followed, that I myself can quote my anecdotal experience that the minimum age I have seen with breath holding spell is 3 months. So it is very difficult to label that child at that particular. So a typical age of presentation, very frequent breath holding spell and very prolonged breath holding spell. Rather, prolonged breath holding spell and very frequent breath holding spell, the most important investigation you should advise to the parent, in addition to the reassurance, is go ahead for an ECG to rule out a long QT syndrome.
Cardiac is most important rather than neurological. And last is very important. Sometimes these parents are very anxious. So that also causes difficulty in diagnosis.
Sir, in this, just one point, even you advise the EEG because of the parental anxiety or even your own anxiety. And if you get the report abnormal, don't try to treat that, because blindly sometimes it could be just slowing, which will be reported as abnormal.
Yeah. So no
need to start
neurological
that
treatment. Okay, this is another child. Now these are small cases, so only 1 or 2 minutes of discussion. This is a 2-month-old boy, otherwise normal birth history development, and then started having this myoclonias. See carefully now. Yeah, this right hand was moving, right hand jerking, right hand, left hand. And important is mainly during sleep and the age. And last line is very important to ask them specifically. Disappears with sleep. So this is a typical story. So what is the diagnosis, Prashant, in one line?
Yeah, so this is a benign sleep myoclonus. Benign itself declares that on awakening, it's disappearing.
And what could be the points to consider against severe epilepsy syndrome or any underlying severe disease?
Because child is developmentally normal and seizures are only during sleep, very minimal. And over the maturation and age increases, it subsides.
So early part of the sleep, as soon as you will make the child awake, they will disappear. So these myoclonias, sleep myoclonias, benign sleep, sometimes they are quite forceful. So might be frightening for the parents. So ask them to record, and the history is very important. That disappears with sleep. So this is about benign sleep myoclonias, and they disappear by 4 or 5 months of age. So what they require is counseling. Now this case is very important in pediatric practice. This child was admitted with loose motion, 8-9 months, loose motions, was there in the ward for 3 to 5 days, treated for this infection, and then started with these abnormal movements, which were diagnosed as seizures. And he has this, if you can see in the video, some amount of light colored hairs, some pigmentation on the hands. So what could be the possibilities here? Nikhil, do you think it is epilepsy?
Well, no, I don't think so, because he is awake, alert, and it's more like a movement disorder.
So what kind of movement disorder?
This looks like a tremors.
Infantile
But
tremors
yeah, not a
syndrome.
clonic
So
movement.
this is a very common scenario. Still, we see many cases, usually stories like this. And there are many theories postulated. Sanju sir will guide us for that.
So the most important point about etiology is still a mystery.
Yeah.
But the recent evidence support the deficiency of B12, and not only B12, but its transport protein, which is transcobalamin 2, and mainly deficiency in the CSF, which is responsible for the neurological issues. And definitely there is a temporal relationship with the onset of the seizure and the type of the feed the baby is having. If she is a vegetarian mother, and if the child exclusively breastfed, and the complementary feeding is not started, that is a particular, there is a classical situation where these ITSs are more common. So a low vitamin B12 level in the mother could also one of the reason. Of course, there were some postulations about the defect in the tyrosine metabolism and substantia nigra involvement. But the most recent causal relationship is with the vitamin B12 only. And there are associated comorbid issues like deficiency of other micronutrients like iron, zinc, and magnesium. But if at all you supplement with only with iron, zinc, and magnesium and folate, the itis is not going to subside. So they has to be read as a comorbidity. And exact temporal relationship with this nutrient deficiency is not established yet.
So it is uncertain, but vitamin B12. So single test, Anand sir, single test to diagnose it. Prashant,
So simple CBC will give you the diagnosis.
You can do for child as well as mother, and MCV you have to look for, because sometimes vitamin B12 levels are not very much certain. So simple CBC test might be helpful. Otherwise, no other test is required. These are the few tests which are done, and the treatment was already mentioned. Many times they require intramuscular injection for 2 months. 14 days, then 2 months. In this schedule, we plan it for 2 years. And most of the time, if you diagnose early, they recover well. I will go to another case. Now, this is older kid now. A 10-year-old girl brought from the school. She had a seizure in the school. She was standing for the morning prayer. She went in the school empty stomach. Teacher noticed she had a fall, and when regained consciousness immediately, and when asked, she told specifically that she has a feeling of giddiness, rotatory feeling, about blurring of vision, and then she fell down. She was not recovering anything. So with this scenario, what could be the possibilities and why?
So as a child is standing for prolonged time, that is the stimulating factor, and sudden loss of consciousness or feeding giddy or funny turns, and then recovery is very fast. So most probably it is a syncope what we are dealing with.
So it seems like syncope. I'll ask panelists to answer in 1 or 2 lines only, because we have to cover many cases. So when will you do, sir, cardiac evaluation? for the child.
So if the syncopes are occurring very frequently and that too mainly during exercise.
Exertion is
That
very
should be one of the very important indication of doing an complete cardiac workup, mainly the ECG. Because long QT syndrome has to be excluded when you have an exertional sort of syncope.
These are the conditions. Nikhil, will you do EEG for the child?
No, definitely not.
So usually not needed until unless, and this is a typical description. And in one line, how sometimes it is difficult to differentiate. Post-ictal absence of headache speaks against seizures. So if this history is there, there is no need. And how will you manage it, Dr. Anand?
Once we confirm that it's simple faint or vasovagal syncope, it's just assurance to parent that it is just because of the position she's standing in a crowded place, warm weather. So taking precaution of that to avoid those triggers, taking good hydration, food before going to school. These are the simple measures. Will not prescribe any antiepileptics or any test once we are sure from the history that it is nothing but vasovagal syncope.
Yeah, so no antiepileptics, plenty of fluid, avoid prolonged standing, salt, and already Dr. Sanjeev has mentioned about prolonged QT syndrome. And to conclude this part of the session, even in doubt in seizure mimics, when one can think about antiepileptics, no one is immune to make false diagnosis. So a therapeutic trial is, you can think about it, but when unwitnessed events associated with tongue bite, incontinence, amnesia sometimes can happen with syncope, but usually seizures, stereotype funny terms like West syndrome, spasms. And the most important thing is that you are going to follow them. It's not like writing 2 years and then come after 2 years. So sometimes you can start and reassess after 1 month, stop the medications, but these are relative indications what I have mentioned. Okay. So second part, this kid, 7-month-old now, Down syndrome, and these jerks, funny turns, what I was mentioning. And this is associated now with cognitive decline. Mother is telling, hasta tha, social smile has gone, eye contact nahi de raha hai. So this kind of jerks he started with, mainly on awakening from the sleep. You can see, these jerks are happening. So now, Prashant, what is the diagnosis, single line?
So a child is a developmental delay, that is the Down syndrome, cognitive decline and infantile spasm.
Infantile spasm.
So it has to be confirmed, but clinical diagnosis should be West syndrome.
West syndrome. And what are the investigations, Nikhil? Yeah?
The first one definitely has to be EEG to look at the signature hypsarrhythmic pattern.
Yeah. So signature EEG, hypsarrhythmia. There are only 3 conditions on EEG 100% diagnosis: West syndrome, hypsarrhythmia, absence, and to some extent SSP. So he has rightly mentioned, and then you will do imaging and all other things. And very important to have how to manage it. So, go ahead.
Yeah.
Go ahead, management of a West syndrome.
So the triad is established.
Yes.
There is a regression of the milestone.
Now,
You have a seizure semiology and the hypsarrhythmia. We would like to follow the most latest AOCM protocol, which says high dose of ACTH. The drug of choice is ACTH preferably, and the dose is 6 units per kg. And that should be continued for 2 weeks. Assess the response and repeat the EEG. If ACTH is not available, then don't bother. Even 4 to 6 mg of prednisolone in this particular dose can be given for 2 weeks and response can be assessed. Dr. Anand?
So it's very important, aggressive management because cognitive decline. So steroids, other drugs, Anand?
If hypopigmented patches are seen and if we are suspecting tuberous sclerosis, then vigabatrin will be the first choice in this case. And usually after 2 weeks, we should see a very good result or response to the ACTH or steroids. And we may check with after 1 month the EEG and how much it has resolved.
So, and sometimes even these vitamins, biotin, pyridoxine can be tried in refractory cases.
One important word of caution, the most common reason of West syndrome in our country is still remote symptomatic epilepsy out of neonatal hypoglycemic brain injury. So please try to avoid neonatal hypoglycemia. Neonatal hypoglycemia is not a one-time event. It is a lifelong morbidity in form of West syndrome.
And it is a type of epilepsy where we need to repeat the EEG frequently.
Yeah, so I'll move to the next case. My aim is to just familiarize them with these cases. So we will have brief discussions. Now this is a LGS case. So brief discussions only will keep. 7-year-old girl with frequent drops like this. She had a tonic seizures during sleep, then absences. You can see she had a lot of head injuries here and significant birth history. So neonatal brain hypoglycemic injury and this kind of epilepsy. So what syndrome, Nikhil, you will think about?
I think this looks like a Lennox-Gastaut syndrome.
Lennox-Gastaut syndrome. So important to label these syndromes in epilepsy because that helps for prognostication, selecting the anti-epileptic drugs. So few syndromes as a pediatrician we should know, and this is one. So overall prognosis, Dr. Sanjeev.
Sir, Lennox-Gastaut is an age-related classical epileptic encephalopathy. Even West syndrome can evolve into Lennox-Gastaut or other epileptic encephalopathy. The characteristic EEG is slow wave complexes and a nightmare for pediatric neurologist, pediatrician. Requires a holistic approach, a team approach with epileptologists, psychiatrists, neurodevelopmental specialists, and multiple sort of the polytherapy.
So Nikhil and Piyu, can you tell us the management?
Yes, I would start with the combination of valproic acid and lamotrigine.
Yes.
Lamotrigine will take care of the tonic component and valproic acid for the myoclonic gel.
Yeah. So these are the few drugs, like sometimes even steroids, ketogenic diet, surgical management. This child was kept on valproate and lamotrigine, gradually increasing the doses, and she did well. So this is a LGS, is another age-dependent epilepsy syndrome one should aware of. This is again another common syndrome what we see in slightly younger kids, 4 to 13 years. This is a 7-year-old boy. These episodes of unresponsiveness multiple times in a day, staring, and last for few seconds, normal examination, no deficit, normal birth history, and EEG is very much characteristics. So Anand, what is the diagnosis?
Classical for absence epilepsy.
Absence epilepsy, childhood absence epilepsy. And usual absence epilepsy prognosis in a single line?
If I have my electroclinical diagnosis is childhood absence syndrome, there is an excellent prognosis.
Good prognosis.
Very excellent prognosis with the medication.
And what is the drugs?
Drug is obviously the sodium valproate, and if the ethosuximide is available, that.
So this is a very good syndrome to get cured. Childhood absence and no imaging is also required. But right drug is very important. If you will give carbamazepine, phenytoin, it may worsen. So valproate is very much important for this, and this is overall summary of childhood absence epilepsy.
So just one point for the pediatric learning, that if you send the EEG suspecting absence epilepsy and you are getting report normal, please recheck whether the technician has done hyperventilation and photic stimulation. Don't believe on that report, believe on your clinical history.
Yeah, hyperventilation is very important to provoke this episode. So excellent prognosis for this child. Now this is another 8-year-old, again age-dependent epilepsy. He had only 2 episodes in last 1 year, so less frequency. During sleep, he got up from the sleep, at times went up to his parents, make them awake. He was not able to speak. There was a lot of drooling happening. And then gradually parents noticed that he started shaking on his one side of the body. And within a few minutes, he was normal. He slept and then got up. He was absolutely normal. This was the story, 2 episodes. Twice in a year. So with EEG I also have kept here. So what is the diagnosis?
So it is a classical, so the age is 8 years, nocturnal seizures, classical, the involvements of the muscles of deglutations are there. Then you have a focal semiology in form of tonic-clonic, behavioral arrest is there, and nocturnal and infrequent seizures. My first possibility will be by the recent nomenclature by the ILA is Beck's syndrome.
Yeah.
Previously, it used to be called as Rolandic epilepsy. Now we label them as a pharmaco-responsive Beck syndrome, considering the classical age and etiology. The most important thing, when you advise EEG for a child with Beck syndrome, you must write sleep and sleep deprived. So otherwise you won't get the classical changes, and I think. who is
Yeah. So
next?
and what is the prognosis?
The prognosis is also good here. With or without treatment, usually the disease goes into remission by 12 to 14 years.
Yes. And what will be the drugs?
Drug of choice is obviously carbamazepine, oxcarbamazepine. But be aware if pediatric neurologist or you have started on carbamazepine, and after 6 months, if child is worsening, there is cognitive decline and poor scholastic performance, you need to be aware carbamazepine induced encephalopathy.
Then you have to change to one.
Yeah. So this is last case in epilepsy. This is older kid now, 12-year-old, 15-year-old. He had 3 episodes of generalized tonic-clonic seizures, early morning mainly on awakening. And he is on asking further in the morning, he used to have this myoclonus mainly on the early morning. And there was history of sleep deprivation previous day when he had these generalized episodes. And this was his myoclonus while doing photic stimulation. See the photic stimulation in EEG is going on. Prashant was telling about it. So he is having jerking with this photic stimulation. So clear-cut diagnosis. Prashant?
So this is a photosensitive epilepsy. Age of presentation is 15 years. Presented with myoclonic jaws and multiple like absences also. So juvenile myoclonic epilepsy.
Initial days it used to call Jan's syndrome. So juvenile myoclonic epilepsy. And how will you manage, Nikhil?
It's like a lifelong treatment, I would say, with valproic acid.
So they will require lifelong, they are well controlled with so small dose of valproate, but they require prolonged treatment. So this is important. This epilepsy, you have to tell them more than 2 years. These are the few characteristics, and EEGs will show generalized fast spike wave discharges. So this is about
comprehensive history is very important to me because most of these kids, they have habit of early morning falling of the object.
That's what I mentioned.
Yeah.
Myoclonias they will have. So this first session is over now on epilepsy.
Umesh, I have to take your leave now.
Okay, sir.
Thank you, the organizers and the August audience, and sorry friends, because I have to catch up a flight from Mumbai. Thanks a lot for the opportunity.
Thank you, Sanjeev sir. So this one opportunity for me to show our flyer for National Child Neurocon 2023, which will be happening in Pune. All the interested one can register on this site cnspune.org. So second session, acute encephalopathy, only 2 cases, 5 minutes or 3-4 minutes each. And this is a common scenario, encephalopathy, admission in the IPD. This is a 5-year-old girl, admitted normal with fever. She was admitted, this fever was going on for 15 days. Mild grade, then high grade, and she was investigated for PO. Multiple investigations were done, and her count was always high, more than 20-25,000. There were toxic granules, so always thought of infection, sepsis. She was received multiple antibiotics. She for fever she was evaluated like Kawasaki disease, ANA, GRA, and then gradually she started becoming drowsy. And then MRI brain was done. Prashant, single line on MRI, what you can find?
So meningeal enhancement is there on this.
Yeah, and some white matter changes.
Yeah, hyper intensities are there.
So multiple hyper intensities, floppy shadows in the white matter, but no diffusion restriction changes. Usually encephalitis will have some diffusion restriction changes. And so this MRI was reported as meningoencephalitis because of this story, prolonged episode, always toxic, always CBC showing high polys, and repeat CBC again showed 35,000 polys. Antibiotic step up, drowsiness increase here, doubtful episode of seizure, EEG was normal. And then CSF was done. CSF showed 140 cells. So what do you think now? Possibility of?
Now looks like an infectious and
encephalitis.
Encephalitis.
So encephalitis sometimes present like this. But only thing odd was 15 days into illness, she was not that toxic. Whenever fever, she used to be little toxic. But as soon as fever subsided, she used to be a playful child. Any child with so much of fever with infection, by 15 days, she will be very much sick. Are you agreed?
Yeah.
And CSF showed high proteins and cells. Repeat MRI showed similar changes, which are increased now. Prashant?
Yeah, still you can see multiple hyperintensities in both hemisphere, even thalami.
Yeah. So at this moment, methylprednisolone was added and fever disappeared. So what panelists will tell what magic could have been here. So you can throw more light here now. Why methylprednisolone was added?
this is like a immunomodulator drug. So something was added like methylprednisolone and patient improved. So looks like rather than inflammatory, it's infective. It is autoimmune inflammatory pathology which is underlying, which has responded now to the steroids.
Yeah.
Methylprednisolone.
Nikhil, you want to add anything specific?
I think the next step would be IVIG.
No. Why methylprednisolone she responded for this case?
Yeah,
So what could be the diagnosis?
autoimmune encephalitis. Could it be ADM or something?
Or ADM
Possibly,
and
because of the
specific
fluffy
ADM?
white pattern. Sorry?
Which kind of ADM you want to say? Newer ADM?
Neuromyelitis optic.
Or
MOG.
Yes. So this seems like a MOG ADM. So I will come to that. ADM is acute disseminated encephalomyelitis they will present with. And in this ADM now there is something called as MOG ADM, MOG antibody positive ADM. And this is important as a pediatrician we should understand because these kids sometimes present in the same way like encephalitis, high grade fever, CSF will show pleocytosis, MRI will show this kind of floppy white matter changes, and in between the child will be normal. And why it is important to know? Because this MOG is available with most of the labs, not very costly, and excellent response to steroids. Single dose of steroid, the fever will go. So as a pediatrician, now we should know about MOG ADM. Okay, so this child had.
But usually by this time, sometimes being India, we start AKT in few cases. So we should restrict ourselves from starting the AKT.
So this is the message that MOG ADM can present with high grade fever. They may mimic encephalitis because of the high cells in the CSF. They have good response to steroids or IVIG. Sometimes prolonged steroids 3 to 6 weeks. And MS drugs, multiple sclerosis drugs may worsen this MOG. So as a pediatrician, one should know high grade fever with this kind of presentation in encephalitis child can be MOG. So you can advise them to do this MOG antibodies in blood or CSF. Most of the time we do it in blood. This is another case of encephalopathy. Apart from encephalitis, what viral encephalitis we see. A 10-year-old girl, again fever on and off for 1 or 2 weeks. Then she was presented with focal seizure, encephalopathy, and intermittent posturing, and a lot of oromotor dyskinesias. CSF was normal. EEG showed mild slowing with something called as delta brushes, and MRI brain was normal. So any panelist can comment on this?
So there's classical febrile encephalopathy followed by regression and oromotor dyskinesias in the video, as we can see. Could be pointing towards NMDR. Along with that, EEG delta brushes is the signature for the NMDR.
NMDR, autoimmune encephalitis. So autoimmune encephalitis is another common entity. Nowadays, we are seeing in our IPD, apart from viral encephalitis, everything is not viral encephalitis. And these conditions, why we should know? Because they require different treatment, different management overall. So this girl was then evaluated and her NMDR was positive in CSF as well as serum. Oligoclonal band is another CSF oligoclonal band. If it is positive, another indicator of autoimmune encephalitis. So where the facility is not available for NMDR, you can do oligoclonal band in CSF. And she was started on steroids and IVIG, and she responded very well. So these are autoimmune encephalitis. And this girl later on found to have UAG abdomen showed teratoma, ovarian teratoma. She was operated and normal within 2 months with no sequelae at all. She's smiling. So important to diagnose these cases, and that's why we should know what what your mind know. That's what you will see in your OPD with your eyes. So autoimmune encephalitis, this is the message, take home message, not rare nowadays. In fact, few institutes have mentioned 10 to 15% of admissions in pediatric ICUs in neurology is because of autoimmune encephalitis. Seizures, movement disorders, CSF may be normal, CSF oligoclonal band can be positive, and they do have protracted course and they respond to immunotherapy and search for ovarian teratomas.
Mainly MRI will be, usually we expect such kind of presentation to be abnormal. Sometimes second MRI may show few changes.
Yeah. So this is a last case, again a common scenario in our pediatric practice and frustrating sometimes, of a 12-year-old girl presented with headache on and off since last 4 months. Bifrontal, but more on one side, asymmetric, throbbing, pulsatile, sometimes aura, visual blurring on one side, and then headache followed with that. It lasts for 3 to 4 hours. Sleep relieves and child avoids light and irritates with loud sounds. So photophobia, phonophobia. And these episodes 2 to 3 per month, and she misses schools 2 to 3 days per month. So quite a lot there is school. The headache problem is not for the child, but also her academic activities. They have to miss schools and being scolded by parents and teachers for the same. So what type of headache, Nikhil? And you can start with this.
This looks like a migraine with aura. And also there's a component of tension headache, if you can see.
Yeah. So primary headache looks like and possibility of migraine because of this typical description. So all these points should be included in the history. Type, semiology, frequency, provoking or relieving factors, and social consequences of it. Okay. So what are the danger signs you will think in headache case?
Early morning headache or waking up from sleep with severe headache or worst headache of the life, any focal deficit or weakness, and projectile vomiting or altered sensorium. These are some of the red flags, I would say.
Worsened by the Valsalva.
So
worsened by the Valsalva, the coughing, sneezing.
Valsalva also. Yeah, last 1 or 2 minutes only. So that's what various short forms are there. One is SNOOP. You have to look for systemic signs, any weight loss, weight gain, neurological focal deficits, onset, abrupt changing pattern, mainly in the morning, disturbing sleep and progressive worsening. In such cases, you need to evaluate. You have to do imaging fundus examination. Okay. So how will you differentiate? So how will you define migraine? Anyone?
Unilateral throbbing with photophonophobia lasting usually more than 2 to 4 hours. In pediatric age group, it can be just for 30 minutes. And if it's associated with nausea and aggravated by even day-to-day activities, these are classical features for the migraine. If this is mild, bilateral, even with headache, if patient is able to perform daily activities, then it is more likely tension type headache.
And all of you in your practice, how common you see migraine in your OPD in pediatric population? Because it's a myth that it is not common in pediatric population.
It's not common, but post-lockdown era or post-COVID era, it has increased maybe because of the use of digital screen and then lack of sleep. The incidence of headache has increased.
So definitely it's not a rare in pediatric population. Almost 10% will have migraine onset and we don't do any other investigations. So how will you differentiate between this sinusitis? Sinusitis is another differential.
Sinusitis is mainly related with infection, then heaviness when they bend forward, and then it get aggravated by seasonal variation. And there will be a purulent discharge or a nasal discharge.
So how will you manage pediatric migraine?
So depending upon the frequency, we will consider. Ideally, all the triggers should be avoided, depending upon what triggers patient has. Regular sleep, food is very important, exercise. When the frequency, infrequent attacks are there, say just 1 or 2 in a month, then rescue therapy. During the headache, only patient can take paracetamol or ibuprofen or naproxen sodium. And if the attacks are frequent, more than 2 per week, or even 1 attack which is not getting relieved with the rescue therapy, or because of the headache, the child has to miss the school, then the prophylaxis is required, which is to be given for at least 2 to 3 months of headache-free period, or headache just once per month to bring down headache frequency that low. And then we can again try the rescue therapy whenever the patient gets headache.
And the second tier should be a triptans. We should be rarely used in a pediatric practice, but definitely we need to take advantage of that.
So these are the triptans which are being advocated for pediatric population according to their age, and it is easily available on internet as well, and it is helpful. We use a lot. And third triad, very rarely we use combination of triptans with naproxen. Prophylaxis, last 1 or 2 slides only. Prophylaxis I want to ask. When will you start prophylaxis for them? Prophylaxis, these drugs, which drugs and when will you start?
Usually we start when it's affecting the child's daily life, that is 1 episode in a week, and it's disturbing his classes, and it's, as you have seen in this case, the going into the depression. We need to start with the migraine prophylaxis, and the commonest is the calcium blockers like flunarizine is the commonest one what we use.
Flunarizine, valproate, and the goal is to reduce the episodes to less than 1 to 2 per month, and it should be the school attendance should increase. So other disabilities should be reduced. So we use these common drugs like flunarizine, amitriptyline, valproic acid, topiramate, levetiracetam, gabapentin, but most commonly we use flunarizine. And younger kids, we can use cyproheptadine. Propranolol sometimes can be used. Asthma, we avoid propranolol, but flunarizine can be used. And somatization, amitriptyline. So this is overall prophylaxis. So how much period you will give? Last question.
3 to 6 months.
Yes.
And topiramate we should be avoiding in a schooling going age group because of the cognitive decline and the language affection.
So obese kid topiramate is helpful. So that's about usual management of migraine. And so I'll stop here. You want to take this while with lack of time, I'll stop here. So this is my last slide. Please join for Child Neurocon next year. Thank you very much.
Thank you. Thank you very much.
Thank you, sir, for wonderful lecture. I request Dr. Purushottam Devi to felicitate Dr. Kalani. I request Dr. Umesh Kalani to felicitate our eminent speaker, Dr. Anand Diwan, Dr. Nikhil Pawar, and Dr. Prashant Utage, sir. There is a small announcement. Immediately, we are going to start with the endocrinology lecture by Dr. Sudha Rao. After that, we will be shifting a lecture of mixed bag Sita or Gita from Hall Panchavati to the same Tapovan Hall. Immediately after we finish the lecture by Dr. Sudha Rao.
For the next session, may I request chairpersons Dr. Rajendra Gaikwad, Dr. Girish Charde, and Dr. Neha Singh ma'am to come on stage, please. I also request Dr. Sudha Rao ma'am, a speaker of the session, to come on stage. Endocrinology is like a complex crossword puzzle. One has to keep thinking and correlating what seems obvious with the probabilities. And I always felt it very rewarding whenever I succeeded in solving the mystery by my own self or with the help of an expert. Howsoever confident we may be, I would rather take an opinion from an endocrinologist rather than experimenting myself, because the treatment usually lasts for a lifetime. So I invite Dr. Sudha Rao ma'am to solve this puzzle for us.
Thank you very much. And very good evening to one and all. And thanks to the organizing team for inviting me to be with you all here. Greetings from Wadia Children's Hospital. The title given to me to talk on is a bit odd, because when to refer to a pediatric endocrinologist, when that was the question given to me, I added the component pediatric. If you look at the brochure, it says endocrinologist. So I just added the component of pediatric endocrinologist there. It's a question which comes to our mind as to practicing pediatricians when we would take specialist referral. I will try to finish this in the next 30 minutes, making sense, I believe. So let's go through this first case of a boy, Danish, who came when he was 13 years of age and presented to us for short stature. So he presented to us for short stature at nearly 13 and a half, 13 years of age. Fortunately, he could be diagnosed to be having an isolated growth hormone deficiency based on the clonidine stimulation test. And he was found to have a genetic deletion causing isolated growth hormone deficiency. He could afford and take treatment of growth hormone. And if, like you see, even at 16 to 18 years, he continued to grow. So this is a case of a referral which came around 12 and a half, 13 years of age. There is another story here of a 13-year, 5-month-old girl child who was born appropriate for gestation age and attained menarche a year ago and had regular cycles. And she was referred for care of this poor height growth, which was happening to her on regular monitoring for further advice and care. Unfortunately, this girl must have been in puberty nearly 6 months to really 2 years ago. She has lost on a pivotal growth spurt and she is presenting to us post-menarcheal, nearly 1 year post-menarcheal. So we all know that the growth velocity in a girl child does drop down when the menarche has set in. So you are on the sliding down scale of growth velocity when a girl has attained menarche. So the amount of help which you can give to this child could be limited. So the question of an Indian scenario, we do have lots of delayed referrals, delayed diagnosis. There is a difficult and expensive thing to diagnose. There is also delay in initiating therapy. And some of the disorders need lifelong treatment. So compliance becomes an issue. And some disorders happen more than one family member. So there are familial forms where the amount of hit to the family finances are double. And unfortunately, no long-term studies are available in the literature. And we, for especially endocrine disorders, do not have any registry as yet so that you can learn from those cases. So when we say we have referral, I would like to pose some questions here as to what is referral and why should one refer? Which cases you would like to refer and when would you refer and which specialist you would refer to? So when you look at the definition of referral as per American Academy of Family Physicians, a referral is a request from one physician to another to assume responsibility for management for one or more of the patient's specified problems. This may be for a specified period of time until the problem is resolved or on an ongoing basis. So this represents a temporary or partial transfer of care to another physician for a particular condition. I think this definition gives us the whole perspective of what a referral should ideally be made in relation to. So when we say why should you refer in this era of 2022 and lots of legal issues and lots of questions which comes from our patients and their parents, it helps us to ensure patients receive the care they need. It would be smoothing out the overall patient experience and reduce the care gaps. The referrals can sometimes be the ideal form when it goes to a specialist of sorts. Whenever there is a difficulty in making a diagnosis, you would want to refer. And when a particular child or a patient wants a specialist opinion, and when you feel that a patient will connect better with a fellow colleague, or when you want to improve the patient's access, for example, somebody who's living in, say, an area like Nasik, you would want to refer to a person who's close by so that the access to the patient could be improved. But what is the gap here at a larger perspective is this presence of specialists, which is an important determinant of the number of referrals. And I guess this is a time when we should say that we should evolve this into a participative care. Which cases and when to refer? Maybe we had a very beautiful session on puberty earlier today, where I was very much pleased to where the whole panel and the moderator gave out clear kind of referral guidelines. Similarly here, in which cases would you want to refer and when would you want to refer are very specific. So there are certain components of endocrine disorders where you would want an urgent referral. So urgent referrals you would want to make in type 1 diabetes with ketoacidosis, children presenting with weight loss, excessive passing urine, vomiting, lethargy, acidotic breathing, etc. You may definitely refer to an ICU. From that ICU, maybe the further care to a pediatric endocrinologist can come through. Hypoglycemia, which could be refractory, recurrent, or symptomatic, needs an urgent referral. Polyuria, polydipsia with dysnatremia, which could be hyponatremia or hypernatremia. Any child manifesting an adrenal crisis, which means hypotension, catechol-resistant shock, refractory hypoglycemia, seizures, some of them can present with symptomatic metabolic derangements. Atypical genitalia, especially in a just born baby. Even otherwise, later on also that would need, it may not be an urgent referral, but it would be needing a referral. Pathologic short stature with severe headache, blurring of vision, or recurrent pathological fractures. These would be some conditions which I could list out where the referral to the pediatric endocrine services would be relatively urgent. So if we take up disorder wise in thyroid disorders, in a congenital hypothyroidism, I guess we need to be able to look at children who have an abnormal screening test, the first column there, whom you would want to do an urgent referral, as compared to some child who is known or treated with an abnormal thyroid function test. So there the referral could be at the earliest. You may start treatment and maybe take a consult subsequently. It could be a routine or at the earliest kind of a referral. In a central hypothyroidism, again the referral needs to be urgent. In acquired hypothyroidism, largely most of them are in a bit of a compensated phase. So you need not be doing an urgent referral, but then a routine referral in presence of low T4, low free T4 or an elevated TSH. Hyperthyroidism of any sort needs to be taken care of by a pediatric endocrine specialist. Goiter needs an urgent referral if it's asymmetric gland. You have an increasing size of the goiter, which some kind of discomfort, or there is an abnormal thyroid biopsy, needs to be referred. A routine referral in the presence of goiter could be an abnormal thyroid function test, antibodies, or an abnormal ultrasound showing small nodules. If you find a nodule which is palpable and is more than 1 centimeter in size and increasing in size, calls for urgent evaluation. A nodule which is seen on ultrasound, not palpable, less than 1 centimeter, you may do a routine kind of referral in those cases. But there are certain things which we must understand when we are referring in relation to thyroid disorder. We often see slight elevation in TSH in obese children, which is secondary to metabolic syndrome or obesity. No endocrine referral is indicated unless the thyroid antibodies are positive in these children. Doing a thyroid test in obese children is quite a common practice, and often we do see mildly elevated TSH. So if the antibodies are negative, you can follow them up in your clinic and maybe refer only when it is rising or there is an antibody positivity. Alopecia or hair loss with normal T3, T4, TSH does not indicate an endocrinopathy, and referral is unnecessary. Children with Down syndrome with mildly elevated TSH, which is the transient hyperthyrotropinemia in these cases, with normal T3 and free T4 and free T4, they are generally, generally referral is not needed unless the antibodies are positive or you are demonstrating a rising TSH. Children with positive thyroid antibodies but normal thyroid function test may sometimes not even go on to develop hypothyroidism. So thyroid function tests just need to be followed up periodically, and if abnormal, referral is appropriate. Thyroid nodule, like I mentioned, if it's big in size, needs an urgent referral because you may need to rule out a thyroid malignancy. So coming to a dysglycemia disorder, DKA would be the spectrum where you would want an urgent referral. At the same time, a type 2 diabetes, a child who's obese with acanthosis, strong family history of diabetes, may not have the osmotic symptoms in the form of increased thirst or urination. You may take a routine kind of a referral, but nevertheless needs a referral. And in type 1 children, ongoing home management is a participative care. There also routine referral would be useful. Hypoglycemia in a failure to thrive child, refractory, recurrent, symptomatic is an urgent referral, especially in the newborn period. And if there is a hypoglycemia in the presence of severe short stature, again, that would be a routine form of a referral to an endocrine service. So it is, if diabetes is clinically apparent, that means your blood sugars are high, there is no need to do a fasting tour or a OGTT to diagnose. You must refer those children as soon as possible. The most important component of pediatric endocrine problems is short stature. And in short stature, like we heard in the previous case scenario, if the child is pathologically short, in the previous neuro panel discussion, if the child is pathologically short and has acute CNS symptoms in the form of headache, blurring of vision, etc., that needs an urgent referral. But we all know the references for pathological short stature, which means a height which is less than -3 standard deviation, height below the mid-parental height range, or when you are serially monitoring the height, if it is crossing percentiles, and if you calculate the annualized growth velocities is less, and short stature accompanied with dysmorphism, disproportionateness, or bone age delay is of more than 2 years, you would want to refer them to for further evaluation. So some points to take home in short stature is poor height velocity with severe headache and blurring vision may be a intracranial tumor. So needs an urgent assessment. If a child is short and is in puberty, maybe in an advanced stage or even starting off with puberty, this may increase the urgency of referral, like the second case I showed, because by the time the child reaches menarche, you don't have any time to help the child if needed for the statural optimizing the growth. Genetic variants of short stature like familial short stature and constitutional delay are the most common causes, and hence they need to be differentiated from pathological causes. Random growth hormone levels are not useful at all. And if weight is decreasing in relation to length or height, please rule out systemic illnesses prior to referring them for endocrine services. Measurement of IGF-1 and IGF-BP3, though may be used, it is very expensive and it's not really almost always useful. IGF-1 levels may often be low in children with malnutrition and low weight and may not be truly indicative of growth hormone deficiency. If bone age shows a bone age of more than 14 in girls or more than 16 in boys, then no endocrine referral is needed because you will not be able to help much in terms of the statural growth of these children, because there is no treatment options to increase height once growth plates are nearly fused. So we need not be referring such children for endocrine services. Puberty we dealt with very beautifully earlier today. So the red flag signs in 6 to 8-year-old girl child precocious with rapid progressive puberty with CNS changes needs urgent referral. You may do a routine referral if there is a progression happening over a period of time, the accelerated growth, advanced bone age, or telltale features of peripheral precocious like the cafe in the picture which we saw of McCune-Albright syndrome. In a 2 to 6-year-old, if you have breast development even without any other signs, needs an urgent referral. At the same time, if a girl child less than 2 years shows thelarchy, you may yourself, in the absence of rapid growth and all that, you may yourself monitor the child for progression. Often they subside because it's a physiological form of thelarchy. In a boy, if you have testicular enlargement and penile enlargement, it needs an urgent referral. Delayed puberty defined as absence of secondary sexual characteristics in boys more than 14 years and in girls more than 13 years. So you would be looking at referring them. And girls with no menses by 15 years with notable short stature, please keep in mind the possibility of Turner syndrome. So in precocious puberty, in benign premature thelarchy, some telltale clinical pointers are nipples are not usually dark or enlarged as is seen in precocious puberty. Fine downy non-pigmented short hair is not considered a secondary sexual hair or secondary, meaning a pubarchy starting. Pubic hair in the suprapubic area is more indicative than some of those terminal hair which are seen in the majora or on the scrotum. Pelvic sonography, MRI pituitary may be required as per the underlying condition. And of course, like I said, advanced bone age associated symptoms are indicators of a pathognomic severe form of puberty, and parental anxiety also needs to be addressed to when these children referred. The third and one of the last common condition which I'm going to touch upon is obesity. And obesity referrals usually needs to be done if you have them early in onset in children less than 5 years of age. If any obese child does not show associated growth in height, but has short stature or has some night blindness, visual defects, pathological hyperphagia, developmental delay, some obvious dysmorphism, would need a referral, though routinely, not urgently. And sudden onset obesity almost always needs to be evaluated. Obese child with features of metabolic syndrome also needs to be evaluated. So when you have an obesity and you have definite history of overfeeding, and the child is less than 5 years, you have genetic forms, so they need to be seen. But if there is a progressive obesity, but the obesity is sudden and progressing fast, you think of iatrogenic causes, drug-induced, you think of hypothalamic insults and other hormonal issues causing this obesity and needs further evaluation. But if it is not really very fastly progressive and the height velocity is appropriate, you look at the comorbidities in the family, and thus these children need to be given an advice and maybe taken care of in a nutritional clinic. But if this obesity is associated with a short stature, you would want to look at the endocrine causes and evaluate appropriately. So these are some pictures: obesity with or without hyperandrogenism. The acne, which is inflammatory extensive, is a feature of hyperandrogenism in a peripubertal girl. Needs, even in a boy for that matter, needs to be referred for further evaluation. Acanthosis nigricans is a pointer towards insulin resistance and dysglycemia in obese children. They need to be further taken care of under a specialist care. So now the last question, which specialist to refer to? In India, we don't have a proper system like in NHS or abroad, where you have a GP referring to a specialist, meaning a pediatrician, and then he referring to further to a specialist. So what we normally do is take an opinion by a consultation, wherein the physician usually takes a consultant's opinion, which is usually combined with his own personal judgment and other considerations to provide treatment for the child. So it could be a one-time consultation, wherein the pediatrician or the physician himself can refer to a specialist for one point of time. Or it could be a transfer of care, which sometimes is done to another physician in order to take care of the management and the whole responsibility of transfer of further care of sick children, which could be almost, could be for a limited period of time or could be permanent. Now this child was diagnosed to be hypothyroid, was initiated on thyroxine treatment, took treatment, as we can see, intermittently, phases of treatment going on. As with all cases, approaching a care service was difficult. And he has, despite being diagnosed quite early, he has not been able to come within the target height range of his genetic potential. So friends, we need to look at role of participative care. There is nothing called referral, I guess. Even if there is a referral for one time or multiple times, it has to be a participative care between the primary physician or the pediatrician and the specialist. We can't beat this. So the pediatrician or referring physician has a key role in picking up abnormalities of growth by use of growth charts, serially monitoring the growth and assessing the growth velocity. When the growth velocity is faltering and weight velocity is also faltering, it is very important to evaluate systemic illnesses which we all can do, nutritional deficiencies, psychosocial issues. Regarding thyroid, as primary pediatrician or care physicians, we should insist on newborn thyroid screening and recognize the red flag signs in the form of, say, constipation, prolonged neonatal jaundice, umbilical hernia, coarse facies, delayed milestones, so on and or a goiter, so on and so forth. Recognize them clinically and maybe preempt them going into a severe form of compromise in terms of thyroid therapy as well as growth. So here, like I showed in my previous case, it has to be a participative joint care because this ongoing therapy is lifelong. And we have to follow the protocol in monitoring. And in pubertal disorders in the afternoon earlier today, they said check the testicular volume in 10-year-olds. But I guess we are seeing even earlier pubertal changes. So as a part of the assessment in girls less than 6 years, it would be good to look at the changes of puberty, do an SMR, recognize the red flag signs. If you're monitoring the growth, if the child is suddenly changing centiles 2 lines, that is a red flag sign, then maybe you can retrospectively check on the pubertal features. Again, it is a participative joint care and follow the protocol for monitoring. These are some points which came to my mind when we said about referral from a trained person to a so-called specialist person. We must look at patient-centered practice. If the patient-centered practice, and it is almost always a shared decision-making. I'm sure even today, many patients believe that what we decide for them is right. But then there are also the other extreme where they would question each and every of your decision. So empowering them with the knowledge would be essential for us to seek better outcomes. Regionalization of care is something which we all should be working towards, and not everything can come to one central place or city. Private-public partnership, programs to address therapy, follow-up and counseling, and training programs for sensitizing professionals and caregivers would be important. Whatever we do, there is always a gap between the specialist numbers and patient numbers. So I think recently there was a discussion in the field of diabetes care about involving more and more pediatricians or the change makers, so-called, or the links, diabetic links, who would link between a diabetes educator, a nurse, the pediatrician, the primary physician, and then the pediatric endocrinologist. Something like that we need to think out of the box so that neither the specialist referrals are overburdened nor they get under-referred for want of a specialist to be around. We do need to make earnest endeavors and expanding of horizons, because we all know children have a very short time to live or tolerate the abnormality of grow and have to live with that for a lifetime. Thank you very much.
I think it is an excellent presentation by respected Sudha Madam, and I congratulate her for a wonderful session. I would like to ask any question from the audience. Yeah, please.
Yeah, so constitutional delay in growth and puberty. So it's like taking a history in detail. So one is you're serially monitoring the child. You have a scenario where you can be more confident to say that this is constitutional delay. So we'll talk of this scenario first. You're serially monitoring. The child starts faltering in height by about 2 or 3 years of age. The faltering continues till he is in the pubertal phase, where he catches up further and he attains his target potential. That is a long kind of prospective waiting. But you want to look at it at one point of assessment. If the height is less than the 3rd centile and the height is within mid-parental height range and the bone age of the child is equal to the height age, bone age delay denotes delay. So the delay is in relation to bone age as compared to the height. So if the bone age is equal to the height age and the height is within mid-parental height, though short, you may want to label that child in the absence of any other illnesses which you must have checked for. You would like to label the child as constitutional delay. One more thing in the delay is a history, family history of onset of puberty in the parents. And usually it is the men, the father who's delayed. Sometimes even with mothers delayed menarche, the girl child could also be delayed. They would be typically giving you the history of being a late bloomer. They were short till in the school time, and suddenly during college, 11th, 12th, they spotted up. When their friends stopped growing in height, they continued to grow in height. Those are some history points which you can ask of the parents, which will help you denote that there is a delay.
Any other question? One thing from my side, yeah, just you are saying atypical genitalia is reported at the earliest, but in our scenario, it doesn't happen because we are reporting only male and female from the gynec part, and atypical genitalia diagnosed later. What is the probable thing you suggested?
So when I said to be referred at the earliest, I meant the labor room call. So if I said like in the early days of life. Suppose you have a delivery, and we know the 5-point checks you should do in the labor room not to miss out on major anomalies. All orifices, the heart, the palate, the central, whatever your the hip joint. Similarly, you need to look at the genitalia. So in the labor room, if you're looking at the genitalia and there is a male-like phenotype in the sense both gonads are descended, the urethra is penile, or a female-like phenotype where you have two openings of urethra and vagina, and you have labial folds which are easily discernible. That is a distinct division as male and female. Anything which is in between needs to be checked. It can absence of descended gonad with penile urethra is also a type of DST. So if you have bilateral undescended testes with a penile urethra, that also needs to be referred before you declare, because that is where most often the errors happen, because the severe virilized form of CAH can present like this.
Yeah, is there any extra column for reporting through gynecologists? Part of it?
So I think the gender is not, or the sex is not declared by the gynecologist. Sex is almost always declared by the neonatologist. Forget that's the ideal scenario. Here, even some mama moshi could be declaring the sex. But having said that, that should not happen. So it should be seen by the new consult on call or the pediatrician on call to see whether the genitals are okay or not. So if you're asking when it is atypical, we need to look at this as a social emergency, take appropriate care, social first, then medical, then cultural, and so on and so forth. So we need to consult, multi-specialist consult has to be taken, and a sex assignment should be tried within 72 hours post-delivery. If it's not possible, there is always a column of the third sex, which can be given in your birth certificate also. And atypical genitalia, we've come a long way from the 90s to now. It's accepted. And there is a lot of discussion and debate happening as to whether we should leave these children alone and not do any surgery. And that's what is happening now.
Thank you, madam. Thanks a lot.
Ma'am has today touched and summarized all the topics of pediatric endocrinology, and it was very point-wise and very systematic matter. Thank you, ma'am. Thank you so much, ma'am.
I request Dr. Devi sir to felicitate Sudha Raman. I request Dr. Praful Patel sir to come on stage, please. Sir. Just come. नहीं. Sharmila ma'am, kindly come on stage, please. Dr. Devi sir. Dr. Neha Singh ma'am. Dr. Girish Sarde sir. Thank you so much, sir and ma'am.
We now have mixed pack session, which we have named Sita or Gita, where two diseases or drugs are quite similar yet different in nature. We have chosen three such twin conditions which we encounter in pediatric practice. I would like to invite Chairperson Dr. Girish Mundara and Dr. Shailesh Chalko to please come on the stage. I would also like to invite Dr. Maninder Dhaliwal to speak on the first set of twins, that is Kawasaki disease versus multi-system inflammatory syndrome in children. We have treated numerous cases of both Kawasaki disease as well as MISC. Both are similar presenting dreaded condition, and it really gets challenging at times to differentiate one from the other. Both have multi-system involvement, critical cytopenias, high risk of complications and death if not energetically treated in time. Amongst the two, MIS-C carries a high rate mortality and end organ damage rate. So I request sir to please guide us more on these dreaded twins.
Yeah. Good evening, all. So I think so. Everybody has treated MIC. Do you think MIC was overdiagnosed? Yes. Okay. So we are on the same page. So the topic is Kawasaki disease and MIC and how to differentiate this Sita and Gita concept. A beautiful concept. I would like to thank Team MAHAPEDICON for an excellent evening yesterday, and we had a good workshop. So thank you for that. So we were bombarded with this COVID virus in 19 and 2020, and then we knew the aftermaths with MISC. So MISC and KD have got similar presentations. The fever, rash, mucocutaneous lesions are common in both of them. And sometimes it becomes difficult for us to diagnose whether it is MIC or it is Kawasaki or what are we dealing with. So the guidelines, if you see the government guidelines, they have divided MIC into MIC with shock. Kawasaki phenotype is a part of MIC and then MIC without shock. So Kawasaki phenotype can be a part of MIC also. So that is there by the government guidelines. And there are multiple studies because COVID first happened in UK and then Italy, the MIC also happened similarly, and then it went to America also. It was labeled PIMS, then MIC. So let's together make it clear what are we dealing with and how to approach such a patient. So Kawasaki and MIS-C are both autoimmune hyperinflammatory conditions that involve multiple organ systems with set diagnostic points as a diagnostic criteria, which can definitely overlap. We'll come to that. But understanding the subtle differences is very important because the treatment varies. On one side, you give only steroids. On the other side, you have to give expensive IVIG, and the follow-up also varies. So the classical Kawasaki has a fever for more than 5 days. MIS-C can have fever for more than 3 days and you can diagnose it. And 4 of the following of the 5 is recorded in classical Kawasaki, that is oral changes, eye changes, a rash, hand and feet swelling or peeling, and unilateral cervical lymphadenopathy. Whereas in MIS-C, 2 of the 5, only 2 of the 5, out of which rash, eye or hand or feet changes, which are first 3 over here, can be only 1 point in MIC. So that's why the Kawasaki phenotype in MIC can happen and does happen. Whereas the other points will be either hypotension, Then myocardial dysfunction by echo or by raised pro-BNP or tropi, coagulopathy by bleeding disorders or raised D-dimers, then acute gastrointestinal problems by even abdominal pain or raised liver enzymes, plus raised ESR, CRP and procal, plus no other obvious microbial cause and evidence of recent COVID. Ab COVID antibody, everybody has taken a vaccine, so wo bhi out ho gaya. So we are now dealing with this scenario in which Kawasaki can be a part of MIC as 0.1 only. So we published this paper again in 2022, where 6 hospitals in Haryana, they joined together, and we found out that anti-pro-BNP and thrombocytopenia was significant risk factors for severe MIC. And interestingly, coronary aneurysms developed more in mild and moderate MIC. None of the severe MIC had coronary aneurysms. They mostly had cardiac dysfunction, but aneurysms were not seen. Coronary dilatation was seen. And a high incidence of gastrointestinal problems were definitely there in all MICs. So they are separate entities. Why? Because we didn't see so many Kawasaki's. When there was a COVID rise, if COVID causes Kawasaki, then we should have seen so many coronary dilatations also. But we didn't see that phenotype. So COVID might not cause Kawasaki. And the etiology and pathogenesis of Kawasaki is still today. It was diagnosed in 1974. Still today, it is not confirmed. What we know, this is published in 2022, is that they both share a proximal pathway of immunopathogenesis. That this, whatever might be the etiology, but the proximal pathway of both of them are same, ultimately resulting in 2 phenotypes. One phenotype, because of this 13 transcript KD gene, they have more of coronary involvement, or in the case of MIC, they have more of cardiomyopathy or GI problems. But they can happen with the same immunopathogenesis. Why it is important? Because the treatment will change. Now, when you're stuck in a patient, you will have a MIC or you will have Kawasaki. Kawasaki will usually happen in a child less than 5 years of age, whereas MIC mostly seen in age more than 5 years. We have seen many in infants also, but maybe we were overdiagnosing. Then hypotension is a strong point in pediatric MIC, where it's a rare manifestation in Kawasaki, hypotension. Altered mental status, GI complaints, respiratory distress are common in MIC and very rare in case of Kawasaki, whereas mucous membrane involvement is very important in Kawasaki. Then comes neutrophilia will be there in both, but here there will be eosinophilia in Kawasaki, whereas lymphopenia in pediatric MIC. Then platelets, this is an important criteria, thrombocytopenia, whereas over here it will be thrombocytosis. Then D-dimer will be raised in case of pediatric MIC. Kawasaki, they are near normal until it is a Kawasaki with shock. Then our pro-BNP, ferritin and CRP all are raised in case of pediatric MIC. Raised ka matlab there's a criteria, more than 20, more than 30. Whereas in Kawasaki, they'll be mildly raised, more than 3 milligram per dl. And in echo, ventricular dysfunction is common in MIC, whereas coronary artery dilatation and aneurysm is common in Kawasaki. And the treatment in pediatric MIC is steroids plus minus IVIG, low dose aspirin. Whereas in Kawasaki, it is IVIG and high dose aspirin. So if a patient has GI complaint, has low platelets, you will definitely not give high dose aspirin. So these 2 points logically say that a patient should have thrombocytosis and should not have abdominal complaint. Then it will be Kawasaki. If the patient has thrombocytopenia and has GI complaint, then it is mostly MIC and you can give low dose aspirin. You understood logic? Agar thrombocytopenia hoga, you cannot give high dose aspirin. Correct? And agar GI complaint hai, again you cannot give high dose aspirin. So logically you can also answer. But what about incomplete Kawasaki? There are some Kawasaki's which are not fully explained. So are they part of MIC? So incomplete Kawasaki don't have the 4 essential criteria. They have fever plus other criteria, or they can be unexplained fever for more than 7 days. Here the CRP will be more than 3 or ESR more than 40. And you do an echo, you get coronary aneurysm, it is definitely your incomplete Kawasaki. But coronary dilatation might not be there. Then you will go for these points, at least 3 of the following: platelets high, anemia, albumin low, and elevated ALT. And then if any 3 are there, you can again treat them as incomplete Kawasaki. Now, but if you see these points, anemia, low albumin, and elevated SGPT can mimic MISU2. So incomplete Kawasaki with these points is very difficult to differentiate whether it is a MIC phenotype of Kawasaki or it is incomplete Kawasaki. So again, I told you the 2 points: thrombocytopenia and abdominal pain. If it is there, then it is MIC with KD phenotype. If there is thrombocytosis and no abdominal pain, it is incomplete Kawasaki. Keep it very simple. So again, these points like unexplained fever, irritability, patients with prolonged fever, unexplained shock, culture negative shock, they can all be a part of incomplete Kawasaki. And we had this patient also mimicking peritonsillar abscess, but it was a case of MIC. Just imagine a retropharyngeal abscess was there, but we gave steroids. We aspirated, it was culture sterile, so we gave steroids. So it was a rare presentation. Then what is atypical Kawasaki? It is all the features of Kawasaki are there, but the patient has respiratory or kidney involvement. So you have coronary dilatations, but lung and kidney is also involved. So this can be MIC also, KD phenotype. Again, the confusion starts. The only differentiating point is abdominal pain and thrombocytopenia. Then it is MIC. If no abdominal pain and thrombocytosis, it can be atypical KD. And this is the score which is recently published. It is called as the Kawasaki MIC diagnostic score. If the CRP is more than 11 milligram per DL, 18 points, D-dimer more than 600, 27 points, age more than 5 years, 30 points, platelets less than 1.5 lakh, 25 points, and GI involvement, yes, 28 points. If this total score is more than 55 points, then it is called as MIC. And over here, again, if you say only take age, which has 30 points, and GI involvement has 28 points. These are the 2 highest points. Then come platelets. 30 plus 28 is 58. It will come to simple. So this study was done in India. All the studies of MIC which are published were done over here. They were studied. The KD-like features were not so common in India. Whereas in other countries, MIC can present with shock, it is 30%. MIC with Kawasaki, it is 30%. MIC with just febrile inflammatory state is 30%. In India, KD type phenotype was very less. So let's take this case. Fever for more than 4 days, pain abdomen, tolerating feed, age 6 years, ESR is high, neutrophilia, D-dimer, this type of rash is there. So whether it is MIC or KD. But these criteria should not be routinely employed. These criteria should be only employed when you have a confusion of MIC and Kawasaki, not for diagnosing Kawasaki or MIC. Only clinically you are confused. That time only these criteria will help. Otherwise, not to be routinely employed. So if you see over here, we get 28 points for this, 30 points for this, CRP high, low platelets. So it is MIC with Kawasaki phenotype. So now comes the treatment part. So management on all the 3 parts, whether it's MIC, Kawasaki or MIC with shock, it is steroids. But the dose of steroids in all 3 is 2 mg per kg per day, not 10 mg, not 20 mg. It is 2 mg per kg per day. So please change it. Only in case of shock, if the patient does not respond to 2 mg per kg, then you go to 10 mg per kg. Then you go to 20 mg per kg. Don't start with 30 mg per kg. And this is government guidelines. It's there in the net Ministry of Health and Family, and we follow this only. So the steroids should be used very limited. But in case of Kawasaki phenotype, you have to give IVIG over 16 hours. In case of MIC with shock, you have to give MIG again over 16 hours. So IVIG is common in both Kawasaki phenotype and MIC with shock. Clear? So evolution of steroids, why I want to harp on it is because in 1974, if you see, no steroids were used. Then high dose steroids came. 84, again no steroids. Then again in case of 99, use of low dose steroids came. Then there was a area when it was not used, that is our era. And then I'll come to that. So this was an era of steroid success, 70s. Then era of steroid excess, then steroid abandonment, and low dose steroids were used. And now again, there is return of steroids after COVID. And believe me, steroids always harms a body. It might give transient results, but it will always harm the body. So be very judicious or cautious in your use. Don't use it liberally. So follow up in a case of MIC, if you have to do echo, then only with patients who have cardiac involvement, like low ejection fraction or aneurysm co-dilatation, repeat at 1 week, 4 to 6 weeks, and at 1 year. It is same as uncomplicated KD, 1 week, 4 weeks, and 1 year. Whereas in KD, you have significant coronary involvement, Z-score more than 10, then at least twice per week till luminal dimension stabilize, then 2 weeks, then 6 weeks, 3 months, and 12 months. This is rare. This is common. So follow-up changes when you label a patient as MIC with Kawasaki or KD. Dose of aspirin is 3 to 5 mg in MIC because in thrombocytopenia, you won't give high dose. Whereas if you label Kawasaki, then you have to give high dose aspirin till the patient is afebrile. And over here, you have to continue it for 4 to 6 weeks till the coronaries become normal. And over here, 6 to 8 weeks. Then low molecular weight heparin, not to be used just following D-dimer. D-dimer is not a criteria to start low molecular weight at all. Criteria is either thrombosis or aneurysm with Z-score more than 10 or a shock with ejection fraction less than 30. D-dimer is a diagnostic criteria, not a criteria to start heparin. In the case of low Kawasaki, again giant aneurysms or there is associated stenosis or peripheral gangrene. So whenever you are in doubt, you must involve pediatric cardiologist. This is irrespective of doubt. But if you have got these patients like incomplete atypical or shock type syndromes or hyperferritinemia, it's better to call another pediatrician because you need to discuss it out or involve a pediatric rheumatologist or a pediatric intensivist. So overconfidence can be dangerous. Discussion is a way forward in this Sita-Gita scenario. And thank you.
Sir, I would request Dr. Girish to please felicitate Dhaliwal sir. I would like to invite Dr. Narendra Naniwadkar sir as a chairperson for the next session. Thank you, Dr. Dhaliwal, for guiding and clearing our doubts. May I invite our next speaker, Dr. Tarun Kanade, for the next double-edged, confusing set of lookalikes. Although somewhat different in etiologies, their manifestations are quite overlapping. Both present clinically with fever, hepatosplenomegaly, marked hyperferritinemia, cytopenias, coagulopathy, and if not treated, end organ failure and death. Yes, I'm talking about hemophagocytic lymphoproliferative histiocytosis versus macrophage activation syndrome. Both are potentially fatal syndromes caused by disorganization and malfunctioning of the immune system. So I call upon Dr. Tarun Kanade to enlighten us regarding the same.
Thank you, Neha. Actually, I'm a substitute player. Dr. Anand Butala was supposed to take this talk, but unfortunately, he had a medical emergency in his family, so he had to leave for that yesterday itself. So he found I'm the best person to handle this. Ideally, this is a topic related to rheumatology. So, but let's see how we can best explain it in the best way possible. So, as the the theme of this session is Sita or Gita. We have Sita as well as Gita with us. Let's see what is the difference between them. So this case, this was a case which presented to Anand at his hospital, was a 3-year-old female child who came with fever for 3 days, which was continuous high-grade fever with rapid breathing and decreased oral intake with lethargy were the predominant complaints at the time of admission. The child was dull but arousable. She had fever with mild tachycardia. CRT was preserved. There was no shock. BP was preserved. The saturation was 95 at room air. There were mild retractions were there. There was a faint erythematous rash, probably related to fever. That's what was a primary impression. Significant pallor was there, and there was insignificant cervical lymph nodes. But what struck the treating physician was the hepatosplenomegaly. It was a large liver, a large spleen in 3 days, which was it showed us some sort of a red flag. The chest was clear. The child was investigated, was found to have anemia. The platelets were significantly low, 47,000. CRP was significantly high. Here, we would like to highlight this investigation, which is in blue, but actually this should be in red. That is ESR. In child in whom you are getting certain atypical features like hepatosplenomegaly, rashes, go for a ESR. It's a very low cost investigation, but which will really help you in guiding you further on, because as the disease evolves, a rapid rise in ESR will tell you that this is probably non-infective in origin. The creatinine was good, INR was raised, ferritin was 1496. Now, ferritin is a very tricky marker. It is telling us that there is definitely some amount of inflammation, there is some amount of cell destruction, but still this is not landed up into a really very bad inflammation. So this ferritin is high. This is telling us there is some inflammation, but this is not a very bad inflammation as yet. All the infective profile which we could do was negative. Blood culture, urine culture was sent, which was later came out to be negative. Chest X-ray was normal. The sonography showed hepatosplenomegaly. The 2D echo was normal. So Dr. Marinda's Sita or Gita is out. So that means we are not dealing with MIC. We are not dealing with KD. Fibrinogen was low. Triglycerides were raised. And Coombs was negative. Now, these two investigations are very important. The importance will come down subsequently. The child was having thrombocytopenia, anemia, 2-cell and depression. So bone marrow aspiration was done. It showed 10% histiocytes with few erythrophagocytes. There was erythrophagocytosis. Erythrophagocytosis means our lymphatic cells itself ingest the RBCs. So you see RBCs inside the white blood cells, inside the lymphocytes. That is erythrophagocytes. Now, this patient must be really a rich person because they had done soluble CD25 antigen, which is really a very costly test. I think it cost somewhere around 8,000-10,000. The observed value was 4,500, which is really very high. And this is telling us that this is very significant by the HLH criteria. So diagnosis was on the basis of bone marrow aspiration with 2-cell and depression with fever with CD25 positive, that this child is having HLH. Now, meanwhile, by the time these investigations were being done, the child worsened with persistent fever, pallor, the respiratory distress worsened, and child had to be intubated and mechanically ventilated. Was put in adrenaline drip, had a central line in place, was transfused with PRBCs, platelets, was given IVIG, steroids, because we didn't have a diagnosis till then. So was given IV antibiotics, steroids, IVIG, and supportive care. But a diagnosis came out to be HLH. So what is a diagnostic criteria for HLH? This is according to 2009 guidelines. We need to have at least 3 of these 4, that is fever, splenomegaly, at least 2-cell and depression. There should be some cytopenia and hepatitis. So these, out of these 4, 3 should be there. Usme se fever is the most important. And at least one of the following 4, that means you should have some evidence of hemophagocytosis either on the peripheral smear or on bone marrow aspiration. You should have increased ferritin, increased ILR2, that is age-based levels, absent or very decreased NK function. Now, this is a very specific test, needs an immunologist or a hematologist for this. Other things, that is hypertriglyceridemia, hypofibrinogenemia, and hyponatremia. These all are supportive evidence of HLH. Now, what is basically familial HLH? It is basically a form of cytokine storm. these lymphocytes or these our white blood cell gets stimulated because of certain genetic factors as well as certain secondary factors. Both these things should act together, and they lead to the movement of cytolytic granules to the site of contact, degranulation, and delivery of these cytolytic granules to the target cells, leading to destruction of the target cells. So it leads to destruction of the RBCs, destruction of the platelets, leading to thrombocytopenia and leukopenia. There are various mutations which have been identified, which are seen in these hemophagocytic syndromes. The most common ones which we have seen is STX11 defect over here. STAX1. Okay, this is one which we see very commonly. Griscelli syndrome is another thing which we see commonly, but it requires a highly specialized immunologist to diagnose these things. Chediak-Higashi is a congenital immunodeficient syndrome. So what happens basically, there are certain mutations in primary HLH with pro-inflammatory cytokines in secondary HLH, so they act together, leading to overactivation and proliferation of macrophages, leading to a cytokine storm, which leads to phagocytosis. So आपलंच सैनिक आपल्याच शरीराच्या विरुद्ध काम करून शरीराची पेशी मारायला सुरुवात करतात आणि त्याचा जो रिझल्ट आहे तो म्हणजे HLH. So what result we get these. We get unremitting fever, we get lymphadenopathy, hepatosplenomegaly, multi-organ failure, and along with that we get hyperferritinemia. Ferritin कुठनं येतं? Destruction, yes. RBC cells are getting destroyed. All that hemoglobin चं heme बाहेर येतंय आणि त्या heme मधलं जे iron आहे त्याचं रूपांतर ferritin मध्ये होतंय, and that ferritin is getting accumulated in our blood. So that's why you get hyperferritinemia. Now this patient which we had was not very high, had around 1400 of ferritin. But if this patient would have followed the ferritin, it would have gone to thousands because the hemophagocytosis was just starting. Now there is something called as glycosylated ferritin also, which is again a very specified test. जसं आपलं glycated hemoglobin असतं, तसं glycated ferritin पण असतं. Glucose combines with this ferritin, which results in glycosylated ferritin. If it is a chronic process, then glycated ferritin will be high. If it's an acute process like in this child, glycated hemoglobin will be low despite hyperferritinemia. Okay, so it will again give you evidence that this is something acute. So this is probably HLH. Now there is certain, there are two entities what we know is primary HLH and secondary HLH. The treatment little varies because primary HLH, you need very high immunosuppression. You had dexamethasone, etoposide, cyclosporin with or without methotrexate, depending upon whether the child has CNS manifestations or not. And if this is resistant, the child will require some form of transplant because the child will have to go for a hematopoietic cell transplant. For secondary HLH, which is secondary to certain infections. Okay, it depends upon what trigger. Like we had recently a child which was shifted to Mumbai and subsequently came out to be HLH. This child had probably something like a EBV-like picture with very high grade fever, cervical lymphadenopathy, fever remitting, going on for a long time. Not all infective parameters negative. So EBV triggering HLH. Almost all patients receive steroids. Mild cases can be treated depending upon just the treatment of underlying disease. But in certain conditions, in severe cases, we need to use anakinra. Anakinra is available in India now, very costly, but available. Because of COVID, lots of these drugs, immunosuppressants are coming into picture. A lot of biologicals have come, rituximab, Alta-2, they can now pronounce karta yet nahi. So again, in these cases, resistant HLH, again, hematopoietic cell transplant is an option in refractory diseases. Now let's come down to MAS. So MAS is basically macrophage activation syndrome. A febrile patient with known or suspected systemic juvenile idiopathic arthritis is classified as having MAS if the patient has the following criteria. Again, over here, ferritin around 600, not very high, and any two of the following. So hyperferritinemia with low platelet count, high SGPT, platelet count less than 1.8, SGPT more than 48, high triglycerides, low fibrinogen. Okay, so here we use the 160-360 rule. 160 is the triglyceride, so triglyceride should be more than 160, and 360 fibrinogen should be less than 360. So 160-360, we remember that to remember the values because hey, values itke easy lakshat rahat nahi. But for MAS, we use this formula. This is according to the latest 2016 guidelines. So what happens in mass basically? Let's come to know what is the pathophysiology in mass. Again, here there is a cytokine storm which occurs similar to that as in HLH also. We see a lot of TNF alpha, IL-1, IL-18 coming into picture, leading to destruction of cells. These inflammatory infiltrates consist of predominantly histiocytes and T cells, mainly CD8, a feature which is shared with primary HLH. So these cells produce large amount of cytokines, interferon gamma, IL-2, IL-6. हे सगळं आपण आपल्या MBBS मध्ये स्किप करायचो, ते सगळं ते सिक्रेट करतात. आणि it leads to again there is hyperferritinemia in MAS, release of free hemoglobin, जे आता आपण डिस्कस केलं, increased production of ferritin. There is elevation of serum ferritin in mass is striking. Now here there is significant destruction of RBCs, so you get a very high level of ferritin. The usually ferritins in mass we get about 10,000. मग तुम्ही म्हणाल आता ते 1400 होतं, मग 10,000 कसं असं? So these children are usually having some form of rheumatological disease underlying. Already त्यांचं destruction चालू आहे आणि त्यावरून mass झालेला आहे. So already their ferritins will be high, and superimposed on that there is cytolysis. So ferritin is going to be sky high. So major differentiating factor between MAS and HLH is the level of ferritin. So a rheumatological, if you ask him, तुम्ही कसं different, you'll see what is ferritin. आपण म्हटलं 4,000, नाही मग ते mostly HLH असणार. आपण म्हटलं 15,000, then it's probably MAS. Again here they have to here the importance of glycated hemoglobin ferritin will be more. If the glycosylated ferritin is high, that means it is probably a chronic cell destruction, and hence probably it's going in favor of a MAS. So genetics in MAS and HLH, whole exome sequencing revealed increased burden of rare variants in SGI and MAS patients compared to healthy controls, and targeted sequencing of pediatric HLH associated genes revealed pathogenic heterozygous variants in 30 to 40% of mass patients. So 40% similarity is there. So to summarize, what is HLH and what is the difference between MAS? HLH is basically a severe life-threatening hematological disease, whereas MAS is a severe life-threatening rheumatological disease. Okay, so rheumatology and hematology as दोन थोडासा फरक आहे. Causes primary HLH is usually due to mutation in genes. Okay, that code for cytotoxic T cells and NK cells. Secondary HLH is associated with malignant and non-malignant diseases that weakens the ability of immune system to attack EBV infected cell. Whereas in mass, it is often a viral infection or a medication which triggers the MAS. Symptoms दोघांचे सारखे, तुम्ही वाचू नका ते सगळ्यांचे जवळजवळ सारखेच आहेत. Rash is more frequent in HLH as compared to MAS. Diagnosis of HLH is based on physical examination, blood testing, and molecular testing for genetic mutations. Whereas for mass, it is by bone marrow aspiration and imaging. Treatments is slightly different, but the bottom line, जसं मनिंदर सरांच्या टॉक मध्ये होतं, it remains the same. Corticosteroids, immunosuppressant drugs, and certain chemotherapy medications in HLH, steroids, IVIG, cyclosporin in MAS. तुम्ही म्हणाल सर तुम्ही तर सारखं तेच गोष्ट रिपीट करताय. ऍक्च्युली इट इज जस्ट द फ्लिप ऑफ अ कॉइन. आणि हा कॉइन पण कुठला आपल्या तुमच्या माझ्या खिशातला नाही, तर शोले मधला आहे. ओके, सो दिस इज प्रॉब्ली द सेम फीचर विच वी आर, द टर्मिनॉलॉजी इज डिफरंट. अमेरिकन पीपल आर व्हेरी स्मार्ट. दे हॅव टू सेल ऑल दीज ड्रग्स ना. त्यांनी काय केलं, दोन वेगवेगळ्या एंटिटीज बनवल्या. जसं आपल्याकडे असतात ना फार्मा कंपनीज, 2 डिव्हिजन्स असतात, दोघे एकच औषध विकत असतात आणि एकच कंपनी असते. तसं आहे ते. We're not going to dark over that just for the sake of fun, but mass is basically the basic differentiating feature is MAS comes in rheumatological conditions, and HLH we have to diagnose it properly using proper criteria with fever, cytopenias, hypertriglyceridemia, hypofibrinogemia, and we have to document hemophagocytosis. So early suspicion, early treatment gives good results. If the disease progresses, the results are not that good. So have a high index of suspicion, especially when you have these red flag signs. With this, I end my talk, and everybody is invited for the MAHAPEDICON, which is in Pench near Nagpur next year in January. Thank you.
Thank you, Dr. Tarun. Sir, I request, sir, felicitations.
Thank you, Dr. Tarun. It's a very difficult topic to understand and complicated topic. It may take a full day session to understand this topic like HLH. Thank you.
I would request the doctor to please felicitate Tarun Kanade sir.
Any questions? I'll just add, if you have seen movie Sita or Gita, then it's their mannerisms and in the way they deliver their dialogues and the way they enact, you come to know who is Sita and who is Gita. And you have, both of you, Dr. Maninder as well as you, have tried to differentiate that fine line where we can differentiate one from the other. Although I just wanted to know, are we not going to include bone marrow as a criteria for HLH?
So we need to document hemophagocytosis. That can be documented either in the peripheral smear or in the bone marrow. If it is absent in the peripheral smear, then we need to go do a bone marrow. Yes, sir.
First HLH test, you said ESR is high, but there is a hypochondroplasia. Actually, there is a complication with HLH. ESR goes down and they have said to be a criteria where fibrinogen is not available. If ESR is low and the patient is critical, then you can.
So you need to track that ESR. The ESR that is probably that ESR.
Yeah, what was important was you showed the graph, not the graph, the table or the chart. And for any critical patient, charting all the investigations, mainly the hemoglobin, WBC count, platelet, as well as the ESR is very essential. So that gives us an idea as to how the child is progressing or is deteriorating.
Thank you, Dr. Tarun, for giving a clear idea about both these dreaded conditions. I would like to invite our next speaker, Dr. Parmanand Andharkar from Thane, for speaking on the next set of twins. The confusion is not only with the diseases, but also with certain drugs. Most commonly used drugs like adrenaline and noradrenaline also perplex us at times. While one is a neurotransmitter secreted from synaptic nerves and other is a hormone secreted by adrenal medulla. So let's call Dr. Parmanand Andharkar for getting a lucid understanding of the same.
I'll just add 20 seconds. Let us wish Dr. Parmanand a very special happy birthday. It's his birthday today. And it is our Parmanand to wish him on his birthday by meeting him physically. Please go ahead.
Thanks everyone. At the onset, I thank the organizing team and Children Madam for giving me the talk in this conference. The Gita and Sita, the adrenaline, noradrenaline. At the onset, I congratulate Tarun to take the talk on a last minute, which is a difficult talk to, and as an intensivist, we work at the last minute. So and it was an excellent, and you defended well. So like a Sita and Gita, which one is an alligator? So I will start with this question. What is desirable to achieve in the cardiovascular hemostasis? We want the patient, if the patient is in a shock, to achieve normal blood pressure percentiles. We want to treat the shock or optimize the cardiac output to achieve tissue perfusion. Again, these are all Sita and Gita. So it's what to achieve and what not to achieve. I'll try to answer this question in my talk. We all know epinephrine and norepinephrine belong to the compounds catecholamine. And these compounds are neurotransmitter as well as the hormones. But the structures are quite similar with little bit of difference. But the effects on the body are different. And that's what it is important to understand. Both play a role in the regulation of sympathetic nervous system and responsible for fight or flight. When in the case of, in a normal situation, when you are in a stress or in a patient, like you have thing, it will improve the heart rate. That is the normal hormones which will be usually secreted in our body. But what we are going to talk about when there is the special situations when the patient is in a shock. They are all secreted in either the adrenal medulla or the sympathetic nervous system from the amino acids from the tyrosine to convert it to dopa and then to dopamine. Few of the receptors, the nerve endings, there are no other enzymes and they stop at conversion to the dopamine. It is called as dopaminergic receptors. And when they stimulate, they only produce dopamine. But in the other nerve endings, they get converted into NORAD only in adrenal medulla. In the adrenal glands, in presence of these steroids, the NORAD gets converted into the adrenaline. If the same chromatin tissue is present outside the adrenal medulla, they may not convert NORAD to the adre. So it is the adrenaline for the conversion of NORAD to adre, the steroid hormones are required. So how they act? Usually we'll see with the epinephrine, it acts on alpha, which increases the heart rate, that is tachycardia. And we know that it works on alpha, beta, and the other receptors. But the adrenaline works in two different dosages. The low dose, it has a different action. It increases the heart rate, increases the cardiac contractility and vasodilatation. That is your beta 1 and beta 1 and beta 2 receptors which get stimulated in the low dose. But as you go on increasing the dose of the adrenaline or epinephrine, it goes into the alpha action and more of it predominates and cause the vasoconstriction. So same dose, same drug have a two different action in the low dose and the high dose. But norepinephrine, it is a potent vasoconstrictor and increases the cardiac output. It preferred drug in the is the preferred vasopressor in the treatment of the shock. So it has a more of an alpha action. So adrenaline, low dose, you can have increased heart rate, improve the cardiac contractility and decreasing the SVR. But here on noradrenaline, it may increase the cardiac output, but it is going to increase the SVR. And I will explain you in the next slides how it works. To understand these vasopressors or vasoactive drugs, what few definitions for few had to be clarified. What is chronotrope? Inotropes, the negative and the positive. Usually we like to look at the positive inotropes are the drugs which increases the cardiac contractility. Chronotropes, which increases the heart rate. And we know that in the pediatric age group, most of our cardiac output depends upon the heart rate. If there's a bradycardia with good stroke volume, still the cardiac output will not be achieved to sufficiently maintain the tissue perfusion. So the drug when we are choosing, you have to increase the heart rate and cardiac contractility. So it has to be chronotrope also. Vasodilatation. We are talking of a patient, vasodilators in a shock. Yes, sometimes we may have a good blood pressure and we want to decrease the SVR. We want to vasodilate. So some drugs like dobutamine, milrinone, these are the drugs which may act as a vasodilators. Then lastly, the vasoconstrictors. Those patients with a septic shock, we like to use the drugs like a vasoconstrictor, noradrenaline or vasopressin. These are the drugs which only increases the SVR or is a vasoconstrictor. So to understand the same drug, how it clinically we can apply in our day-to-day practice, we will go through. This is a recent case which is still admitted in our ICU. This is a 13-year-old female child, came with fever for 4 days, cough for 2 days, and respiratory distress for few hours prior to the admission. Febrile, heart rate of 140 per minute, respiratory rate of 30 per minute, blood pressure 88, or initially when they came to the casualty, actually 70 systolic. SpO2 was 88. So it was a poor perfusion and it was like a hypotensive type of shock. When there is we like to have the classify first, it's identify first, it's a shock, the PALS guidelines. It's an hypotensive, what's the type? It's a hypotensive type of severity, it's a hypotensive type of shock. And is it because of what? Septic shock. So it's with severe pneumonia. This was our working diagnosis when it came to. We did the blood gas, which was showing the pH was maintained, but their bicarb low and the lactates were high. That suggests that the perfusion was getting affected. So we followed the guidelines. We gave the fluids. We started, first drug to start is an oxygen with non-rebreathing mask taken, and the cannula, administered the fluids and given first drug of the antibiotic in a septic shock in the first hour and sent the blood culture. And after giving around 40 ml per kg of fluids, still the blood pressure was low and was diagnosed to have the persistent hypotension. So it's a fluid refractory shock. Now it's early. We like to use the vasopressors early because it's a low blood pressure. We like to improve the blood pressure in this situation. Then the question comes to our mind, what next? What inotropes and what route? So we started on noradrenaline through peripheral line. Some in the initial situations, we are, because these are the vasopressors, if we give through peripheral line, it can cause gangrene. So in this situation, you can use double dilution and start with, because to take a central line at that time also it takes time, sedation. So you start NORAD, improve the blood pressure, and then you can put your central line. Then subsequently we taken a central line and started on noradrenaline with then how to proceed further. The question comes to mind. We started NORAD. How I should decide a drug in a septic shock? Which again, what action you want? What do you want to monitor? And how to titrate and wean off that drug? So again, the question which I started, what I want to achieve, a normal heart rate, blood pressure, or to treat the shock or optimize the cardiac output to achieve the perfusion. So remember these three simple equations. What is it showing? A DO2 is the product of your oxygen content multiplied by cardiac output. So if you feel the patient is in the shock, you just remember one thing. CO2 means the oxygen content. If the hemoglobin is low, the oxygen binding the receptors are less. So the tissue perfusion or the oxygen delivery to the tissue will be less. In that situation, you use blood, like an hypovolemic or a traumatic in a situation with bleeding. Then cardiac output. If my cardiac output, even my hemoglobin is good, but my cardiac output is not good, how am I going to deliver this oxygen to the tissue? So I had to improve the cardiac contractility. That just means my cardiac output depends upon the stroke volume and the heart rate. So I had to increase the heart rate as well as my stroke volume. Then I had to think what drug I am going to use to improve the cardiac contractility and the heart rate. Then the mean arterial pressure, it depends upon the blood pressure, what you want to achieve to perfuse the organs. It depends upon the cardiac output and the SVR, that is systemic vascular resistance, peripheral. If your cardiac output is good, but my SVR is more or like it is less, that is happens in a shock, with a traumatic shock or a septic shock. So if my volume is there, but it is not getting, it is causing a relative hypovolemia. Or is my cardiac contractility is not good, like a cardiogenic shock, and SVR is high. So these are different situations which I had to, that's reason this equation you keep in the mind when you have the patient with a low blood pressure. And then you choose the drug depending upon the what action you want to achieve in that particular child. So if you feel it's a hypovolemic, give fluid. Correct? So think, if the patient is having a loose motions, bleeding because of the trauma, give blood, give fluids. If you feel the pump is a failure, means like there is the crepitations on your auscultation, your heart rate is very high, and your liver is palpable, you may think of a cardiogenic shock. You want the pump to contract, so use a drug which will increase the cardiac contractility. Then you reduce then look at the afterload. Afterload, how I will know clinically my afterload is going to be low or high? If my blood pressure has a narrow pulse pressure, so you take a blood pressure which is narrow, maybe 90/70, and I have the same patient, second patient, I am giving you 90/30. 90/70 is a narrow pulse pressure. So that suggests that there is a cardiac contractility is not good. If that same 90/30, that means it's a peripheral vascular resistance is low. and the diastolic is low. So I have to use a drug which will increase the SVR. So you don't have to monitor, your just blood pressure can tell you your SVR is, how is your SVR. So that can tell you that it's a cardiac contractility is good or no. So you keep this in mind and what you want to achieve. So what are the physiological variables? You look into the shock. The hypovolemic, you know that it's a fluid loss because of either it's a gastroenteritis or in a septic shock because of the low SVR. Then the most difficult question which comes in mind in your ICU is to treat the septic shock. In initial phase of the septic shock, the SVR is low. So it's a warm shock. The patient will come with irritability, but blood pressure may be normal. But if you don't correct at that time, then the body's response, the catecholamine secretion goes up and it becomes a narrow or a cold shock. And if still it is not untreated at that time, so what happens is the cardiac dysfunction start. So you have a situation, your pump is not contracting and there is a vasodilatation. So whatever the fluid coming out of the blood coming out from the heart, there is a vasodilatation. It is not, that's a relative hypovolemia. So it is severe hypovolemia is going to occur in the body. The perfusion is going to get affected. So I had to use a drug to increase the heart rate and the contractility and increasing the SVR. Now low dose of adrenaline, what I said, it will increase the contractility, but it will vasodilate. But if I use adrenaline at high dose, it is going to worsen my SVR. So I am going to get confused at that time how to choose that drug. So in this situation, I may use the other drugs like dobutamine or something with the blood pressure is normal to improve the cardiac contractility, I know. And then I use a vasopressor, I know how much to titrate that to have that SVR to maintain the organ perfusion. Correct? So you have to judge, that's the reason that 3 equations has to be summarized, keep in mind when the patient is in shock. Then cardiogenic shock, you know that the venous return is good, the pump is filled, so that there is a accumulation of fluid in the body. Cardiac contractility is not good, so the cardiac output is not good. So you have to choose a drug to improve the cardiac contractility and decrease the SVR. So low dose adrenaline and dobutamine is the drug of choice. Here I am not going to use the NORAD. So algorithm identify the problem, correct the problem and monitor the response. Same equation. The stroke volume is the product of preload, afterload and contractility. Multiplied by heart rate is your cardiac output. I am repeating this because it has to be summarized in your body when you, in mind when you are choosing the drug. So you optimize the preload by giving blood and blood products. So then you choose, now this is the most important chart in you want to understand. Adrenaline, inotrope, that is going to increase the contractility, increasing the heart rate, vasoconstriction and vasodilatation. But this is different in different dosages. Look at noradrenaline. It is only vasoconstrictor. Dobutamine has the different actions. So high cardiac output, low SVR, use norepinephrine. Low cardiac output with high SVR, use low dose epinephrine. So just the case continued. The in view of persistent hypoxemia, 2D was done, which was showing LV dysfunction of 40 to 45. It was on NORAD. No pericardial effusion, bilateral pleural effusion. So now we are already on NORAD to increase the SVR. Now what we have done an echo because the perfusion was not good. And what is this showing? LV dysfunction. So now I had to choose a drug to add adrenaline to increase the cardiac contractility and decrease the SVR and titrate it. So same thing now we see with the GLS. This is a new thing which is coming up. See the thing. So this is not contracting heart. This is now the cardiologist help we take it to understand what is the LV function of that, and we try to choose a drug accordingly. So after 20 hours of admission, the child had a persistent tachycardia, tachypnea. Urine output was 0.6 ml, but there was positive balance of 3.2 liters. BP maintained now above 95 percentile. See the chart. But tender hepatomegaly and gallop rhythm started. And it is now adrenaline as well as noradrenaline. You have achieved the blood pressure. The first question, you have achieved the target. Has the patient improved? No. So achieving a blood pressure is not the answer when you are talking of a blood, like and treating a shock. So you monitor, it was showing the worsening cardiac function. So what is physiologically? What was happening? It was a cardiac dysfunction with volume overload. Correct? Correct. He's in gallop rhythm. And then with increased SVR. You see the blood pressures now? All are high. So your high SVR, cardiac contractility is not good, and you have volume overload. Now what will you do? You have to, in this situation, fluid restriction, like a cardiac failure, give Lasix, get rid of that extra fluid, then added calcium as an ionotrope. So increase the cardiac contractility. Then noradrenaline, now you start tapering because you don't want that SVR to be high. So you reduce the afterload. So it's a jugglery. You have to be on a bedside to look into it, what you are treating. You are giving Lasix, you are removing the fluid, you are increasing the cardiac contractility and reducing the afterload. That means you have to understand what is the physiology which is happening in the body when you are treating a patient in a shock. So the child persistent had a respiratory distress after that also, worsening of acidosis and lactate levels were rising. So now, in spite of doing this, patient was in persistent shock. That is an indication also to intubate the child. So that's an answer when to intubate. So here again, it is going to, intubation is going to decrease the afterload. So it will increase the cardiac function by 20% also. So it is going to improve in that. So the elective intubation also is important in those patients who are not improving. So the LV functions were severely deranged. Now it's to 5%. LV has worsened to 5 to 10%. So noradrenaline was tapered and stopped. We continued low dose adrenaline and fluid restriction to decrease the preload. So this was the initial phase. You look at the lactates which are 4. Now see the lactates which has gone up to stain, and then after jugglery, then it has come back to 1.5 or 1.5. So that now here the blood pressure is normal and the lactate has become normal. That means the tissue perfusion has now become affected. It's like an improved, and the blood pressure is normal. So that means your end organ perfusion is also improved and your urine output. This is the answer for your question. So epinephrine, norepinephrine, it works on alpha and beta receptor, producing mostly potent vasoconstrictor. Epinephrine low dose, its work as an inotrope and conotropic effect with vasodilatation. At high doses, alpha action, it causes vasoconstriction. In norepinephrine is preferred drug vasopressor in treatment of septic shock, and epinephrine is a second line in a septic shock as well as the drug of choice in anaphylaxis. So what is this type of patient shock now? Please, this is not the same patient, it's a different patient. It's a cardiac patient, it's showing a pacing also in this. Now what's the blood pressure? 63/53. No? So it is narrow pulse pressure, it's a cardiogenic shock. The drug, if you want to, which drug? If you want to give, it's a low dose, adrenaline or dopamine. So which drug? Look at the contractility there, see the dilated LV and see the LV here. Here, what you want, the volume lower, this cardiac contractility is not good. So you expect that here, the narrow pulse pressure, you want the drug to choose is to increase cardiac contractility and decreasing, it's the adrenaline is a drug of choice here. If you have this good contractility and the patient is in a shock, here I will use the NORAD. So it's the same thing which has to be looked into at low dose adrenaline with norepinephrine. So I want to see this chart, keep it in your in your ICU or in the working, different actions, different drugs. This is most important. So you choose that which drug you want, and the dosages of adrenaline and noradrenaline can be summarized and kept in your the ICU to titrate the drug according to your patient's requirement. So irony of inotropes, none of the drugs works on an empty heart. So you have to give fluids. No single magic drug works. It's not that only adrenaline, my dopa dubit diya. Yeah, my only dopa diya. It doesn't work. Rigid protocols usually often fail. So guidelines are to initiate the treatment, but if you have to monitor the child and titrate your drug accordingly. Same drug may not work in the same situation. So you have to bedside titrate and give it. Same way same drug may not work if the same patient come later on. So you have to choose according to the clinical situation. And Tarun will agree, no two consultants will agree with each other which drug to use. Thank you very much.
Thank you, Dr. Parmanand, for throwing a light and showing the practical application of epinephrine and norepinephrine ICU setting. Any questions?
Any questions?
Slide. None of the drug is out. Dopamine is also there if you are practicing. So you see the last slide. Bus. So he has a see the action. It is a 3 different actions. Yeah. So what action you want? It's not easy to answer dopamine. What action you want? You choose the drug. There's nothing wrong in that.
I think the carry home point is that you take this stock of the situation, you see all the parameters and then choose the right drug. And
keep it in mind.
Yeah.
Keep those 3 principles. What is there in that patient and bedside? There is no rigid protocols. That doesn't work.
Warm shot and cold shock difference is in youth we are using the
There is a study done by Dr. Suchita Ranjit when the cold shock. They have put in an arterial line, and those patients also are found to be vasodilatory shock. So it is the arterial line has to be in. So in clinically with the NIBP, it may be falsely high in the patient when they are cold extremities and they are normal pressure. So they may be vasodilatory, but the extremities may be cold. So you have to have an art line inside to diagnose that what drug. So maybe a drug clinically looks like an adrenaline, but there when you put an arterial line, it's a vasodilatory. Then you use a drug vasoconstrictor that is vasopressin. Sorry, noradrenaline or vasopressin. There's no just like can do this or that. You have to have clinical judgment. Every drug is good, whether it's a dopamine, dobutamine, adrenaline. Only thing, what action you want in that patient, you have to understand, and then monitor and titrate the drug accordingly.
so what is your take, sir?
See, my personal practice is I use dobutamine with NORAD.
Yes.
So I know where I am going to look at. If I want to increase the cardiac contractility, I will keep at 10. And I will use NORAD. I have a 2 vasoconstricted, I will reduce the NORAD. Problem with adrenaline or dopamine, if I reduce the dose, the action change. So my personal practice, I practice with dobutamine with NORAD. So but that is because I know what I'm doing it, I can titrate it. But it's up to you what action you want and you choose. Even if you're using an adrenaline and if you're coming down on the dose and it is clinically perfusing well, you achieved what you want.
What is your take and experience of using noradrenaline in neonates?
I'm using it. In a neonate with septic shock, we use it. There is nothing you cannot use it.
Basically, inotropes, they don't have one answer. You have to understand the pathophysiologic state and accordingly take a decision. Only you should know what drug acts where and at what dose. That's what This is the final line.
Perhaps the most difficult Sita or Gita.
I would request Dr. Narendra.
Only one aspect of that NORAD and adrenaline, only that shock part, I took it. There may be another actions of these drugs. We cannot cover those only in 15 minutes. Only this only took it as in the shock part.
I would request Dr. Narendra to felicitate Dr. Parmanand Singh. I would request Dr. Dhananjay Sangare to please felicitate the chairperson. Yes. So we end here today's session. We'll be meeting at banquet and cultural events at 7. It is a cultural event by pediatrician for the pediatricians. Thank you.
Pleasure.